Thank you for joining us in this event despite the bad weather. I am Jeffrey Arboleda. I'll be your moderator for today. Before we begin the day's activity, let us all rise for the Philippine National Anthem to be followed by the invocation.
Heavenly Father, we come to you today with humble hearts, seeking your guidance and wisdom as we begin this program. Lord, we ask that you would bless every person who has gathered here today, and that you would be present with us in a special way. We pray that this program would be a time of learning, growth, and fellowship for all of us. Help us to listen to one another with open hearts and open minds, and to support one another as we strive to serve you in all that we do. Please give us the strength and the courage to follow your will and to use the gifts and talents you have given us to make a positive difference in the world. We pray all of this in your holy name. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
You may now be seated. The University of the Philippines, Philippine General Hospital, Department of Rehabilitation Medicine, the Disability First Foundation Incorporated, and the College of Medicine, Department of Anatomy present Muscle 2, Musculoskeletal Ultrasound Skills through Cadaver Learning 2, in partnership with JCS Pharmaceuticals, Cosmo Medical Supplies, VMed Medical Supplies, and Prime Medics. To officially open this event, may we all welcome our Department Chair and the Program Director for Muscle 2, Dr. Dorothy D. Chingbing Agsaway.
Good morning to everyone. A blessed day. We're so blessed that after 3 long days of typhoon, rains, and flood waters, we are now here. Okay? So, distinguished guests, colleagues, and pioneers in healing. Okay? Welcome to the second staging of the Musculoskeletal Ultrasound Skills through Cadaver Learning Enhancement, Muscle 2 for short. So, we are gathered here today, not simply marking a time as a profession, but we're marking a milestone. We are actively shaping the future of medicine and our profession. And you are the movers and shakers in the field where precision meets purpose. In this room are minds that will challenge boundaries, redefine standards, and drive the evolution of global health. So let's stand together, not only as clinician practitioners, but as architect of progress in our profession, and collaborate for a future. So with that, I hope that you will gain a lot of things during your 2-day stay here. And as we are as colleagues, we have to help each other and support each other. Thank you very much.
Thank you, Dr. Agzaway. Before we begin, please answer the pre-test using the QR code flashed on the screen. You can also find QR codes for the primer on the screen. Kindly download it for your reference. For those who have not yet registered, kindly register at our registration table located at the entrance and ensure that you have received your participant ID, food stub, and kits. For this morning, we will have a series of lectures from 8:30 a.m. to 1 p.m. with a short coffee break and lunch breaks in between. Questions will be entertained after each series of lectures during breaks. By 1:30 p.m. onwards, we will begin with a live model demo followed by hands-on scanning. So if you have taken the picture already, now to formally begin our program, let us welcome our first speaker for today. She is a diplomate and fellow of the Philippine Academy of Rehabilitation Medicine, a scholarship recipient from the Pain School International Comprehensive Education Program, Budapest, Hungary, a certified interventional pain sonologist, World Institute of Pain, a registered musculoskeletal sonographer, Alliance for Physician Certification and Advancement. She also had her post-residency training in musculoskeletal medicine and sonography, Pacific Central Coast Health Centers, California, USA. She is currently the team physician of FIBA Women's Asia Cup, an active consultant of the Medical City, Diliman Doctors Hospital, Medical Center Manila. Ladies and gentlemen, to talk on lumbar spine anatomy, let us give a warm welcome to Dr. Therese Dayan B. Estrada.
Morning to everyone, despite the rainy weather. Thank you for all for being here, and we pray for the safe arrival of those who are still on their way. It is my honor and privilege to start our day one lecture and workshop with my presentation on lumbar spine anatomy. I have no conflict of interest. I will first discuss the lumbosacral spine, the spine motion segment articulation, moving forward to its sonoanatomy correlates. Lastly, we will review the relevant spinal innervation and arterial anatomy. Okay. We start off at the mid-sagittal section of the lumbosacral spine. In this cryomicrotomb section, we see the vertebral body over here, the disc and its nuclear and annular components. The ventral epidural space is prominent at L5 and S1, which consists of vascular channels and fat. It is much smaller above L5 level around here. We see its correlates with T2 and T1 weighted images. The dorsal fat pads are seen as hyperintense signals, both on T2 and T1. They are more prominent at the upper lumbar levels and diminishes at the L4, L5 level. Moving laterally at the level of the foramen, we see here the ventral root and the much larger dorsal root. These are inseparable on the MRI. We often see linear structures within the neural foramen on the MRI, and those are always going to be veins. When we look at the radiograph laterally, we see the neural foramen very well delineated in the upper lumbar levels, because here the foramen is directed laterally. It is not well seen at the lumbosacral level around here, not because it's stenotic, but because the foramen is angled anteriorly and it's not parallel to the X-ray beam. Now in the coronal plane, if this is the L4 pedicle, then this would be the exiting L4 nerve root. Here we see the expansion of the dorsal root ganglion at the midsection of the pedicle. The traversing nerve root will exit under the next caudal level and usually affected by a disc herniation. And we see here correlates with the CT myelogram and MRI. Moving forward with the axial anatomy of L1 to L3, they are very similar to one another. The pedicle is directed at the sagittal plane over here. The surface of the vertebral body and the disc is directed with an orientation of convex anteriorly. Here we see the neural foramen, which is directed laterally. We see this We see these orientations very well, both in CT and MR. At the L4 level, we see a transition. Here we see the pedicle obliquely more oriented. We still see the posterior margin of the disc and the vertebral body to be convex anteriorly, and the foramen still directed laterally. And again, seen very well in CT and MR correlates. Now at the L5 level, we have a greater obliquity of the pedicle, and the foramen is directed anterolaterally. This is why we don't see it very well on the lateral radiograph. Now, we can note that the posterior margin of the disc and the end plates are normally convex posteriorly. We see again the same orientation very well, both in CT and MR. Now for the anatomy of the dorsal epidural space. It is important when we do interlaminar injections. We see the dorsal fat pads as hyperintense in T1, and at L3 and L4, shown in the dotted and solid lines respectively, seen centrally situated in the little triangle. If we go far to midline, we risk the penetration of the thecal sac. The situation is very different over here at the L5 level, when there's almost no dorsal fat in the midline. There's ample fat laterally, and this invites a lateral parasagittal approach, which can be helpful when we treat L5 foraminal stenosis. Moving forward to the spine motion segment articulation, we have the discovertebral complex. The nucleus consists of living chondrocytes, proteoglycans bound water, and collagen, and is encased in a collagen capsule that extends from the fibrous annulus and is contiguous with the cartilaginous end plate. The well-hydrated disc, or the nucleus, rather, absorbs axial load and disperses radially and is constrained by the fibrous annulus. As a reminder, the L1 to L4 posterior surface of the disc and vertebral body are seen normally as convex anteriorly. This is in contrast to the L5 posterior surface of the vertebral body, which is seen normally to be convex posteriorly. Here we see nicely hydrated discs in an adolescent, but we are always going to see some normal loss of this hydration starting at age 21. Now, moving forward, the facet joints. These are the posterior articulation of the lumbar spine. Here at the axial image over here, we see that the superior articular process is more anterior and the inferior articular process is posterior. It is a curved joint. We see it in this patient with a direct AP and 45-degree oblique view. Hence, we see it in a 45-degree arc of motion. And we will be able to access the facet joint only in the direct posterior vector. Moving forward, the ligaments. Anteriorly, we have the anterior longitudinal ligament. The disc is a modified ligament. And posteriorly, we have the posterior longitudinal ligament. The posterior ligamental complex comprises of the following: the ligamentum flavum, facet joint capsule, interspinous and supraspinous ligament. Here is another nice schematic diagram of the supraspinous and interspinous ligament that act to resist extreme motion of the spinous process and also protects the facets and disc. Additionally, here we see the iliolumbar ligament originating from the transverse process of L5 and inserts to the iliac crest. And that being said, it prevents anterolisthesis of L5 on the sacrum. These ligaments play an important role in balancing tension and compression of the lumbar spine. We live in a world of idealized anatomy where we have 24 vertebral segments, but this only pertains to about 92% of the time. Seven cervical vertebra is constant, but about 10% will have anomalous number or distribution of thoracolumbar segments. and 15% will have transitional anatomy at the LS junction. The presence of a transitional lumbar segment strongly correlates with an anomalous number of vertebral segments, and this results to alteration in radicular pain patterns. Ideally, we should count from skull base, but we can use the CT junction or the cervicothoracic junction as a practical alternative. And we use the landmark of the first upslope transverse process of T1, shown in this line. So how do we correlate all of these and visualize systematically under the ultrasound? To start with the basic ultrasound scanning sequence of the lumbar spine, we have to master 5 views, as shown here. Ideally, we use a curved transducer with a low frequency of about 2 to 5 megahertz because of the depth of the structures of the lumbar spine. Now we start with the transverse spinous process view with the transducer directly over the lumbar spinous process. We note the large acoustic shadow casted by the spinous process and lamina that completely obscures the spinal canal. Next, we have the transverse interspinous or interlaminar view, which is the home base image of most of our lumbar spine procedures, namely our lumbar medial branch and lumbar facet joint block. At the right image over here, we are able to insonate through the interspinous space. We see the hyperechoic reflections of the epidural space, the posterior dura, and the anterior complex in the midline. And laterally, we see over here the articular processes. On sagittal scanning, we start usually paramedian oblique over the lamina because the median sagittal view is too superficial, casting a large anechoic shadow. We note here the hypoechoic space of the epidural area between the ligamentum flavum and the posterior dura. The intrathecal space is between the posterior dura and the anterior complex. We see hyperechoic reflections over here, which are casted from the intervertebral disc. The lamina at this view are typically seen to show a horsehead sign. The next sagittal image is the paramedian sagittal articular process view. Since this is an articulation of the inferior articular process of the vertebral body above and the superior articular process of the vertebral body below, we don't see a gap in between. We see the erector spinae muscle overlying above, and typically, this shows a camel hump-like appearance of the articular processes. The last view is the paramedian sagittal transverse process view. We note here the hyperechoic reflections casted by the transverse processes that produce the so-called trident sign. The psoas major muscle is seen within the acoustic window between the transverse processes, and it's recognized by its hypoechoic and striated appearance. The lumbar plexus is situated over here in the posterior part of the psoas muscle, and there are hyperechoic longitudinal striations within the substance of the muscle that may represent as intramuscular tendons, and this should not be confused with the lumbar plexus, which is more situated above. The retroperitoneal space is deeply situated below the mentioned structures. As we draw closer to the end of my presentation, I will discuss briefly the spinal innervation. We see the ventral ramus here. The sinovertebral nerve innervates the ventral epidural space, the ventral dura, the posterior aspect of the disc. It comes around the lateral margin of the vertebral body as gray rami communicans, and it synapses with a sympathetic ganglion. The much smaller dorsal ramus turns posteriorly over here. We see the innervation from the medial branch, which takes care of the facet joint and the multifidus muscle. the intermediate branch for the longissimus muscle, and lateral branch, lastly, for the iliocostalis muscle. For the facet joint, each facet joint is dually innervated or has a dual innervation. For example, the L4 and L5 facet joint is innervated by the medial branch coming from L3 medial branch and L4 medial branch. This comes into play when we do a medial branch block where we target the same level of the affected joint and the level above. How does it look like anatomically or in a cadaveric specimen? Here we see the expansion of the facet joints. This is the mammilloaccessory ligament. The medial branch of the dorsal ramus goes underneath the ligament. At the enlarged view on the right, we see a tiny articular branch of the medial branch coming from the dorsal ramus over here. And at the cross-sectional image below, we are looking at the junction of the superior articular process and transverse process. And this is the site where we do our medial branch blocks. It is important to note that the L5 dorsal ramus differs from the other lumbar dorsal rami because it runs at the junction of the sacral ala and the superior articular process of S1. It only gives off a medial branch as it only reaches the caudal aspect of L5 and S1 facet joint. Finally, with the arterial anatomy of the spinal cord, why is it important? We have had catastrophic complications from interventional spine procedures. We now understand that it is most probably due to the embolization of the anterior spinal artery, probably from a particulate steroid injection, and likely due to the involvement of the artery of Adamkiewicz. This is the primary blood supply of the anterior spinal artery of the low thoracic level. The artery of Adamkiewicz arises from the left-sided intercostal or lumbar artery, and this results to a tiny radicular artery which may communicate with the anterior spinal artery at all lumbar levels. Finally, some take-home points. As pain management physicians, our diagnostic accuracy and interventional precision rely heavily on our understanding of the lumbar spine anatomy. We should always know variability of lumbar enumeration. And lastly, examine your patients very well and review all relevant imaging prior to intervention to plan the best and safest effective procedural approaches. And with that, thank you very much.
Thank you, Dr. Estrada, for that comprehensive lecture in lumbosacral spine anatomy. You may ask your questions after the third lecture. For our second lecture, I am honored to introduce to you one of our esteemed consultants. She is a diplomate and fellow of the Philippine Academy of Rehabilitation Medicine, an associate professor 7 of the UP College of Medicine, vice chair for undergraduate training, UP-PGH Department of Rehabilitation Medicine, member of the Philippine Society for Ultrasound in Musculoskeletal Medicine, international scholar and corresponding member of the American Academy of Cerebral Palsy and Developmental Medicine, consultant of the UP-PGH Providence Hospital, Jackson's Medical Center, to give us a lecture on posterior hip and pelvis anatomy. Please help me welcome Dr. Mona Lisa Limdungka.
Pardon the technical issues. Again, thank you so much for coming over and joining us this very rainy morning. I was tasked to go through the posterior hip anatomy, particularly for this session, because it is a common differential when we talk of low back pain. Now, where is it really coming from? But unfortunately, the hip is quite challenging. It's not one of the most common joints that we do scan. And if we do, it is not usually the posterior. More often than not, we do a lot more anterior scanning. And posterior hip evaluation is not a usual part of the protocol unless the patient's actually very symptomatic. So it is often guided by the patient's symptoms rather than having a standardized scanning regimen. But it is important because it does contribute to pain and may be an important differential for our sessions today. So these are my objectives. I was tasked to go through the following that might help us in our scanning for the posterior hip. But just to make it a little bit easier, we'll try to concentrate on these structures in order for us to be a little more directed, no? Because there's so many things to see. So let's start off with the bony landmarks. Always, this is our angor. We start with the dorsal iliac crest. So things that we, if you can't see it, palpate it. And so the bony landmarks are quite helpful, especially if we are not frequently doing this region. Next would be the posterior superior iliac spine, the posterior inferior iliac spine, because these would be landmarks for other structures that we would need to do. And of course, very important is the SI joint. The sacral foramina is important. This is particularly true for injections as the areas we should try not to be careful with. And of course, the greater sciatic notch, and the ischial tuberosity. One other area not mentioned here is the ischial spine, and we have it around here. So let's start with the sacroiliac joint. It's a diarthrodial joint, and its sacral surface, it's composed of the sacrum and the ilium. And the sacral surface is hyaline cartilage, while fibrocartilage lines the iliac surface. So there is a variation in terms of its depth. Generally, when we scan, we either start midline and go at the level of the superior iliac spine and go slightly distal. And so one important thing that we need to do is try to identify your sacroiliac joint. The superior aspect of the SI joint, as is seen here, is a little bit more shallow. And I'll go into the inferior aspect later as a point of comparison. But the arrow also points to the sacral foramina, which is a spot that we must be careful with and is very easy to confuse with your SI joint. In comparison, the inferior aspect of the SI joint, as shown here, is seen deeper based on our scans. No? It's a little bit, the slope is a little bit deeper, and again, the foramina on the right side of our screen or picture, as it is correlated with our anatomical picture, is something that we must be aware of. So I think a lot of us are going to be interested with the posterior hip muscles, and there are quite a few that we need to tackle. So there are the muscles in the gluteal area. I will go through the more relevantly affected muscles, and there are also going to be the proximal insertions of the hamstrings, which may contribute as well to pain in that region. So let's start off with your glute max. It's very hard to miss, unless you have thunder thighs and thunder buttocks like me. But it is the largest and most superficial posterior hip muscles, a primary hip extensor and external rotator with innervation of your inferior gluteal nerve. So seen here is its posterior origin at the dorsal ilium, sacrum, and lumbar fascia, and sacrotuberous ligament, as well as the insertion to the TFL. And putting that in, it blends into the ITB at the gluteal tuberosity of the femur. So cutting that away will reveal the gluteus medius. So here it is, and maybe just to illustrate it a little bit further, it is outlined here, and the structure underneath it would be your gluteus minimus. So going back to the gluteus medius, it is a hip abductor internal rotator with the superior gluteal nerve as its innervation. Its origin is at the dorsal ilium between the posterior and anterior gluteal lines, and its insertion is at the lateral surface of the greater trochanter. So just to highlight it, this is how it looks in full view. So interesting to note is that when we do scan around the hip, probe being placed in this manner, then we can see the glutei muscles here in this area. So superiorly would be your max, and inferiorly at this level would be your medius, gluteus medius. Since we are at this area, another nerve that I was tasked to go into were the cluneal nerves. They are sensory cutaneous nerves, located at the lower back and can be a common source of pain in the buttocks and in the back area, particularly when they are entrapped. They are hard to see in all reality. No? They're very small, but certain landmarks may be used. There are three main divisions that we are interested to see. Of great interest to us is actually going to be superior cluneal nerves, the particular division. But nice to know would be your medial cluneal nerves as well, and your inferior cluneal nerves. Okay, so here they are, and your superior cluneal nerves originate from the lower thoracic and lumbar nerve roots and travel towards the iliac crest. So that's a point of interest. The medial set will originate from the sacral nerve of roots S1 to 4 and lie beneath the long posterior sacroiliac ligament. So if you were to scan at the level of the iliac crest, this being the iliac crest here, schematically, they're very hard to distinguish unless your probe is very high in terms of its frequency. So this is the schematic of where likely the cluneal nerves would be. Really, one good indicator always is to ask the patient, where is it most painful? And if it more or less hits the same area, it is one structure that you may want to keep in the back of your head. So the piriformis is probably the star muscle in this area. It is a deep external rotator of the hip, and it also abducts the hip, does horizontal abduction when the hip is in flexion. It is innervated by branches of L5, S1, and S2, with its origin from the anterior sacrum, and it inserts at the superior border of the greater trochanter, so seen here. So going a little bit more deeply into the piriformis, important to note, especially when we scan, is remember the sacral foramen that we had mentioned earlier. Your piriformis exits, so excuse me, most of its belly exits at the level of your sacral foramen, and it is intimately related with the sciatic nerve. That is why it is the star muscle of this region. The sciatic nerve normally exits below, such as shown here, and the reality is we're not all made the same, and so there are variations to how your sciatic nerve exits. In about 14 to 17%, depending on your reference, there is a subtype that actually runs through the piriformis, which increases its propensity for an entrapment or pain in that area. So something to take note of as well. So again, relative to the piriformis would be another set of nerves that maybe you just want to remember. The superior gluteal nerves, shown by the arrow, also runs within the periphery or adjacent to your piriformis. And also your inferior gluteal nerves here at this level. So again, things that you may want to consider. So it starts at the SI joint. When we try to scan it, we normally look for the SI joint that was shown earlier. And as we move down towards the sciatic notch, remember that the probe initially was placed in a short axis view. We need to angle the probe towards, diagonally towards the greater trochanter. And so we try to externally rotate the femur in order to maximally expose the piriformis. So here, what we see would be the belly of the piriformis here at the ilium in relation to the structures here, no? And this is your greater trochanter related here. So this would be the tendinous attachment, and this would be the belly. And as you externally rotate, you look at the quality of the belly or the tendon sliding in and out. Okay? But there are other deep external rotators, and I will go through them quickly. The gemelli, or the gemellus superior, there are two here. This is your superior. I'll go into the inferior later. There are external rotators of the hip, innervated by your obturator internus nerve, origin at your ischial spine, and inserts at the greater trochanter, and the tendon of the obturator internus. So the superior is shown here in better view, all by itself, so that we can isolate it. As compared to the inferior, again, relative to each other, in relationship to each other, this is your inferior. It is bounded in between here by your other muscles. And so what's important to remember is that our next set of muscles, which is your obturator internus, bounds the two gemelli. So the obturator internus is also a deep external rotator, and it's innervated by the nerve to the obturator internus, L5S1. And it originates at the obturator membrane and adjacent bony structures and inserts also at the greater trochanter. So these are the small deep rotators of the hip underneath or inferior to the piriformis. Deeper to that would be the obturator externus, as just to reference. No? So if you were to cut it out, then it's the deeper muscle below. However, when one important muscle that we should also consider is your quadratus femoris. So as we go more inferiorly, it is an external rotator of the hip, but it adducts the thigh, innervated by the nerve to the quadratus femoris and inferior gemellus, with its origin at the anterior border of the obturator ring. So it's relatively inferior, and it inserts into the intertrochanteric crest of the posterior medial femur. So from a practical standpoint, the other thing that we need to remember is all of these small external or deep external rotators at some point are going to be related to the sciatic nerve, as well as the other nerve that we have here, which is your posterior femoral cutaneous nerve. So that would be one of the structures that we probably would need to take a look at. So if we're going to start, let's start from the bottom and try to visualize the quadratus femoris. We use the gluteal fold as a reference, as is shown in our model here. And it would more or less anatomically look at this particular area. So looking at the structures that we will encompass, sonographically, this is how we would probably visualize it. So this would be your ischial tuberosity. And this one would be your quadratus femoris. And the sciatic nerve is located right on top of it. So the gemelli and the obturator, you can go a little bit more superiorly. It is very difficult to actually distinguish individual muscles, although we can try if you'd want to do it in short axis view. But if you were to scan it in this manner from the gluteal fold, we go a little bit more caudally or superiorly, then this is what we would see. No? So here is this is going to be your obturator internus admixed with small parts of your gemelli. No? It's, in this particular view, when you look at the muscles in longitudinal axis, they're a little bit more difficult to differentiate. And again, sitting on top of it, would be your sciatic nerve, okay? So going now, let's go a little bit more inferior. We go through the posterior proximal thigh muscles. This is going to be important at its insertion to the ischial tuberosity. So going through the muscles, the biceps femoris, we have two heads. So it can unilaterally extend and externally rotate the hip and flex at the knee, and bilaterally, it does have an action towards the posterior pelvic tilt. It is innervated by the tibial branch of the sciatic nerve. And here we have the long head, which originates from the ischial tuberosity, shown here, with the conjoint tendon of the as a conjoint tendon with the semitendinosus. To differentiate that with your short head, this one is going to originate from the lateral linea aspera, and they will insert both at the head of the fibula. So the other hamstrings, as we had already mentioned, would be the semitendinosus. So bilaterally, it does have an action towards your pelvic tilt. Unilaterally, it hip extends the hip and flexes and internally rotates the knee. So what is important is there is a conjoint tendon that joins the long head of the biceps as well as your semitendinosus at the ischial tuberosity, inserting at the medial aspect of the tibia distally. Okay. Now, the third muscle, of course, is the semimembranosus. So actions, posterior pelvic tilt, bilaterally if they contract, unilaterally hip extensor and hip extension. So its innervation is the sciatic nerve. So important to note here is that its origin is the superolateral ischial tuberosity. And it inserts medially from that area, goes medially, and inserts at the posterior aspect of the tibia and medially. So the important, and why do we need to go into this in detail, the importance is the relationship of the three muscles as we go from its proximal to its distal path. No? So if we look here, generally speaking, there is going to be a little shift. No? It is not in the scope of this morning's lecture to go all the way down to the mid-thigh and knee. Let's just try to concentrate in the proximal aspect, but we will see it here. The semimembranosus tendon and aponeurosis is relatively deep to the semitendinosus. And yes, the reason why we call it semimem is because it's medially oriented. However, as it goes more proximally, its insertion relative to the conjoint tendon is a little bit more lateral. And so from that perspective, that might have a bearing when we view. And then in reference, the sciatic nerve is even more lateral. So it is supposed to form a triangle with the sciatic nerve laterally oriented, semimembranosus medial, a little bit more distal, and the conjoint biceps femoris and semitendinosus as its apex. So let me try to illustrate that in greater detail. So looking at it, if we were to look at it just proximal at this point, that description at the level or just slightly below the gluteal fold, this is the relationship that we will see. So the semimembranosus here, and here, the triangle that was mentioned, the semimembranosus, shown here posteriorly, not too well seen. And here, what you see is superiorly would be the beginning conjoint relationship of your biceps femoris and semitendinosus. Sciatic nerve located laterally as is shown in our schematic diagram. Now, relative to that, if we go a little bit more proximal, now at the level of the gluteal fold and at the ischial tuberosity, we go a little bit higher. When we see the ischial tuberosity at this level, so ischial tuberosity, the conjoint tendon is seen here more superficially, and the shift of the semimembranosus begins. It goes now more laterally. Okay? So, and as you go even higher, no, sorry. And in comparison, when you go distally, you go back to that relationship of your semimem, semiten, semimem medially, semiten on top, as is shown here, the biceps. The sciatic nerve would be somewhere here, as is shown in our image. And note, going down more distally at this level, then you see the raphe of your semitendinosus as your landmark. So, looking at it from a longitudinal axis, if we go right above it, okay, if we target the conjoint tendon of the biceps femoris and the semitendinosus, this is how it would look over your gluteal folds. It's likely if you're over the ischial tuberosity, this is probably what you will be able to scan. It is very difficult to see all of these three together. There's only a small window. And here, if you go a little bit more laterally and superiorly, just slightly, likely at this point, that is where you will see your semimembranosus appearing, okay? Because they're not completely in the same parallel plane. Now, laterally, as you proceed even more, then the sciatic nerve might come into view. So again, let us keep that in mind so we do not mistake one from the other. Or if we are not sure, then we can always look at it in short axis to reconfirm. Okay. So ligaments of the posterior hip, I was tasked to go through the following in relationship to, I guess, this is because of the relationship to the pudendal nerve. So let's start. This was partially mentioned in the earlier lecture by Dr. TD. Sacrotuberous ligament, we have a strong fan-like ligament here coming in from the posterior superior iliac spine and lateral aspects of the sacrum and coccyx, inserting into the ischial tuberosity. So we are looking at it from the person standing up. If we look at the patient on prone or the person on prone, this is how we would probably look at it. So if you're going to orient your scanning, this is how it would probably be oriented. So it's a key stabilizer of the sacroiliac joint, preventing excessive movement and rotation of the sacrum to control sacral forward tilting, to resist twisting and side bending excessively. So as we scan here, see we scan proximal, again the bony landmark, ischial tuberosity, go more caudal or more proximal. And so what we would likely see would be this ligamentous structure. Ligaments as have their characteristic fibrillar pattern, which we can look for. In relation to that, another important ligament is your sacrospinous ligament. So in relation, this is your sacrotuberous, sacrospinous. It plays a crucial role in stabilizing the pelvis and preventing forward tilt as well. And your sacrospinous ligament is situated deep. So it's much deeper than the sacrotuberous ligament. And it attaches at the outer edge of the sacrum and coccyx and to the ischial spine, as well as a bony projection on the ischium, the pelvis. So maybe to get a better orientation, if you look at it anteriorly, this is how deep your sacrospinous ligament is. Important to remember for this particular ligament is it is a border for the greater and lesser sciatic foramen. And Dr. TD has always reminded us very well on that one. So it acts as a border for the greater and lesser foramen. And it helps in terms of the pathway of the superior gluteal nerves, as well as the posterior femoral cutaneous nerves when they exit. So if you were to take a look at it from a scanning view, remember that the piriformis would likely be on top of it in terms of its relationship, and the fibrillar structure underneath would be that ligament. So it's important to also remember how the nerves are in relationship to these particular ligaments. So as going back, if we compare without the nerves and as the nerves exit, so the greater sciatic foramina is our point of interest. But one particular, along with that, would be the smaller nerves other than the sciatic nerve, would be your nerves related to this would be that of your posterior femoral cutaneous nerve exiting down. So it's actually this very small nerve here. Maybe just to give you a better view, this is the nerve in question. So again, something to think about. And here, the other thing that we'd like to show here would be the different nerves, your inferior gluteal nerve, as well as that of your superior gluteal nerve, which we mentioned earlier. Now, an additional nerve that we need to be aware of would be the pudendal nerve. Okay? It is here at the lesser sciatic foramina that we probably might have problems as the pudendal nerve exits. It is adjacent to the sacrospinous and the sacrotuberous ligament at this point, and may be a cause of entrapment, and may be an area to evaluate in terms of pain. So if we were to look at it in terms of its relationship at this point, here we have your sacrospinous ligament, your sacrotuberous ligament, and here in between, so ischial spine, would be where your pudendal nerve may likely have issues in terms of entrapment. This was already mentioned earlier, your iliolumbar ligament. It's a strong ligament that has a crucial role in stabilizing the lumbosacral junction, connecting the transverse process of the fifth lumbar vertebra to the iliac crest. So just again to orient you, it does have its superior and an inferior part. Shown here, it's probably best seen anteriorly. So important here is to visualize it in certain areas that you may have pain. Okay, so what we see here would be your iliac crest, that the probe is placed, the border of the iliac crest here, and the ligament is seen here. So as I wind up this particular review, we were tasked to go through these structures relative to its value for the scanning of today's event. I hope we were able to review that. But suffice it to say, these are not the only structures of the hip. There are a lot more, and probably these are things that are good to review, particularly for the anterolateral segment. So thank you so much. These are my references, and thank you for your time.
Thank you, Dr. Lim Dungka, for that posterior hip and pelvis review. Now that we have reviewed the pertinent anatomy of the lumbar spine, hip, and pelvis, let us now move on to the imaging correlation of the said structures. To give a recorded talk on the MRI of the lumbosacral spine and clinical correlation, let me introduce to you our next expert. He is a fellow of the Philippine Orthopedic Association, an associate professor of the UP College of Medicine, an executive committee member of Asia Pacific Orthopedic Association Spine Section, head of the Community Development, AO Spine, country leader of AO Spine, and educational head, Philippine Spine Society from 1995 to 2019. He's also a consultant of the UPPGH, Manila Doctors Hospital, and St. Luke's Medical Center, BGC. Let us give a warm round of applause to Dr. Jose Manuel Ignacio.
And I was requested to give some pointers on how to understand the MRI of the lumbosacral spine better, and I felt it best to do this with some clinical correlation. I have nothing to disclose, just a brief outline of how to understand MRIs. First of all, we have to look at the value of X-rays. Then we'll talk about the basics of plain MRI, the different image sequences. Now we'd like to know how to determine if a compression fracture is chronic or acute. When is contrast useful? We'll talk about spinal stenosis and the different types. We'll talk about disc herniations. Now, what is the difference between disc degeneration and degenerative disc disease? We shall be talking about spinal instability, and we'll look at other causes of radiculopathy. We'll touch briefly on disc infections and what this Tarlov is all about. Now, MRI is not always better than X-rays. Many times we get patients giving us their MRIs and expecting us to understand everything about their back pain. But there are things better seen on X-ray than MRI, and I tell them that. Just to give an example, this is a standing X-ray, and this is an MRI. In the standing X-ray, you see a listhesis of a grade 1 at L4, L5. When you look at the MRI, it's actually reduced. So what does this mean? It means that this is an unstable spine because X-ray is a weight-bearing X-ray, and when they go supine for the MRI, it reduces. And when I see this, I look at the facet joints, and over here we can see there is synovial effusion in that area. So that indicates instability in the region. Now, what are the different sequences on MRI? Well, we have the T1, T2, and the steer images as the basic ones, and I'm sure you know all about this, but that the T1 highlights fat better, but do not expect the highlight to be as bright as what you see in the CSF. What you do see is it's slightly brighter where you have more neural elements because they are lipid rich, and so the spinal cord is brighter, a little bit brighter. And if you look at the vertebral bodies, since there is marrow there, it also lights up a little bit, but not like the fluid and T2 images. And it is always best to compare them with T1 image and T2. Always look at them and compare them. Now, when you get abnormal signals like this, you would like to know if this is probably an infection, malignancy, or due to trauma. Well, is this probably just a hemangioma? Well, if you do put contrast in this area, contrast in this patient, what you see is that it lights up, and this will indicate that it's more than just a simple hypervascular area. This is actually a case of a hepatic CA with metastases. So contrast enhancement can help delineate these things. Now, T2 and STEER images both highlight edema or water. However, STIR is even more sensitive. It suppresses the fat. It's a fat suppressed and image, and it highlights water. So in cases like this, for instance, where you have multiple compression deformities, you do not know which one is actually an acute fracture. If you look at the STIR image, you see that it's actually this vertebral body which has an acute fracture. So you say, why do I still need to do the MRI if it's obvious that I have a compression deformity here, and that's the only one we see, and the patient has back pain in that region? So can I not just do my kyphoplasty, for instance, based on this X-ray? That will be dangerous because, as you can see here, the compressed vertebra was actually an old fracture, and this is seen on STIR. It did not light up. Actually, it is the level above which lit up. It just didn't have time to collapse yet. So MRI has use in these cases. Now, MRI is also helpful in trying to see if you have retropulsion into the canal by the fractured vertebra. Now, compression fractures, the osteoporotic type will heal. Most of the time, it will heal. As what you can see here, in 2 months, you have concertina collapse. It's a pancake of the vertebral body has collapsed significantly. And at 5 months, you can see that the body has tried to stabilize the area. You see syndesmophytes forming. Now, to know if it's acute or not, you have the STEER sequences, as we mentioned earlier. Now, in other cases, if you see things like this, you see multiple punched out lesions, you see collapse here and there. In these cases, the pattern of involvement does not point to osteoporotic fractures only. This is actually indicative of metastatic lesions, and most of the time, if you look at the X-rays, the pedicles, which you see clearly on other areas, are ill-defined in these cases. Now, what if you see gas on X-rays, on CAT scan, and fluid? This is a T2 image. You see fluid in the vertebral body. This may indicate that this fracture is going into non-union, and this is indicative of a vascular necrosis of that vertebral body, and this is known as Comel's disease. Now let's talk about spinal stenosis. Over here you see a stenotic segment. Spinal stenosis can be central, can be foraminal. If you look here, these are the nerve roots foramen. The foraminal volume is best seen on the parasagittal cuts here. The gray areas here, that is the nerve root exiting, and it has spinal fluid around it, because the nerve root, as it exits, it brings with it a short piece of the dura, and inside that dura is fluid. So over here you see that the nerve root is being compressed severely on both sides. So this is a central stenosis, this is a subarticular stenosis, and foraminal stenosis. And again, you see the facet synovitis in this area. So here you have, for instance, on this side, you have stenosis under the facet joint, and that is what we call subarticular stenosis. Now let's talk about disc herniations. Disc herniations will depend on where it is. It can be central, can be paracentral or one-sided like ref or right-sided. It can be foraminal and in the foramen area, or it can be extraforaminal. So this is an example of a paracentral disc herniation. It is on one side. This will be labeled as a left-sided paracentral disc protrusion. Now, you can have the herniation or protrusion underneath the facet joint, and this is called the lateral recess or subarticular herniation. And if you look here, this is, for instance, the L4 vertebral body, the L5 vertebral body. The L4 nerve root hugs the pedicle and goes out in this area. So this is, if you have an L4, L5 level, the exiting nerve root is the L4 nerve root, and the L5 nerve root traverses the disc and exits in the L5, below the L5 pedicle. So if you have the subarticular or the one-sided herniation, the most common type, it will affect the traversing root. If you have a far lateral herniation, this will cause symptoms in the exiting nerve root. So if you have a central herniation, then that may not have reticular patterns to the pain. This is an example of a protruded disc on coronal cuts. So what's the difference between a disc protrusion and an extruded disc? You look at the base, the size of the base and the height of the herniation. Or if you have a wider base and a shorter height of the protrusion, this is called a protruded disc. However, if the base is shorter than the height, as what we will see later on, that will be an extruded disc. So this is a protruded disc over here. This is an extruded disc. So the base is shorter than the height. The height is longer over here. So this is a down-migrated extruded disc since it goes caudally. This, on the other hand, if you look at the cuts, you see that this is a cut passing through the disc. It has the same color as the disc. It is dark, and these ones are the same color as a vertebral body. So this is the disc level, and you still see proximal to that part of the extruded disc. So this is an up-migrated disc extrusion. So what about extraforaminal or far lateral herniated disc? So here it pinches the exiting nerve root. So it is a foraminal or far lateral protrusion or herniation. And if you look at the parasagittal cuts, you see that the nerve is being pinched as it exits. Now, I just want to share some facts about extruded disc. Extruded disc and sequestered disc are very, very painful, because what happens is when the disc gets torn, the annulus gets torn, the nucleus pulposus goes out and goes to the epidural space. And nuclear material in the epidural space is foreign body. So what the body tries to do is it creates a hyperinflammatory response in that area. So it's very, very painful. But it is the same hyperinflammatory response which will make the body able to lyse that extruded disc. So later on, when you take a repeat MRI, you see that the disc has regressed. And this patient, actually, by the time I saw the patient was already advised surgery because of the severity of the pain. By the time the patient consulted my clinic, the pain was improving already. So we sat tight and managed conservatively with rehab, then with pain meds, and patient did improve. So now, what are the other causes of radiculopathy? Over here is a facet capsular cyst, facet joint cyst. This is similar to a ganglion cyst in your wrist, but it actually is in a very, very small space going into the spinal canal and compressing the nerve as it exits. So this is another cause for radicular symptoms. Let's talk about back pain. when you have a patient seated in front of you, he will point to his back and say, my back is painful. Of course, everyone will point to their back. What I do is I ask them to stand up, turn around, and tell me where exactly is the pain. Is it midline? Most of the time they will say, actually it's one-sided, paralumbar one-sided, and the gluteal. Or is it a radiating pain or a full sciatica? So I ask the patient to always point to me where the pain is. Now, what's the difference between disc degeneration and degenerative disc disease? Well, if you see a patient with a dark disc, everything else is okay, but there's a dark disc, you might have a high intensity zone, what we call an annular tear, and the patient has no pain, then this is just disc degeneration on MRI. However, if the same patient is complaining of back pain, then it becomes a disease. So it is now a degenerative disc disease. So this is a 38-year-old male with atrial back pain, no radiculopathy, and the patient is a cook, and he says, I'm about to be kicked out of work because he couldn't stand working in the kitchen for so long. Every so many hours, he has to lie down on the table. So when the boss saw him, he said, they're going to have to let him go. So the patient asked to have surgery. I don't usually advise surgery in young patients with degenerative disc disease because the results are not very predictable. But the patient said his job is on the line. So we did a discogram. You can read on what a discogram is, but what the discogram pointed to the L5S1 nerve root disc as being the culprit. So we did fusion in that area, and the patient was still able to go back to work despite some residual symptoms. And this is another fairly young patient, 42-year-old male with atrial low back pain. Again, you see only one disc involved. Doing discography, we saw that it is the same area which is desiccated, which is degenerated. So that patient also had a fusion. And the patient did improve. Now, what are modic changes? You read about this in the MRI readings. Well, modic changes are, you need to compare T1 and T2 image, T1 and T2. So a modic type 1 change, the end plates at T1 and T2. In T1, it is dark. In T2, it is bright, as what you see here. In modic type 2, both are bright. T1 image and T2 image, the end plates are brighter. Modic type 3, they're both dark. And there's some controversy about the clinical correlation of this modic change, but just so that you know when you read it, it has something to do with this one. Now, there was a study which showed that it is not really the type of the modic change, but the grade. Is it just at the end plate? Does it go to about a fourth of the vertebral body? Does it go beyond half of the vertebral body? And they say that these are the ones which may not do very well when operated on. But it is not, again, there's still some controversy here. Now let's look at spinal instability. When you get patients with, like this one, a grade 1 spondylolisthesis, you can do flexion extension x-rays and see if there is reduction. Over here, there's some reduction in the listhesis, so this is an unstable segment. And if you look closely, because of the listhesis, you have foraminal stenosis as well. And if you look at the facet joints, you see synovitis. You could also see part of that in the lateral sagittal MRI. So this was an unstable spine, did not respond to conservative treatment. So this patient had surgery, tried to reduce, we fused the spine, and the patient had some improvement. Now, spondylodiscitis infections, how do we know if there is an infection? Well, there's a patient with, it's a fairly young patient, 40s or late 40s, early 50s, with a severe decrease in the disc height. And when we took the MRI, you see a big extruded disc, but the pain was out of proportion to what we see in this MRI. The pain was so severe, patient could hardly walk. Patient had some fever every now and then. when we placed contrast, we could see that this is not just an extruded disc or protruded disc, but actually a disc infection. So the patient had debridement of that disc and prolonged antibiotics. This is another one, severe patient with severe back pain. This patient had end-stage renal disease, having dialysis 3 times a week, and diabetic, immunocompromised. So many of my patients with discitis in the lumbar spine actually are undergoing dialysis. So you can have bacteremia from all that, and eventually you can have an infection. And this was a spondylodiscitis. And the MRI again shows, if you look at the end plates, are very, very irregular. The disc is very destroyed. So that patient had antibiotics treatment. The patient was not a good candidate for surgery. The patient did improve. Now, when you look at Pott's disease, look at the paraspinal region, the psoas area. You can see here that there is an abscess. You don't usually see an abscess this big in bacterial infections, but over here you see it, and this is more indicative of Pott's disease. So Pott's disease versus bacterial. Pott's disease runs an indolent course. So because of slow progressing symptoms, they usually come to you with neurologic deficits already or a deformity. However, bacterial infections, pain is so severe, and they consult with you much earlier. So that is a difference clinically. Now, what is a Tarlov cyst? Tarlov cyst is a meningeal cyst, basically. What you see is CSF, and it is rarely the cause of your patient's symptoms. And rarely do you need to do surgery on this one. Most of the time, it is just an incidental finding. So in summary, X-rays are still important in understanding your patient. STEER sequences can help determine if a fracture is acute. Contrast enhancement helps to delineate suspected infections or metastatic lesions. Spinal stenosis depends on the area. Is it central, lateral recess, or extraforaminal? Disc herniations will depend on the location and will dictate which nerve root will be affected. Protruded and extruded disc will depend on the height and the base of the disc which is involved, the disc which has come out of the confines. The extruded disc may regress. We have to know how to identify axial low back pain. This may, however, also have radicular components. There is a difference between disc degeneration and degenerative disc disease. Modic changes are MRI descriptions of this end plate degeneration. Spinal instability can be determined by dynamic views. Spine infection, pay attention also to the clinical course of your patients. Contrast will help. Look for psoas abscess in what you will see in Pott's disease. Tarlov cysts are usually asymptomatic and are usually just an incidental finding. Thank you very much for your attention. Good day to all.
Ignacio, for your excellent lecture on MRI of the lumbosacral spine and clinical correlation. So at this point, we can entertain 1 to 2 questions for Drs. Estrada and Limdunca. For Dr. Ignacio, you may send us your questions and we will forward them to him. Anyone? Do we have any questions from the audience? If none, you may now have a quick coffee break. So we have a complimentary Figaro booth outside. But please be back after 15 minutes. So that's 10:15. Thank you. We will be resuming in 1 minute. For those who have not yet scanned the pre-test and primer, the QR codes are available on the screen. Again, we would like to thank our industry partners, JCS Pharmaceutical, Cosmo Medical, VMed Medical Supplies, and Prime Medics. please settle down. We will be starting our second segment. Okay, welcome back to our morning segment. To kick off our second segment for this morning, we talk about the imaging of the pelvis and clinical correlation. May we welcome back on stage our first speaker, Dr. Therese Dayan B. Estrada.
Good morning. For the second part of my lecture, I was tasked to discuss pelvic imaging and clinical correlation. So, why is it so challenging to treat pelvic pain? The truth is, it has a broad differential diagnosis. You can think of gynecological conditions like endometriosis, different urologic conditions. We talk about interstitial cystitis, irritable bowel syndrome. But the focus of my talk will be more on the musculoskeletal and neuropathic causes of pelvic pain. We will go over these common musculoskeletal and neuropathic conditions involved in pelvic pain, highlighting also the role of imaging in diagnosing and management of these conditions. First, pain in the SI joint is generally felt and localized in the gluteal region, but referred pain may also be perceived or felt in the lower lumbar and groin. It is important to note that the sacroiliac joint pain and posterior sacral complex pain are separate but overlapping entities. The SIJ is a sinuous joint. Due to its primary plane changing from cephalic to caudal, it complicates our understanding of its 2D planar imaging. Typically, just showing my pointer here, okay. Typically, when we look at the frontal radiograph, we see two lines or two joint expressions. The more posterior one, which is accessible to us when the patient lies prone, is virtually always projected medially. And the anterior expression of the joint, that one is inaccessible, is projected laterally. The right image shows a fluoro-guided SIJ injection where the needle is placed at the most caudal aspect. And this is where the two joints come together as one. So when you inject the joint, you can observe how very thin the synovial space is. We see the posterior aspect of the joint over here and the anterior aspect of the joint. As the dye fills up, we can see that it outlines the synovial space all the way to its superior aspect, but only up to its anterior extent. In terms of imaging of the SIJ, findings of osteoarthritis such as sclerosis, vacuum phenomena, marginal osteophytes, and joint space narrowing do not correlate well with pain. Images here are CT manifestations of typical OA findings. We see here bridging osteophytes, some marginal sclerosis, and a little bit of joint space irregularity, and none of these findings correlate well with pain. And this has been demonstrated in the study by El Ghafi et al. In terms of physiologic imaging, we have bone scans. Bone scans are relatively specific but insensitive. You can see the specificity in this two study, which is around 100 to 90%. But the sensitivity is quite low. Hence, a positive scan is specific, but a negative scan is unhelpful. An exception to this occurs when we're talking about inflammatory spondyloarthropathies. Here we see MRI physiologic parameters, that is T2 hyperintensity, T1 hypointensity, and gadolinium enhancement, which correlate well with disease activity and symptom progression in spondyloarthropathies. Over here, this is a patient with an active spondyloarthropathy, and the T2 weighted images indicate extensive signal abnormality and some fluid around the joint. We can see the accompanying radiograph to your left. During therapeutic injection, some significant sclerosis and loss of the nice cortical margin. Now, talking about piriformis and its relation to the sciatic nerve, as discussed by Dr. Mona, we believe that when there's some abnormal contraction of the piriformis, it creates some sciatic nerve irritation. And because of this, we have a term called piriformis syndrome to describe pain in the buttock. But let's pause for a moment and think about this. First, it's not uncommon for patients with piriformis syndrome to have some investigation of the sciatic nerve through ultrasound or MRI. But most of the time, they return to us with normal scans of the nerve. Second, if you look here on the diagram on your left, the sciatic nerve has a close relationship to the piriformis, but also it lies to many hip rotators. There are 6 of them altogether. So why do we have to pinpoint one muscle and call it piriformis syndrome? The diagram on the right, we see that the sciatic nerve usually exits inferior to the piriformis, and as said, it has an intimate relation to a number of hip rotators. And then also, as you can see, a number of nerves around this area. This is enclosed by the gluteus maximus into a very tight space called the deep gluteal space, and a lot of things can be wrong in this area. This leads us to a term such as deep gluteal pain syndrome, which embraces a wider spectrum of anatomic structures and etiology for sciatic nerve involvement. It describes the presence of pain in the buttock caused by a non-discogenic and extrapelvic entrapment of the sciatic nerve. This was termed in 1999, so this is not something too new. But if this is something of your interest, this article is fairly recent and has a nice summary of all the things you should know about deep gluteal syndrome. The following are the current advances in imaging of the deep gluteal syndrome and its sciatic nerve involvement. We focus our attention first for dynamic ultrasound. We focus our attention on the diagram on your left. If you apply a long axis scan of the sciatic nerve, the left-hand side is cephalad and the right-hand side is caudal. We see a sagittal scan of the sciatic nerve over here. Deep to this is the superior gemellus muscle, inferior gemellus muscle, and over here at the arrow is the tendon of the obturator internus. And when you start to internal rotate the hip, you will note that the sciatic nerve will not assume a smooth contour. It may look like buckled over here, but it doesn't mean that you will right away have symptoms of sciatic nerve irritation. But what it does is it decreases the excursion of the sciatic nerve. Next is high-resolution MRI and MR neurography. Here we have axial scans of the piriformis over here. The right image is a coronal scan of the piriformis, and the sciatic nerve is somewhere around here. But we are not getting the details. In higher resolution MRI, you can see much more detail about the sciatic nerve, and something here traversing the nerve, and in some cases, it might represent a fibrous band that can actually adhere and cause sciatic nerve irritation. And when you have better resolution, you can have a better understanding of the nerve and even see the sacral plexus with the MRI called MIR neurography. The third is tractography. It is a medical imaging technique that uses data from a special MRI scan called diffusion tensor imaging. It has been used for the brain and now can help us pinpoint the source of pain, especially if it is nerve-related. It can also present in detail nerve structure variations, which is most important if our patients show atypical symptoms. An accompanying condition that we may often encounter with patients having piriformis syndrome or deep gluteal pain syndrome is pain at the greater trochanteric region. It is not only the piriformis muscle attaching onto greater trochanter, but there are also other tendinous attachments coming from the gluteus muscle. It is important to remember that symptoms causing GTPS are usually due to a gluteal tendon abnormality and is rarely caused by a true bursitis. There are various diagnostic imaging modalities for GTPS, with ultrasound being the first line of investigation, as it can detect soft tissue abnormalities. As what I said, the primary etiology for GTPS is a tendon abnormality. Ultrasound can also be helpful when identifying snapping hip conditions associated with GTPS. MRI can help differentiate GTPS from other conditions that cause lateral hip pain, such as osteoarthritis and femoral acetabular impingement. Lastly, we have radiographs that might be helpful in cases of calcification, also associated with this condition. The diagram on the left shows an ultrasound examination of the greater trochanteric region, knowledge of the anatomy of the different gluteal tendons, their facet attachments, corresponding bursa is essential in identifying the source of pain and injury. Diagram on the right shows an amorphous calcification over here, adjacent to the greater trochanter, while the corresponding ultrasound image below shows a solid calcific nodule with posterior acoustic shadowing adjacent to the insertion of the gluteus medius tendon. An important structure that can present as myalgia of the pelvic floor is the obturator internus. Dysfunction of the obturator internus, such as strain, overuse, tendinopathies, or even bursitis, can result in deep gluteal pain, often mistaken as piriformis syndrome. And one of the reasons why it may be easily subjected to injury because of its anatomy. If you can see here, it has a sharp angulated exit from the pelvis, coursing posteriorly around the ischium and courses laterally deep to the sciatic nerve, and has a common insertion with the gemmelli muscles. Another important structure here on your right is the Alcock's canal, and more on that later. Ultrasound can be used to evaluate obturator internus muscle injury or tendon, surrounding structures, particularly in cases of suspected bursitis or muscle injury. So how do we target the obturator internus? Using fluoroscopy, you can obviously easily isolate where the obturator foramen and treat along that lateral margin of the foramen. But if you choose ultrasound, it's usually straightforward as well. You can visualize clearly the inferior pubic ramus and target the needle into the obturator internus area. For the last part of my presentation, we will discuss about nerve entrapments around the pelvic region, namely the ilioinguinal and iliohypogastric nerves, pudendal nerve, and posterior femoral cutaneous nerve. Here we see in the cadaveric picture on the right the ilioinguinal and iliohypogastric nerves and its entrapment site at the area of the external oblique muscle. The cadaveric picture on the left shows a close relationship of the pudendal nerve over here and the posterior femoral cutaneous nerve. This is a nice diagram of the different innervation of the perineum and pain patterns of the nerves discussed. Take note also the extension of the pain patterns to the lateral thigh over here, coming from the branches of the iliohypogastric and posterior femoral cutaneous nerve. As previously mentioned during my discussion about sciatic nerve, ultrasound, MRI, and high-resolution MRI such as MR neurography are useful tools for evaluating peripheral nerve pathology. They can also reveal muscle atrophy and denervation, with high-resolution MRI offering detailed visualization of the entrapment such as scarring, masses, or anatomical variants. However, these modalities are best reserved for complex cases requiring anatomical clarification. The ilioinguinal and iliohypogastric nerves may be injured in cases of open appendectomy, cesarean section, and even trocar insertion during laparoscopic surgery. It has a consistent location laterally at the superior aspect of the ACES and found between the transversus abdominis muscle and internal oblique. The diagram on the right shows a cryoanalgesia procedure targeting these nerves. Next, we have the pudendal nerve. And there are many ways that we can injure the pudendal nerve, whether it's through vaginal delivery or someone's very active, doing a lot of squatting, even prolonged bicycle riding. And when we think about entrapments of the pudendal nerve, majority of the time, the entrapment is at the ischial spine. And we have numbers here. It is possible that the entrapment site may exist higher at the greater sciatic notch and even distal at the Alcock's canal. The diagram on the right shows that the pudendal nerve at the Alcock's canal under ultrasound visualization. You can see clearly over here the diving down muscle highlighted by the yellow arrow is your obturator internus. The levator ani is covering the visceral portion over here highlighted by the blue arrow, and the coccygeus muscle is pictured as orange, situated medially, and the target is the pudendal nerve over here, just medial to the ischial tuberosity and obturator internus muscle. Lastly, we have the posterior femoral cutaneous nerve, which is one of the nerve that can actually communicate with your pudendal nerve. Here we see the anatomic dissection on the left, showing the perennial branch of the posterior femoral cutaneous nerve, traversing and coursing medially, innervating the scrotum in this male cadaveric specimen. And this is one of the reasons why sometimes patients are non-responsive to a pudendal nerve block. The diagram on the right shows a fluoroscopic landmark of the posterior femoral nerve, showing its close relationship to the sacrotuberous and even the ischial tuberosity. Hence, injury around these structures can also injure the nerve. And I think that's the last part of my lecture, some take-home points. You should have a broad differential diagnosis when dealing with musculoskeletal and even neuropathic causes of pelvic pain. Diagnosis begins with a thorough clinical evaluation with imaging as a supplementary tool. And lastly, imaging plays a key role in guiding safe and accurate interventional procedures. Thank you, everyone.
Thank you again, Dr. Estrada, for another insightful lecture. To keep the ball rolling, let's get on to our next speaker. She is the new department chair of Department of Rehabilitation Medicine, Philippine General Hospital, a registered musculoskeletal ultrasound sonographer, Alliance for Physician Certification and Advancement, a clinical associate professor of the UP College of Medicine, an associate professor of the College of Allied Rehabilitation Sciences, UERMMCI, the program director of the Physicians for Peace Philippines, secretary of the Fragility Fracture Network Philippines, consultant of UPPGH and Metropolitan Medical Center, to give her insights on the incidence and prevalence of low back pain. Let us all welcome our department chair and program director, Dr. Dorothy Dichingbing Agsaway.
Hello again to everyone. Before I start, I'd just like to acknowledge some key figures here in the room. So we'd like to acknowledge the presence of our international faculty, Dr. Teresia Novi, who came all the way from Indonesia. Thank you very much for coming. Dr. Jemilo De Castro, our advisor for this program and event. Yes. And we'd like to also acknowledge all our participants who braved the weather. And of course, we have one here from Dr. Lee from Singapore. Yes. And we also have our participant, our orthopedic colleagues who came all the way from the northern part of the country, from the Visayas and Mindanao. Yes, thank you very much for coming. And of course, our own colleague, our members from Rehabilitation Medicine, who came also from the northern part of the country and also from the Visayas region. Thank you very much. And from the National Capital Region, thank you very much for attending our activity, and of course, our faculty. So I'm assigned this topic on low back pain incidence and prevalence. So we will take a short pause from a very in-depth discussion of anatomy, but we will shift a little bit on the incidence and prevalence. So for disclosure, I have no conflict of interest. I have to disclose I'm not an epidemiologist, but I'll just have to present this lecture. So our learning objectives is to define some terms, and we have to go back on the epidemiology of low back pain, discuss the incidence and prevalence of low back pain, as well as correlate low back pain with global health issues, and mention some of the preventive or intervention. So low back pain. So actually, low back pain has been documented way back in the ancient Egyptian times, 1500 BC. So this is just point out that even early on in the ancient times, in the olden days, low back pain has been already well recognized, and physicians in the olden days were able to do some physical examination during that time. And low back pain is not new, right? And of course, for us, we have to also review some terms with regards to prevalence and incidence. Now, these two terms measures the frequency of disease. However, it is different in terms of the aspect that they describe. So when we talk about prevalence, this actually measures the proportion of population that has a condition already. So that means prevalence will tell us the existing disease. How many has the existing disease? And with this number of the proportion of population, it will provide now an information on the burden of disease. As in contrast with incidence measures the rate of the onset of a condition over a specific period of time. So this will now tell us the new occurrence of a disease. And this reflects the risk of developing the disease and important for etiology determination. While epidemiology is the study of the frequency of disease, which also include the distribution of the disease, the determinants of the disease, as well as its prevention. So just a short definition of the term pain. Pain right now has a new and revised definition according to the International Study of Pain. This is now defined as an unpleasant sensory and emotional experience associated with and resembling that associated with actual or potential tissue damage. It emphasizes now both sensory and emotional aspect of pain. It's not just only physical now, no? So pain can be related to actual or potential tissue damage. So it has 6 key notes, no? So pain is a personal experience influenced by various degrees and varying degrees by biological, psychological, and social factors. So it's a little bit complicated now. And pain and nociception is 2 different phenomena. So they are 2 different phenomena. So we have to really differentiate nociception and pain because it can be just an emotional description or not just purely physical. And pain can be learned through experiences. And a person's report of pain should be respected. Sometimes we might be thinking that they might be doing malingering or not saying the truth, but we also have to respect if they reported pain, even if we think that as from the medical point of view, it seems like it's not true, but sometimes we have to acknowledge it. And pain usually serves as an adaptive role, but may also lead to adverse sequelae on function and social and psychological well-being, especially if it's taking so much time and it's persistent for a long period of time. And verbal description is usually a common way of expressing pain, but sometimes for those who cannot express themselves, we also have to take note of the presence of pain, especially through gestures or through facial expression. So based on anatomical boundaries, when we talk about low back pain, pain will be described starting below the lower edge of the 12th rib all the way to the inferior gluteal fold. I will have to pardon my slides because I shifted my laptop to a USB, so I think it did not match the features of this laptop. Anyway, so when we talk about low back pain, again, the anatomical boundaries will start from the lower end of the 12 rib all the way to the inferior gluteal fold. So this mainly will include the lumbar, the lumbosacral, and the buttock areas. So in general, low back pain, at one point in time, we will all experience that, no? Once at our lifetime. And of course, with the description, most of the patients will describe the pain as localized, can be diffuse, can be radiating, can be referred pain. So, well, low back pain can be classified into several areas according to duration. So it can be just acute pain, so it's relatively less than 6 weeks. Subacute is 6 weeks to 12 weeks. Chronic if it's more than 12 weeks. And if we try to check the intensity of the pain, we can have several tools to check, or scale to check the intensity of the pain. It can be using a visual analog scale or numerical rating scale. For the anatomical location, it can be a somatic type of pain or the visceral type of pain. For the etiology, it can be subdivided into general umbrella of non-specific to specific. And with regards to pathophysiology, pain can be categorized as a nociceptive type of pain, meaning there's an actual tissue damage or inflammatory process ongoing. This is one of a physiologic response after a tissue damage or tissue injury. And it could be also a neuropathic type of pain, meaning the pain emanates from a damage or lesion affecting the nervous system, or a nociplastic type of pain, meaning the pain emanates or arises from an aberrant or deranged nervous system, which may not have an actual evident tissue damage for that matter. So nociplastic type of pain. So with regards to WHO, as of 2020, WHO has already mentioned that there are already 619 million affected with low back pain. So this actually represents 1/10 of the population, and this is projected to increase to 843 million. And low back pain is considered single and the predominant cause of years lived with disability worldwide. And because this is a leading cause of years lived with disability as of 2021, this accounts for 15.9 million disability-adjusted life years. So that is the DALY. No? DALY represents 1 year of loss of healthy year, no, for this patient. So low back pain is the greatest contributor to the loss of productivity, absenteeism, and disability, as well as early retirement for our patient who will manifest low back pain. And this will also influence labor market and healthcare system, as well as socio-economic framework. So low back pain is actually, with regards to the scope of problem, has the highest prevalence globally among musculoskeletal conditions. And low back pain can happen to anybody. You know, it can be present in children, can present in adolescent as well as in adult. But among all in the population, women represents the highest that will have a low back pain, a greater number of low back pain. And the peak number of cases will be observed in the 5th decade of life to 55 years old. So women experience more low back pain than men. And because the prevalence, and with low back pain, the prevalence and disability impact is also greatest among those who are senior citizen on their 80th or to 85 years of age. And for most of our geriatric population, they will have recurrent low back pain episodes, and this is also common among geriatric population or aging population. So looking at the global picture, the proportion of years lived with disability in adults and those aged 55 years old, there are 3 risk factor contributory to this. And it was found out that occupational ergonomic factors accounted for 15% of patients with presenting with low back pain. Smoking also is another risk factor at 13.5%, and a high BMI for those representing 13.4%. So, obviously, incidence, prevalence, and disability impact is really increasing from 1990 when the data were obtained up to 2021. So the global burden also among working age group is already at 452.8 billion. So that means this will be our clients. When we go to the clinics, it will be likely our clients in the future. So again, the incidence of low back pain from 1990 started from 125 million to now 125 million point 92 to 192 million point 5 as of 2021, a 50% increase in the numbers. And so it's really a call to action with regards to this increasing number of incidence and prevalence. So again, why is it important to take note of this? Because working population or working age group is also a substantial segment of our workforce, and we need them. We need them for our labor market, for our economics. Okay, and they are also contributor to the economy. Frequently, most of our working age population encounters a lot of occupational risk factors. That also make them prone or at risk for developing low back pain. In this slide showing us the global, regional data on the different age groups showing low back pain. So this one, they have an age group of adolescent, adult, and geriatric population. So here, there is prevalence of 1,600 for adolescent manifesting low back pain, and incidence of 830, so relatively low. But if you go up with your age, when you become an adult, and then down the line, if one gets into the geriatric population, all the more that there is increase. There's a peak number of your prevalence and incidence. So low back pain is not just pain, but we also have to also understand that it also may affect some other factors, like sleep, mood, and distress. And as such, if pain will not be addressed early on, then this might also lead to the vicious cycle of other problems. Like initially, it might initially present with physical problem, but if it will not be addressed soon enough, then it will lead to some other psychological problem, which will lead to depression, increased perception of pain, and then other problems like anger, fear, and reduced social interaction, isolation, and so on. So there will be a vicious cycle of pain. So with regards to intervention, we mentioned about the etiology of pain, low back pain. So you will be surprised that in the WHO key facts figure, it mentions that 90% of low back pain are actually non-specific. So if it's non-specific, the main intervention there is just to recommend that they engage with physical activities, and there should be also additional psychosocial and social support group. And we also have to ensure that there will be strategies to reduce strain at work. And if needed, then we also have to advise lifestyle changes like the diet, and let them engage in activity because there's always a shift now of the sedentary lifestyle that we are having right now. Most of us are hooked to the computer. We don't really stand up most of the time because we're so engaged with fixing our work, or our engagement with our work is all in the computer, so we really have less time engaging with outdoors activity. So we have to have the change in our health habits. Now, for specific conditions, Dr. TD, Dr. Mona has already mentioned about the different conditions that might manifest or that might be the cause of low back pain. And we also have to really have a thorough history and physical examination to really probe deeper and find the underlying condition so that we will be able to provide the necessary strategies and interventions. No? It might go from initial intervention of medication, oral medication, to the different rehabilitative intervention, to pharmacological intervention, and more aggressive ones like injections, and if needed, then surgical intervention. So with regards to low back pain, what is important here is a patient-centered approach with multidisciplinary care. So we emphasize a holistic approach in terms of managing low back pain. So because we want pain relief, it's not just purely totally medication, but we also have to ensure that we will be able to probe and assess the other factors that might also contribute to low back pain. And of course, for patients with low back pain, they will benefit from rehabilitation services. And we just like to emphasize that in the WHO Rehabilitation 2030 initiative, there are already several publications or public dissemination of this initiative from WHO that we have to consider. And of course, because we mentioned that a lot of our patients suffering low back pain are also in the geriatric population, with the UN Declaration of Decade of Aging, which we are already celebrating from 2020 to 2030, we also have to ensure that our geriatric population will be properly taken care of. So, in summary, global low back pain incidence and prevalence are continuously increasing, and the main drivers actually is because of population growth and aging. And so there's an urgent need, and there's a need to campaign for comprehensive public health planning and responses. And we have to improve access to rehabilitation service to reduce long-term impact of low back pain on health system, as well as for workforce productivity and economic stability. And so we have to promote no to low back pain. So for all of us, I hope everyone will be staying fit and healthy so that over time we will not suffer from low back pain, and we keep ourselves available for our patients, clients. Thank you very much.
Thank you, Dr. Diching Bing Agsaway, for that informative lecture on the incidence and prevalence of low back pain. For the last lecture for this morning, may I present the former chair of the Department of Anatomy, UP College of Medicine, chair of the Museum of History of Ideas, program leader of Biomedical Engineering Program of the National Institute of Health, underwent fellowship at the Oxford University, United Kingdoms, Japanese Orthopedic Association Traveling Fellowship, and received the following awards: Distinguished Orthopedic Surgeon Award from the Philippine Orthopedic Association, Outstanding Educator Award from the UP Medical Association Society, Eisenhower Fellowship Award, and Metrobank Outstanding Teacher Award. He's a consultant of the UP Philippine General Hospital. To share his expertise on fluoroscopic guided versus ultrasound guided injection in spinal disorders, I am humbled to introduce to you Dr. Rafael C. Bondoc.
Hello, good morning. Thank you for allowing me to give this short discourse on what might be a viable choice in doing injections for pain relief in spinal disorders. We actually have two choices that will give us an accurate trajectory to where we want to deliver our injectate: an ultrasound and a fluoroscopic apparatus. And usually we want to deliver them either over the epidural area or over the nerve roots. So let me go directly to the comparison between the two. My disclosure is I don't do ultrasound, and most of what I have here is based from literature, okay? So with ultrasound, our equipment, of course, will be an ultrasound handheld apparatus. And with fluoroscope, you need to have a C-arm or an image intensifier. Logistically, an ultrasound is handheld. It can be done in your clinic, in the community, as compared to a fluoroscopy where you have to be facility-based, where you have this fluoroscope machine. And of course, with ultrasound, you can do it by yourself, no assist needed. But with fluoroscope, you have to have a radiology technician. And protection-wise, you have to wear lead gowns. When ultrasound, you don't have to have any protection at all. And of course, the medium with ultrasound is sound waves, and with fluoroscope, you have radiation, for which you have the risks of radiation exposure. That's why you have to have your lead gowns with you. And with fluoroscope, you have to inject dye in order to be able to visualize the nerve root. And of course, some patients might be allergic to dye injection, okay? With visualization, you have very good soft tissue exposure or visualization with ultrasound. With fluoroscope, you have excellent bone visualization for your landmarks. And accuracy-wise, leveling might be an issue with ultrasound. Of course, many of you will disagree with me, but with fluoroscope, it is very precise because you can see the levels of the bone very well, especially the vertebral levels. Now, as to which is a better choice, literature is awash with randomized trials comparing ultrasound to the gold standard, which is fluoroscopy. These studies show varying conclusions depending, of course, on the preferential experience of the authors. But we have plenty of reliable systemic reviews and meta-analysis comparing clinical results that expounded or expounds on the VAS scores on back and leg pain, Oswestry Disability Index, and other clinical parameters comparing ultrasound and fluoroscopy. Now, let's just look at the summary of these comparisons. With ultrasound, these studies point out to the ease of handling the apparatus, where obviously, with ultrasound, one is dexterity in handling an ultrasound on one hand and then controlling your needle on the other hand. Versus fluoroscopy, wherein both of your hands are on this delicate needle that you are inserting over our patients. Time-wise to execute the procedure is almost comparable. Now, there are reported bleeding injuries in fluoroscope, understandably because you don't see the blood vessels as compared to ultrasound. With a bit of infection reported in ultrasound, probably attributed to the gel use, because of course you need gel when you inject, and when you have gel over that area and you inject it, you introduce part of those gel inside the body of the patients. But clinical results are perfectly the same. And what we are after is the clinical results. So comparing ultrasound and fluoroscopy, clinical results are the same. So literature says that whatever technique works, as long as we have the training and the experience enough to direct our common denominator. And what is our common denominator? The needle, which is the most important part of our work. Now, the bigger question is, how much do we really know the hypodermic needle? Needles are engineering marvels. It is a precision instrument that comes in different diameters and lengths and forms, specially designed for specific utilization. It is one of the most vital tools in medicine and surgery. Needles are internationally color-coded, and our most useful tool will be the gauge 26, which is brown-colored, and the gauge 23, which is blue-colored. And for our purpose, we use the 85 millimeter long, commercially available spinal needles. Our needles have opening ports at the end, with bevels on the pointed end, with corresponding markings on the locking cups of the stylet on the opposite ends, which we hold. Now, do you know that we have three different types of tips? We have the Quinque, we have the Whittaker, and we have the Sprote. The Quinque is the most popular because it distributes our injectate forward and sideways. The Sprote and the Whittaker are used in directing our injectate to the side where we want it to go. Now, we have a problem with the bevel. And as you can see, the Sprote and the Whittaker are not beveled. So when you inject them, there's a big difference between a beveled needle and a non-beveled needle. When magnified, they look like mean deadly weapons. The Quinque is beveled, a cutting tool which can injure blood vessels and the neural structures. That is why we have to be very careful when using it. This picture is a gauge 25 needle magnified 30 times. And one can see how very sharp it is at the edge. Now, the bevel of the Quincke needle puts it in an extreme disadvantage, and the Quincke is one that we use very often because it causes the needle to deflect as it goes through the resistance of the tissue where it is injected. Look at this video. This is a simple homogeneous gelatin, and you can see as we insert our needle, it deflects downwards because the bevel is catching on the resistance of the gelatin. And you have to imagine, we're going to use this on muscles, ligaments, no? And a patient is squirming in pain. And as the muscle spasm, no, you can have more deflection. Thus, it can be very frustrating in targeting your intended area if you don't maneuver your needle as you insert it. So as you insert your Quincke needle, you have to turn it around in order to be able to negotiate the direction that you want to do, or else you will never reach the level where you want to be. Now, have you ever thought of that? No. At least I have taught you something for today. Just where do we want to direct our needle using ultrasounds and fluoroscopes? We want them to be injected caudal. You can deliver it in the epidural space by injecting it interlaminarly or foraminally, or to the foramen directly to the nerve root. So basically, if you want to deliver or inject it to the epidural area, we can deliver it interlaminarly by piercing the ligamentum flavum, or caudally to the sacral hiatus, or if you want the nerve root, we can choose the foraminal root. Literature dictates that the best technique of delivering an injectate to the spine to control most pain disorder is over the foraminal area. It is not the scope of this lecture to compare translaminar versus transforaminal versus caudal injection, and I will focus on the foraminal injection. Okay? On the transforaminal steroid injection, let us understand the foramina first. The foramina is an architectural opening between two vertebrae where our nerve root exits. And I enjoyed the lecture of Dr. Estrada a while ago because it was a very good lecture on the anatomy of the spine. And she already delved a little bit on the foramina. But I would like to draw your attention something bit about the foramina yet. So let us understand the foramina a bit better. The ganglion occupies most of the foraminal corridor. The dorsal root ganglion contains a rich number of mechanosensitive receptors and nociceptive cells that are related to pain sensitivity. After the ganglion, the spinal nerve branches into a ventral and a dorsal rami. The ventral rami goes to innervate the trunks and the limbs. The dorsal rami, on the other hand, supplies the muscles of the back, the facet joint, and the capsule. Then, we have the recurrent nerve of Luschka that goes back inside the foramina, which innervates the sensitive anterior half of the dura, the posterior annulus, and the posterior longitudinal ligament. This recurrent nerve of Luschka plays a very big role in pain generation. Thus, over the foraminal plane, one, we have the ganglion, the recurrent nerve of Luschka, and the sinovertebral artery, and the epidural vessels, as what Dr. Estrada has shown a while ago. Thus, steroid injected over the foramina exerts its effect on the recurrent nerve of Luschka to control pain over the annulus and the anterior dura. It will also exert its effect on the ventral rami to lessen sciatica to the legs, and it will also exert its effect on the dorsal rami to relieve pain of the dorsal paraspinal muscles and the facet joint. Now, if you inject your medicine into the epidural space over the caudal area or the interlaminar area, you won't be able to contain your injectate over the area where you want to control these pain generators. It will just disperse over epidural area. That is why foraminal injection is a lot better than epidural injection. It is like hitting 3 birds with 1 stone which we cannot achieve with epidural injections. The foramina is actually a very complex structure. We have to realize that we have plenty of very fragile interforaminal ligaments within the foramina itself that holds the nerve root in place. Microscopically, our foramina will look like this. This structure is our nerve root and the recurrent nerve of Luschka and our transforaminal blood vessels within the nerve root. And I think Dr. Estrada has shown that with an MRI picture. Then we have the superior, the middle, and the inferior transforaminal ligaments, which creates a diaphragm-like structure over the foramina. So there is a barrier before we go into the epidural space from the foraminal area. This transforaminal ligament suspends our nerve root well in place so that we will not be rubbing, so that the nerve root will not be rubbing against the osseous corridor of the foraminal corridor. Thus, when there is resistance, when you're injecting your medicine over that area, you need to pull out a little bit because the tip of your bevel might be hampering against this diaphragm. That's why it won't go out. So pull it a little bit and inject it, and once it is free, it means that you are now over that area. Okay? Now, how to target the foramina? I do not do ultrasound, but I use fluoroscopy a lot on a weekly basis. One is to position the C-arm in AP, lateral, and oblique planes. Unfortunately, Dr. Dichin Bing wanted to have a fluoroscope-guided demonstration as well, but it did not push through. Probably in Muscles 3, we should be able to incorporate fluoroscopy already because our department, anatomy, has our own C-arm, as you can see later on. Okay? You need to have a good rad tech with you, and both of you should be protected with lead gowns. Okay? So this is the setup that I have in our outpatient OR where I do my ultrasound on Thursdays. I gather all of my patients for the week and do it on Thursday afternoon or morning, sometimes 3 of them, 5 of them. That's why I know a lot when it comes to fluoroscopic injection of steroids. When it comes to vertebral leveling and targeting fluoroscopy, fluoroscope will remain to be the perfect gold standard because you can really level it very well and you can target your foramina better. No? What do I mean? With fluoroscope, nothing can compare with very clear pictures like this of your cervical foramina and your lumbar foramina. With ultrasound, it can give you leveling, but it might not reveal problems with lumbarization and sacralization issues. That will matter in our pain control. And sometimes sacralization and lumbarization are incidental findings when we are doing fluoroscopic injection. You don't know that the patient has it until you see it during your leveling with fluoroscope. And with ultrasound, it might be seen at all. Now, in fluoroscopy, we use non-ionic contrast medium to visualize the nerve root in fluoroscopy. And you should see a picture like this in the cervical spine of an image of the nerve root once you have injected it with your dye. And you can see here a very good image of the C5-C6 nerve root. Okay? Or something like this with your injection. Or something, a perfect picture like this of your brachial plexus as you inject your dye. Okay? This is a very good lumbar case where you can see the L4 nerve root as you inject it on both sides, okay, with a dye. And this is a sample of your L5 nerve root. This is an injection of 2 levels where you can see L4, 5 nerve roots very well, and you can see the needle there. No? And at least with fluoroscopy, you need a dye to be able to see your nerve roots. With ultrasound, you can see images of those nerve roots. No? But a good thing about fluoroscopy is that it is very good in targeting the foramina of the lumbar area. This is another multi-level injection of injectates over the area where we want to control pain. And you can see very good images of all the nerve roots. And these are some other pictures of patients where you can see the nerve root. And as you can see there, you don't only see that exiting nerve root, but sometimes you can also see the traversing nerve root. meaning to say that you were able to disperse your injectate beyond the diaphragm of the foramina. Now, with ultrasound over the lumbar area, you will not be able to see or visualize the foramina very well. Probably in the future, as technology develops, you will be able to see that, no? But I believe, however, that for the cervical area, ultrasound can be a game changer. That's why I volunteered to lecture here, because I want to have a free registration, because I want to see how you do your ultrasound over this area. And as you can see, over this area, I think 1/3 of the registrants of this course are orthopedic surgeons wanting to learn from our rehab colleagues. Okay? Because in the cervical area, you have your cervical foramina, okay, very near your carotids and the very deadly vertebral artery. With Doppler ultrasound, we are able to appreciate vascular structures very well, enabling a safer corridor for us to reach our target area and prevent injury from the very innocuous vertebral artery. Because with Doppler ultrasound, you can actually see the color of your artery. Okay. And lastly, the injectate. All of us have our own concoction. All of us have our own secret formula. Okay. This concoction has been formulated by my anesthesiologist over the 25 years that we have been doing spinal injections. So take your picture. It has a simple secret that we gladly share to our colleagues so that our patients may benefit from it. I tell you, this concoction works very well for us. And I guess it will also work very well for you. So you have your local anesthetic, which we inject over the area where we inject our injectate. Of course, pain is only felt when the tip of the needle touches the skin. That's my issue with ultrasound. Sometimes you have pain all over that area, and as you massage them with your sensor, the patient keeps on screaming because they're already in pain. Here, at least, with the local injection, once you insert the needle, you don't cause much pain on the patient that you're injecting. Now, our base fluid is over there, and our injectate is with methylprednisolone. So our injectate is 1 ml of methylprednisolone plus 2 ml of the base. So actually, what we inject over the foraminal area is 3 cc of our base and our methylprednisolone. Okay? So, take-home messages. I hope I have compared somehow ultrasound and fluoroscopy as targeting tools. Whichever we are using and whichever we are experts in works, but we want to learn from each other. We orthopedic surgeons who do a lot of fluoroscopic guided injection, we want to learn your technique. Thank you very much for bringing us in here, okay? I have expounded on our secret weapon, the needle, which most of you don't realize is very, very important and a big engineering marvel. I have told you that foraminal injection is better epidural because we direct our injectate over an area where we hit 3 birds with 1 stone. The foramina is something that is hard to understand, and I think now we understand it with my lecture and the lecture of Dr. Estrada. And I think cervical foraminal injection will be the thing of the future with ultrasound, and we have shared our secret weapon, our simple formula, the injectate. Thank you very much for your attention.
Thank you very much, Dr. Bondok, for that very insightful lecture. Your detailed comparison of these techniques, along with your clinical insights, provided great value to our understanding and practice. At this point, we will have our lunch break, so everyone will be having a packed lunch. So I think you could, is it available? It's available already at the registration booth. We just have some few announcements. May we ask the following doctors to visit the registration booth for additional signatures: Dr. Jeremy Flordelis, Dr. Carissa Genuino, and Dr. Beatriz Rey Machas. And may I invite all the faculty members and staff at the Mariano Hall so that we could have our lunch together to talk about the afternoon session. Thank you very much. Please be back by around 11:45 a.m. Thank you so much. May we ask everyone to settle down, please? So to make the most of our event today, our next speaker is so eager to start early so that we could have an extended discussion of his topic. So for those who haven't answered yet the pre-test, you may scan this QR code. Good afternoon. We hope you had a refreshing lunch. To kick off our next session, it's my pleasure to introduce a distinguished speaker who will be discussing the biochemical and physiologic basis of low back pain. This topic is essential in understanding the underlying mechanisms that contribute to one of the most common and debilitating musculoskeletal conditions we encounter. Our speaker is a diplomate and fellow of the Philippine Academy of Rehabilitation Medicine, diplomate of the American Academy and Board of Regenerative Medicine, international member of the American Academy of Anti-Aging Medicine, and the American Academy of Physical Medicine and Rehabilitation. He's a former faculty of the Asia-Pacific Musculoskeletal Ultrasound, chairman of the Department of Physical Medicine and Rehabilitation, the Medical City South Luzon. He's the founding director of the Philippine Academy of Lifestyle Medicine, member of the Society of Diagnostic Medical Sonography. He's an examiner of ultrasound step certification program of AAPMNR and the medical director, CEO of Smart MD, Center for Non-Surgical and Regenerative Therapies. Please join me in welcoming Dr. Jemailo De Castro as we dive deeper into the science behind low back pain.
Okay, so good afternoon, everyone. My task this afternoon is to give you the biochemical, physiologic, and atomic basis of low back pain. As you can see, we all encounter low back pain in one way or the other, but somehow this is a disease which seems to be elusive in one way or sometimes very specific in the other way. So we have to understand really what is it in the low back pain that makes it very, very difficult sometimes to diagnose and treat. Maybe easy to diagnose but hard to treat. So for my disclosure, we have written these following books, and we're coming up with 2 new books this 2025, which is a sports ultrasonography, also by Springer. And next year we're going to release also another book, Dynamic Spine Sonography, which is also by Springer. So you can watch out for that. Now let me begin by citing a very familiar Bible text found in Isaiah 40, 30, and 31. Even the youth shall faint and be weary, and the young men shall utterly fall. But they that wait upon the Lord shall renew their strength. They shall mount up with wings as eagles, and they shall run and not be weary. They shall walk and not faint. So as you can see, and as has been I can describe early in this workshop, we have seen already that low back pain is very familiar to us, and in fact, a lot of patients with low back pain really comes to us on a daily basis, maybe representing about more than 50% of our patients in an outpatient department. But overall, this is an activity that is really limiting, and we would say to some extent this is also self-limited, but somehow there are patients who really have a struggle on how they would have to treat patients with low back, and that is why it is very important to make the right diagnosis. So today, we're going to do how to scan using ultrasound these structures in the lower spine, and what are the specific criteria that we would be using especially for our equipment. So usually for spine ultrasound, we recommend the low frequency so that you can look at the depth, but at the same time, you can also see the other details of the spine structure. But more especially right now, since we have a lot of ultrasound, I would really highly recommend that we choose a high frequency type of ultrasound. Really something that is sometimes very also limiting because the cost is just very high, but for you to be able to really see very clearly structures that you would like to see, I would really recommend that you use a very good ultrasound. And of course, curvilinear probe is the one that we recommend, although sometimes we can use also the linear probe, especially if we're looking at structures which is like your ligaments and other superficial structures of the lumbar spine. So here, how do we understand pain in low back? So if you look at the lectures early on, you will notice that most of the structures in the spine are generating pain. Whether you're talking about the nerve itself, the ligaments, the joints, the disc, all of those are sources of pain. But at the same time, there are also specific sites wherein we could say probably a very good source of pain, depending on how it affects in terms of pathology, and that actually releases substances that also cause pain. And of course, we have the sensory neurons also that are sources of this pain. Now here, we can also see that there are nerves that surrounds the disc that could be a very, very good source of pain. It was discussed earlier by Dr. Bondok, and you would notice that anatomies are not always, should I say, they're always the same. And it's just a matter of knowing where exactly that is in relation to the structure that we're looking at. So these structures are very important because this would give us an idea that if there is any alterations on the structure, it would definitely evoke pain, or should I say there will be pain that will be felt by the patient. But on the other hand, there are also other markers that we used in order to identify areas that could actually cause pain. An example of that is your growth-associated protein, which is a marker of pathologic nerve ingrowth, which is actually the one that transmits pain, especially for the degenerated disc. And of course, the pro-inflammatory cytokines in the form of your TNF-alpha, interleukin-1, interleukin-6, all of these are pro-inflammatory cytokines that generates pain whenever there is altered or there is any problem. And that is why it is very important that if we discuss to patients issues about low back pain, that they understand exactly what's going to happen and what exactly is causing the pain. Because sometimes while we are doing interventions, it is also understandable that there might be some other issues that could generate the pain, which is actually beyond the scope of our practice, that we can always refer to our colleagues here. So we have a lot of orthopedic surgeons around. And I don't know if there's an anesthesiologist around here. No anesthesiologist? Okay, just orthopedic surgeons. Okay. And then, of course, the reason I mention this is because what I usually do is, of course, inject it with alpha-2 macroglobulin, which is actually an anti-pro-inflammatory cytokine. So it acts against the pro-inflammatory cytokines, which is your TNF-alpha, interleukin-1, and interleukin-6. But at the same time, new understanding of the spine also shows that the disc is considered to be the largest vascular organ in the human body and an immune-privileged site. In other words, immune complexes and alterations could also generate pain, which could not be seen on an MRI. When we do assess our patients, which is actually the most important part of our physical examination, we really have to go through the process of really getting all the history, physical examination, and we have to really spend a lot of time doing that, because not all the pains in the back could be explained by the presence of what we see on the images. I'm mentioning this because I know you understand what I mean, that sometimes you do MRI and you cannot find any reason for the pain. You do ultrasound, you cannot also explain. You do X-ray, the more we cannot explain anything. So I hope when you look at this imaging modality, it's just an assist to what you already know. And it should not be something that you depend on in the absence of a diagnosis. Because otherwise, if that is our approach, we will make a mistake. We might just be treating an MRI and we miss the patient. Or we might just be treating an ultrasound findings and we might miss the patient. So I hope we're at the same page in understanding that we're treating the patients. We're not treating the modality, the imaging modality, whatever that is. So that way, we understand exactly what are the things that patient is coming. Sometimes they would come to you because of other sources. He will just say, oh, I have back pain here, but actually he's psychologically challenged. He might be suffering from, the video exposed in, I'm just kidding. Okay, so here, understanding pain generators in the lumbar spine. Of course, one other thing is your nerve growth factor, NGF. Now, for those of you who are doing PRP, let me just say this. PRP has a lot of NGF. So the more you inject PRP, the more it becomes painful. That's just what I'm going to say. Because if you inject it with an NGF present, you might actually induce more pain than treat the pain. And that is why this is just a warning for those doing PRP, that NGF is such a potent pain generator present in the PRP itself. And of course, this is also an area where we need to understand that not all distribution that is present in a level of the spine is coming from that area itself. For example, just to give you an example, for example, L1, L3, if we examine that area, we might thought the problem is in the L1, L3, but actually it could be generated by pain receptors actually coming from T11 to L5. So the reason for this is this anatomy. The anatomy here is so wide that pain coming from other areas of the thoracic spine could generate in the lumbar and vice versa. So we might be at a loss trying to find out, what is the cause, what is causing the pain here? I cannot find it, and the images doesn't coincide. So now we would understand, maybe there's other areas that we need to see that could actually explain the presence of back pain. Okay, now another thing that I would like to mention is the MRI findings on low back pain, which I mentioned earlier. This is a landmark study by Jensen, published in 1994, so it's a little bit older already, but I will show you a more latest study that I've shown. 52% of asymptomatic individuals had these bulges. So I'm sure Dr. People here would agree with me that if you just do an ultrasound, an MRI without any complaint, you will see something there. So don't treat the MRI, treat the patient. Okay, so 52% of asymptomatic individuals would show these bulges. Should we do something about that? Yeah, so it's your call whether you're doing something or not. Then, of course, a meta-analysis also found that 2/3 of lumbar disc herniations can regress spontaneously without surgery. I'm sorry for my colleagues here, but I hope you don't you don't unfriend me, okay? Okay, this is just a study that I'm trying to share. Okay, so here, if you look at the data, disc sequestration, 96% resolved. Disc extrusion, 70% resolved. Disc protrusion, 41%. Disc bulging, 13%. These are data that was a result of a study in 1994. So another thing is back pain without anatomic findings. 12 of the 21 individuals reported low back pain, had completely normal MRIs. They cannot see on the MRI anything. No herniations, no stenosis, no degeneration. So what could be the reason? And I think for rational doctors like we are here, we're trying to understand low back pain. We should be more broad-minded in the sense that we need to understand what really is causing the pain other than the abnormality that we see on MRI. Of course, we're going to image later, but it is also important that we understand exactly what is the real problem the patient is suffering from. And that is why it's very important that we really extract that from the history of the patient. We need to understand what happened, why this is happening. And of course, it also says in the same study, this is the Bornstein, was published in 2001, MRI findings are often poor predictors of low back pain. Just want to mention that. Of course, you've seen a lot of these images earlier this morning, but another study just said it could not be a good predictor for low back pain analysis. Okay, so you can see here what are the different types of this disc herniation. So you have the bulging disc, you have your protrusion, you have extrusion, sequestration. So all of this stuff that you see read and passed on to you by, of course, by the radiologist, because patients had an MRI and you're there. And then the patient is just in front of you and would say, okay, you know what? You know why you have a back pain? Is because of this. We cannot totally say this. Now, the reason I'm saying that is we have to try to broaden our thinking about low back pain. That it is not always what we think it is. Because eventually, for example, when we do something about a disc problem, you also have to remember that that level of disc will release also pro-inflammatory cytokines that will eventually affect the level above it and below it. And this is what you have to also think about a patient. Okay, a patient was operated probably 2 years ago and then comes back with a new problem of back pain. Of course, we say, oh, it's a persistent spinal pain syndrome, which was the new term used for failed back pain syndrome. But I think we have to understand that the moment the disc is tickled, okay, and this has been studied very well, it will really affect the level above and the level below. So it will be important in making decisions as to what is best for the patient suffering from back pain. Now, another study, actually the same study here, published by Kunha, which is published in 2018, that when a disc is seen to be herniating, this is a sequestrated disc, that there are cells that comes into play. And interestingly, the most important of these cells is your macrophage. The macrophage has an ability to actively phagocytize the herniated tissue with its receptors called CD36. So it has a receptor in the spine. It sort of engulf it and act through that and eventually acts on the findings that you see on the spine. And one of the more active pro-inflammatory cytokines is TNF-alpha, because TNF-alpha, once it's activated, will actually enhance the effect of the MMPs, or matrix metalloproteinases 1 and 3. And these are considered to be inflammatory type of matrix metalloproteinases. This is the one that really destroys the disc. Now, one very interesting finding that they found here in this study is that even if you inject, now there are people who are injecting intradiscal with regenerative products, and we appreciate that. But the moment you don't seal that area that was injected, it will release pro-inflammatory cytokines, and you will have more problems in the future. Because the pro-inflammatory that was released will affect the level above and below. It's almost like you're doing a surgery with that procedure. That's why the question of, should we do that? I'm not even interested to study about doing an intradiscal injection, because I know exactly what's going to happen. There has to be a sealant that has to be placed on the disc being injected in order to prevent the release of the pro-inflammatory cytokines. Otherwise, as it is released, it will affect the levels above and below that area. So what I'm saying is the macrophage is very important here and has a role here. Now the question is, why MRI fails? Because many asymptomatic people have disc bulges, degeneration, protrusions. And study shows that 30 to 80% of people with that back pain have abnormal MRIs. So that's why I asked you earlier today, what should we do about those people without any complaint and having these problems, having these findings? And MRI does not assess pain generators. It only assesses structures, but not pain generators. So here, not to overemphasize, the best tool is a skilled clinician using a psychosocial, biopsychosocial approach, integrating physical findings, functional assessments, and patient history, rather than completely just relying on imaging alone. I know exactly that you would like to rush your patients into finding what is causing it, but again, let's not miss the opportunity to really talk to our patients, find out how it happens, and what is the pattern of pain, and assess exactly what is going on. Now let's go through, I will walk you through the process of diagnosing, of course using ultrasound as a tool for imaging your spine. Of course, this is typical planes of the spine that we use normally. So you can see here that we divide into three parts: the transverse plane, median plane, of course, coronal plane. Now, there are specific patterns that we will see, but it is very important to understand first that specific areas, of course, you know those parts already, so I have to skip this one. But in the lumbar region, of course, we all begin with, of course, spinous process. That's the most prominent part that we see when we do your ultrasound. So the spinous process is in the middle. If you use a wide panoramic view of the ultrasound, we would be able to see everything. You can see the spinous process, you can see the facet joint, you can see the transverse process. But at the same time, you would also be able to find out that correct technique of scanning is also important. So you can only see this if you use a really true transverse imaging. But if you go to actual imaging, it will be a little oblique, because the only way to see all the structures together is to kind of scan it a little oblique to be able to see all the structures clearly. But for the purpose of just identifying the parts, then we could just say we could see all this together in one view. And then, of course, you can see like it's almost like a crown with the spinous process to the middle. But then, as we move a little to the side, then we would be able to see the paramedian sagittal view of the lamina, which is considered to be a horse head or a sawtooth view. And so you can see the lamina, it's like a horse head, as you can see here, horse hair. And what it depicts is just the lamina, and this is the site where you could almost kind of toggle it and be able to see all the details that you would like to see in the muscle underneath. And then, of course, we have the paramedian sagittal AP view, and then this one will show your erector spinae. We will also try to do this later on in the scanning, but just to characterize, this is like a camel humps view. You see, as you use your ultrasound, just a small movement to the side or to the left, as you move it, the images will change. So it's very important that you do it really, really small, and you move it quite sensitively, and so that you will see all the parts very well. So you will see all the structure. So that is your facet joint. And then, of course, as we go to the sides, then you would see a different pattern, and this is actually your transverse process. It's characterized as a trident sign with three-prong thing there. It could be more depending on the scope of your ultrasound, and then you can see all the details of the bone. So you actually scan this depending on the patterns, and the pattern will show you exactly what structure are you imaging. Then, of course, we can try to tilt it. As I mentioned, if you only see the one side, it's not completely transverse. You have to try to move it on an oblique to be able to see all the parts very nicely, where you can see the spinous process, the facet joint, and of course the transverse process, and of course the nerve root found between your facet joint and your transverse process. Now, here you will notice that I'm trying to inject an area of the facet joint, okay, and right there you would see how the needle goes down to the area. And then this is another view of the same images, injecting a right through the facet joint. Now, since we are talking here about the nerves, we would like to also to understand how their distribution really comes from. Now, if you will notice, for every facet joint, there are actually two nerves. So it represents by the descending branch or medial branch of one nerve above it, and then, of course, the branch that goes from the same level. So what is the implication of this? The implication is that if you are trying to block a medial branch block of that particular level, it is important to do it two levels, always. The reason is there's a descending branch that comes from the level above it. If you only do one level, you'll not be able to get a complete relief of that area which you are trying to target, because you're only injecting one level. So it's always important to do it two levels, one level above it, and of course the level that is at the same area of that nerve, especially if you are doing an injection of that branch of the medial branch. Then, of course, you have to realize that there's a lot of arterial areas on that side, so it's always important that you do Doppler. Especially if you're using an ultrasound, it's always nice to do a double view. So you have one side where you can see the needle approaching the area of target, and you have another side where you can see the Doppler while you're approaching the site. That is to protect you from puncturing into your blood vessel while you're trying to approach it, because you cannot avoid sometimes puncturing, especially vital structures, in the process of injection. So the W would be very helpful. So if you're ultrasound, if you're buying an ultrasound, make sure you have that feature. You can ask that from the vendor, and then ask them, do you have this feature? And then if they have that, then that's a good time ultrasound. And then, of course, as I've mentioned earlier, when we do scan, of course, it's not a completely transverse view. It is usually oblique to be able to see exactly what are the structures that you see when you actually apply an oblique view, and then you approach it depending on that area. We will do the demonstration later on. And of course, the lumbar nerve root, as you can see here, that's there is a waist of the particular nerve that you are targeting, and then of course it is usually located between the superior articular process. That's a nerve root. Usually, if you do it in the longitudinal view. And then, of course, the role of transformal and rotating ligaments and nerve root compression is also explained by the fact that that could also compress the nerve that's exiting in the spine. And so it is always important to also identify whether there are any structures that gets in the way when you do your injection. Now, for those of you who are really fond of injecting this, for example, there is what we call the Cumbins triangle. This is an area where there is nothing there that will get in the way. It's safe. In other words, the nerve is above it and the disc is below. So sometimes you get into that area just to access the disc posteriorly, for those of you who are doing that. But I'm sure not all of you are doing that, so, but just an added information just in case you are doing that procedure. Okay, so for selective nerve root injection, okay, this is an L5 area, so I go through just below the facet joint and into your nerve root area. And then, of course, for the spinal ligaments, I know this was discussed very well early, so probably I wouldn't anymore discuss this very well because it has been discussed already. But another source of pain that we usually missed all the time is the iliolumbar ligament. This particular ligament is always mistaken for an L5, L4, L5 problem because they thought it's on that area between your sacral bone and, of course, your L4, L5. And then there are two branches, one that comes from L4, one that comes from L5. And so this area is very important, especially for rehab people, because this is one area which is usually is found to be very tight, and that could also cause limitation of motion, but at the same time pain. And that is why it is always important to image this area. And for us, we either do prolotherapy, okay? It's not the neural prolo, it could be the real prolo, which is 15 to 25% of your dextrose water. Or if you are using neural prolo, you can just use 5%. And then, of course, the approach here, okay, would be directly on the site of the iliolumbar ligament. It's always important to consider this as one of the pathology, because as we have explained to you earlier, not everything could be explained by the presence of disc problem, by the MRI. So it's always good to go and look at the ligament as well, because this is also a source of pain that could be generated with low back area. So this is an example of a patient being treated by PRP at the iliolumbar ligament. You can see that on the, I think on your left side, that is the pre-treatment, and the area is very diffused. You can hardly see the pattern of the ligament itself, because it's usually hypoechoic, but at the same time, there could be fatty infiltration as well. But on the post-treatment area, you will notice that it's very distinct. The striations is very distinct for post-PRP treatment at the iliolumbar ligament. So this is usually very helpful, and you have to mention to be patient that it will be painful first before it gets better. Don't forget to mention that, especially if you're doing your PRP treatment, because most of the time it's really painful first before the patient will experience relief. Then, of course, sacroiliac joint. Now, the only thing that I would like to add here, I think TD gave a nice lecture on this, is that there are two segments of the sacroiliac joint. There is that fibrous layer, which is above, which is very thick, and it's not a good place for injection. So you go lower, which is articular. In other words, there's an articulation, there's a joint below. That is the very good site for injection. That's where you have to inject. Because if you go higher, very tough, your needle might not penetrate the area. Whatever you do, it will be very difficult to puncture it with your needle, especially if you're using gauge 23 or 21, very difficult. So you go below because that's where the joint is located, and that is the best site for injection for your sacroiliac joint. Otherwise, if you go higher, it will be very fibrotic, very fibrous, and it's very hard to penetrate the area. Okay, so here is your spinous sacrotuberous. This has also been explained very well. Okay, this is just an approach of the sacroiliac joint. Okay, you will notice that the reference is always the posterior superior iliac spine, and then of course cervical foramen is also located more medially. So make sure that you don't inadvertently inject the sacral foramen, but instead go to the sacroiliac joint. So caudal epidural injections, okay, maybe not very useful for you. I just included it. Of course, for our anesthesiology patient, this is what they use to block, which is the lumbar plexus block or the psoas compartment block. I will not talk about this more because I know this is a little complicated for you. I'll just skip this. But I'm going to go through the nerve itself, which is also the source of pain. Okay, usually my approach has always been to identify whether I'm dealing with a radicular versus non-radicular. And what I mean by that is, when I say radicular, is it has a lumbar spine component. But when I say non-radicular, it is a pain that doesn't necessarily comes from the spine, but is coming from the nerve after exiting the spine. Okay, I hope that definition is clear, because sometimes when we ask the patient, and the patient would say, the pain is not in the lumbar spine, the pain is below the iliac crest. And so sometimes we still think that pain below the iliac crest is still radicular in origin. But most of the time, the pain below the iliac crest is really non-radicular. It really has its own problem. It has its own identity, and not related to the father, which is the lumbar spine. Okay? So now, the reason why it's important is because those areas below the spine, especially below the iliac crest, I would say call that, has its own nerves that could be compressed and cause its own problem. A very, very common issue that I always notice is a pain that is just below the iliac crest. And sometimes very hard to say, oh, this could just be a referred pain. Okay? And so we try to find ways of explaining that is related to the lumbar spine. And we thought, especially if there's an MRI findings, that, oh, you have a disc bulge, you have a disc herniation. So probably this is coming really from the lumbar spine. But let's allow ourselves to also investigate what is happening below the spine. So maybe we could see findings that might open our minds and find out. Okay, so here, the superior cluneal nerve is the most common site of this injury. And the more common areas, because there are three of them, the medial, part of the cranial nerve goes through a fibrous tissue, and it usually happens when we see patients, especially if we extract the history. The patient will always tell us like this: okay, my work as a laborer would lift an object like this and rotate this way. So lift, rotate, lift, rotate. And that is exactly the mechanism of injury of this particular nerve. Because when we rotate as we lift, that superior clonial nerve is tractioned from the fibrous tissue on top of the iliac crest. And when we try to palpate that area, most of the time the patient will say, ah, that's where the pain is. This is where you can use the ultrasound. And to me, that is a very valuable tool to identify that particular nerve, because those three nerves are not visible. Only the medial clonial nerve could be seen clearly because it passes through a fibrous tunnel and it perforates in a way that goes all the way down to the erector spinae. So it goes like this. The origin is L1, L2, L3, but it digs deep into the erector spinae and goes up to L1, L2, L3. So the anatomic location of the superior clonial nerve is very, very susceptible to that kind of mechanism of injury, such that this is really a common problem. And guess what? If you treat that well, the patient's pain is just gone. And you will be surprised why that simple treatment would just remove the pain. Of course, Dr. People here gave us a lecture on the mixture of steroids, which is a very good steroid. Thank you for the combination, Dr. People. We know her secret already, so he has no secret anymore. Okay. In our case, our secret is 5% water, dextrose water. Is that expensive? Not very expensive, right? All you have to do is to inject the 5% water on that side, and the pain is just gone in 5 minutes or 2 minutes. Alexis is nodding his head. Did you try that? Okay. Expert si Alex dyan. So, and then of course, if you want to image that ultrasound, we're gonna do it for you later. Maybe when we do the scanning, and we'll show you how that superior clonial nerve looks like on ultrasound. And of course, that is one of the more common site. And of course, the symptoms is 1.6% to 14% has a prevalence of T12 to L1, and of course 50% with leg symptoms, lateral leg. If you look at the symptoms, it almost looks like a radicular pain, right? Because it also has a lateral leg pain. In other words, the pain is here, but it goes all the way to the lateral leg. So what can you say? It's basically a radicular component, right? But it's also a symptom of superior clonial nerve. So I'm just trying to confuse you so you will think more. Okay? So by ultrasound, this is how it looks like. So it digs deep up to the iliac crest, goes down all the way to the erector spinae, and you can see that pattern of the superior clonial nerve. And you can also see when it's swollen and when it's not. So you can compare right and left and see what's going on with the nerve. And you can see how it looks like when there is a problem. Now, another very common is superior gluteal nerve. Have you thought about that nerve? This nerve is very interesting because by ultrasound, this is located between your gluteus medius and gluteus minimus. We'll show that to you also in the scanning. And it innervates the piriformis muscle. Now, the triad of this patient has buttock pain, hip abduction weakness, and tender area and deep gluteal palpation. So if you look at the pain, okay, use your finger, point the pain. He will just point it right at the lateral side of the buttock area, and that's exactly where your superior gluteal nerve is located. If you image that part, you will know, let's say, any nerve there except superior gluteal nerve. That's the only nerve present there. You will not make a mistake. That's the nerve. So that is your superior gluteal nerve. Now I'll show you here. Okay, of course this is a hydrodissection of the medial clonial nerve right at the fibrous tunnel on top of the iliac crest. That is the bigger part of the superior clonial nerve. And I'm going through the area, not inside it's not really inside the fibrous tunnel, but on top, right into the erector spinae. So you kind of hydrodissect that part, and that's exactly how it looks like. Now, superior gluteal nerve, that's the area where the pain is. You notice that? That's almost like below the iliac crest, and the symptoms goes all the way to the leg. So the question is, have you ever thought about that? That's a question. Because if you have never thought about that, maybe it's time to think about looking at this structure, because it might just change everything that you're thinking about, the cause of back pain. And then, of course, this is the site, the superior gluteal nerve site, okay? That's between your gluteus medius and minimus. And then, of course, how do you approach it? Of course, this is a hydrodissection between your gluteus medius and minimus, approaching the superior gluteal nerve. You can see it's really on top of the iliac fossa. Okay? Now, this has been lectured early on, so the only thing that I'm gonna say is that there is a suggested normal value of the sciatic nerve, which is between your 0.52 plus and minus 0.028. So that's a suggested neural value. It doesn't always come the same way as the rest, but at least you have a suggested neural value. So you can compare the right and the left to find out where is really the inflammation. Now, the other thing that I'm gonna just mention here is that we always think about that area to be a piriformis syndrome, but don't you know that only 6 to 8% are piriformis syndrome? So in other words, we sometimes over-diagnose things because we thought it's piriformis syndrome, but again, just to remind you, it only represents 6 to 8%. And sciatic nerve impingement along its course, or what we call sciatica, is 43%, or the range is 13% to 40%. So in other words, we really have to see what is happening down there. It's actually part of the syndrome called deep gluteal pain syndrome that was mentioned earlier. And it's important that we just have to look into that area. So now this is a picture of the piriformis syndrome attached to the sacrum and the greater trochanter, and underneath is your sciatic nerve. So you can see the piriformis syndrome sliding, and it will also help you find that. And of course, in this area, of course, you will also see how these nerves is related and could be compressed in what position, especially sciatic nerve in the deep gluteal pain. And so you can see here all the muscles that was discussed earlier. I'm not going to do that anymore. And then, of course, how interventions could be done on different areas. So this is like between your quadratus femoris and inferior gemellus, where the sciatic nerve is just right on top of that. Okay? We'll do more of this later. And then, of course, just also to mention to you that there are two branches of the perineal branch. We always thought that the perineal branch is just coming from the sciatic nerve, but there's also a perineal branch coming from the posterior femoral cutaneous nerve. So two of them. So which is which? So the perineal branch coming from the posterior femoral cutaneous nerve, and the perineal branch coming from the sciatic nerve. So two. And the two nerves has different distribution. Of course, we also have gone to the point where we have to find out also the posterior femoral cutaneous nerve, which is a distal branch of the inferior cluneal nerve. So it's very interesting that these nerves also, the landmark that I use more often is the gluteal fold. You just go to the gluteal fold, that's the area of the inferior cluneal nerve. And the same area for posterior femoral cutaneous nerve. Okay, so much information here, but just to make you understand that there's just a lot of variations that's happening here. So, okay, and then of course, we'll go to the pudendal nerve. The pudendal nerve is very interesting because this is one nerve that is usually misunderstood. And as has been mentioned earlier, it is just between your sacrotuberous and sacrospinous ligaments. And the reason why this has been misunderstood is because we thought this is the one that goes into your labia majora and controls all of these things in the reproductive system. But actually, the pudendal nerve is a nerve that also causes a lot of pain at the medial side of the gluteal area, which doesn't necessarily going into your labia majora area. So 4 areas of entrapment. Of course, the most common is the Alcock's canal. This is where you can find the sulcus spinous and sulcus tuberous ligament entrapping the pudendal nerve. And you can also see this in the imaging later on. And this is one of the more throbbing and painful, because the reason why it's throbbing is because it goes with the pudendal artery. It's always almost beside each other. So when there is pain in this area, you feel like there's throbbing pain at the same time, because they are very, very close to each other. And then, of course, for pudendal neuralgia, it only represents about 4% of patients with chronic pain, and it could affect sitting and sexual activity and may cause dyspareunia and perineal pain and some painful bladder syndrome as well. If you scan this, it's usually seen at the edge of the iliac ischium, I would say. So you look for the ischium first. At the medial edge of that would be your pudendal nerve. Now, of course, we have other issues like degenerative disc disease. We have already mentioned that the bulges in the lumbar spine could not be explained merely by the anatomical problems, but it could also be explained by the presence of biochemical components, which are with what I mentioned to be your pro-inflammatory cytokines present in the spine. And of course, the broad-based disc protrusion, extrusion, sequestration in 75 to 100% resolved without treatment. And at the same time, there's the NGF, which could promote nerve ingrowth into the disc and sensitize dorsal root ganglion and may cause peripheral sensitization of the area that is causing pain. Now, degenerative disc disease, okay, 40% of patients with chronic low back pain, and the return to work is about 67.7%. So, just for added information, and of course, these are the different biochemical basis for diagnosing the degenerative disc diseases. There is what we call the fibronectin aggrecan complex, which is the most important component here. The reason why this is important is because if you are positive for FAC, those are the patients that respond with steroids. So if you are FAC negative, even if you inject with steroids, usually it doesn't respond, and you wonder why. So one of the things that is best to do is to first find out if it is FAC positive or FAC negative. If it's negative, don't do steroids. It won't work. If it is FAC positive, then steroids would work. And then, of course, there is also what we call the cartilage oligomatrix protein, which is part of the cartilage damage that is seen with the presence of disease affecting your cartilage, but at the same time, any cartilage in our body. And then how it works in terms of the treatment is, of course, in my case, I do a lot of alpha-2 macroglobulin intervention for spine especially. And the reason is, it is the more effective that I found out to be working against the pro-inflammatory cytokines without any surgical intervention. Now, I'm not saying we will not reach that point, but there is a point where it is important to do and decide whether patients are good candidates for surgical intervention or not. And so the pearls here is that structures in the lumbar spine should be assessed very well. And as I've said earlier, history taking is still very important. Even if you don't like to really listen to our patients and really find out what's the cause, very, 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 very important part of the assessment is really history and physical exam. You wouldn't make a mistake. And your imaging modalities would just assist you. The MRI would just assist you. Your ultrasound will assist you. All of this would just assist us. And hopefully, This will change our mindset on how to approach our patients with low back pain. And thank you very much for your kind attention.
Thank you very much, Dr. De Castro, for that wonderful discussion. Your expertise and clear explanations deepened our understanding on the underlying mechanisms of this common yet complex condition. For our next speaker, it is my honor to introduce a distinguished expert in the field of pain management and rehabilitation. She will be delivering a lecture on ultrasound-guided procedures for the pelvis and hip, a highly relevant and practical topic in today's clinical practice. Our speaker is a lecturer at the Department of Physical Medicine and Rehabilitation at Samratulangi University and currently serves as Program Director of the Pain Management Network. She holds 2 master's degrees, one in medical nutrition and another one in sports and physiology, both from Padjadjaran University in Indonesia. Beyond academia, she is an accomplished pain specialist affiliated with the Bandung Pain Rehab Center, PIK Pain Rehab Center, and Kandu Pain Rehab Center. She is also the author of numerous books and chapters focusing on pain management and interventional techniques. Please join me in giving a warm welcome to Dr. Teresia C.T. Novi as she shares her expertise on ultrasound-guided interventions for the pelvis and hip.
Thank you for the very warm welcoming speech. Dear professors and doctors, mabuhay. Selamat sore. In Bahasa, it means good afternoon. My colleagues there in Indonesia send very best regards to you all. And I'm very happy to be here again with my dearest family here in Manila and Philippines. This is my 6th time here. I'm very honored to be here. I met Dr. Jojo again, Dr. Mona, Dr. Dorothy, Dr. Tidi, all my very dear friends since long time ago. So first, I'd like to thank you all for having invited me again. Okay, this is my slides. Actually, it's a bit overlapping with the other lecturers, but it's okay. I try to talk about something that maybe hasn't been delivered before. May I borrow the mannequin over there? To let this go from the no, at the front it's okay. How to take it off? I haven't slept, but Dr. Dorothy said that I'm pretty, thank you, because of the lipstick. What is this? Sorry, some of you are orthopedists and the others are rehab, right? And what is this? Sacrum. Okay. And here at the back, what is this? Lumbar spine. So from the lower part of the costal until the gluteal fold, it's called the lower back. The pelvis is only here, the area of the ilium, the sacrum, and all inside it. It's called pelvis. And hip is this one. Hip joint is the joint in between the head of femur, which is this, and the acetabulum. Acetabulum is the round structure like ball that will fit to the head of femur. So it's like a keyhole and it's key. It's very congruent to each other and it's very stable. So talking about the hip, slide please. Slide please. Okay, this is Indonesia, slide please. This is my daughter, he's not well now in her room. Yeah, it's beautiful, like Philippines, it's similar, right? Slide please, slide, it's me. I have nothing to be disclosed, slide please. Hip joint, and then next, okay, next. You all know all about this now. Previous slide please. So talking about the hip, we want to inject something to the hip or the area around the hip. So we treat pain that's suffered by the patient. So how can we inject? The TD, Dr. Jeremy has given the lecture about that the main problem is how to make the diagnosis. So talking about the hip, is the source of the pain coming from the hip or from the greater trochanter, the piriformis, or from the facet joint, or from the sacroiliac? We must know first what is the function of the hip. The hip function, can you raise your hand? I believe you all know already. What is the function of the hip? What is this? Flexion, abduction, adduction, external and internal rotation. And each of the hip is done by certain muscle. Okay? Hip flexion is done by iliopsoas. Extension is done by glute max and so on. Abduction is done by glute med and its friends. And adduction is adductor. External rotation, yes, piriformis and so on. And internal rotation, the slide, the previous slide. Okay, that's why. Okay, so when we have the patients, we must ask the patient to move that part so we know the source of the pain coming from that structure, not only the hip joint. If the hip joint is the problem, the pain should be all the way, all the movement, flexion, extension, adduction, internal and external should be in pain. So we know about the Thomas test, right? The Thomas test should be positive, but should be here at the hip joint. If we ask the patient to do the Thomas test and the pain is felt at the back, maybe it's not the hip joint. If all the movement cause pain, maybe it's coming from the hip joint. Then how to do the injection? Slide, please. Next. I will not talk about too much about the anatomy. Next. This is about the test. Next, we'll go back to the test. Next. We want about the hip. Okay. If we have the diagnosis of hip osteoarthritis or rheumatoid arthritis and we want to inject it, how to approach it is by taking a line, imaginary line from the SIAS. This is SIAS to the pubic bone here, divided by 3 and put the probe obliquely like this. Imaginary line from the SIAS to the pubic bone, divided by 3, take the 1/3 lateral and put the probe obliquely like this, and then slide please. You will find a structure like this. Here, you will find the humeral head here, because you see the configuration of the neck femur. If you put the probe like this, we'll see the acetabulum first here, right? Acetabulum, and then we'll see the head of femur and the anterior recess. This is the side where we want to put the needle in plane from lateral to the medial side into the anterior recess, and we can hopefully heal the hip joint pain. Okay, next slide please. Okay, and then if the pain is felt at the greater trochanter area, where we felt the pain, not always that the source of our pain is there. So it can be referred from other side. It can be referred from the hip joint. It can be referred from the sacroiliac and else. So we must make sure that the source of pain is there in the greater trochanter. Dr. Tidi has already mentioned before. We have three main structure here at the greater trochanter. We have three facets. Okay, these are the facets. We have here, maybe will be easy for you. Here is anterior facet. Can you see it? And then at the mid is medial facet, and the posterior is posterior facet. At the anterior facet, we'll insert the glute min, gluteus minimus. And at the medial facet, we'll insert the glute medius. And at the posterior side, we'll insert the gluteus maximus. So what happens if the glute med is injured or inflamed? The function is to do abduction. So abduct the leg, and there will be pain, and the pain should be felt here. Not here, not here, not other. Okay? And then you can do other tests. One leg stance test. Do at the healthy side, it will be okay. Do it at the injured part, it cannot stand on the injured side. So, means that probably the site of target of injection is the medial side of the greater trochanter, which is the insertion of the glute med. Next slide please. We put the probe transversely over the greater trochanter like this. It's not easy. You must do cupping technique over the greater trochanter like this, because it's big, and then put the probe at the middle of the round structure here, transversely like this, and then you will see the image. Slide please. This is the anterior side. It's 10. This is a straight, and then round, and then straight again. Means this is the anterior facet, like the glute minimus, and then at medial facet we lies the gluteus medius, and then side glute max. Depends on whether the glute minimus or glute medius or glute max is inflamed. We insert the needle in plane. This is the subgluteus medius bursa, and this is the subgluteus maximus bursa. Mostly happens to the gluteus medius, and when it is inflamed, it will be filled with fluid collection. We will see it black. Okay, we cannot see anything. So, if we are sure that it is glute medius tendonitis, but we cannot see anything, we can do diagnostic block. Yes, you are right. Put the needle here, and then give 1 cc of lidocaine 1%. Withdraw the needle. The pain should relieve at least 50%. Yes. Then put the medication. Okay. Next. And then about the other structure. This is flexion. This is abduction and adduction. Hip adductor tendonitis. Adductor muscle will do the internal rotation, okay? So if it is, slide please, if it is inflamed and it becomes tendonitis, the simple way to assess it by asking the patient to lay down and do squeeze test. Lay down and put the knee flex 90 degree, and then put a ball in between the knee and the ball, and it will be painful, and it will be felt here at the insertion of the hip adductor. Hip adductor consists of three, the main hip adductor, which is Alabama, adductor longus, brevis, and magnus. Just follow, put the probe here at the CS, and then follow the inguinal line. We will see, slide please. We will see at the lateral side here, we will see first the Cias and then Sartorius, and then we will see the Iliopsoas muscle. This is the femoral head, and we go further to the big area. We will see here pectineus muscle, and then we will find the breast of adductor. Okay, and then next slide, please. So this is pectineus. This is from the other side. This is medial side. This is lateral side, and this is the adductor muscle. We'll insert into the pubic bone here. So aim the needle here, and medication that you want to choose. Easier, right? Next slide, please. Next slide. Here is the image of the needle insertion. So put the needle from the Cias obliquely to the pubic bone until you find the Alabama. Okay, next slide, please. Piriformis has already been before already. So should I skip it? Yes. Dr. James has already mentioned that it's often been overdiagnosed, but very frequently it's underdiagnosed as well. So all the back, all the hip and the pelvis has very similar signs and symptoms. Cannot sit, cannot stand, cannot walk because of pain, right? So how can we make confirmation that it is piriformis muscle? We can see when the patient muscle tendonitis or sacroiliac joint pain, when he sits like this, if the left side is injured, then he will sit like this. He doesn't want to sit on the injured part. That's one. And then the second one, try to ask him to stand up. If stand up is painful, sit down is painful also, the process of movement is painful, the probability is piriformis or sacroiliac. Piriformis or sacroiliac? Probably the joint. If movement causes pain, the first difference diagnosis is joint, maybe the sacroiliac joint or the facet joint. So then we must make confirmation by the other provocative test. Piriformis is to do external rotation, right? So do external rotation. Piriformis test should be in pain, and we resist it, more pain, and the pain should be felt here. Okay, and talking about the low back pain, that's in bahasa Indonesia it's called jembatan keledai. Jembatan keledai is what is that? Something that we use to make a simple conclusion, but it's not always true. So we put the patient in prone position. Prone position. Okay. So if the patient can do prone position, we press the back of the patient. Okay. This is PSIS, right? If we press it here and the patient felt pain, maybe the pain has sacroiliac joint pain. Okay, and if we press it here and there is pain here, maybe the pain is coming from piriformis syndrome. If we press it here at the middle, this is spinous process, right? It's near to the facet. So if we press it here and the patient feels pain, maybe the source of pain is coming from the front. The front is the corpus, right? Vertebral body. Maybe there is fracture or something, or facet bilateral. Bilateral facet is in pain. So make confirmation. Press it 1 finger breadth from the midline. Press it. If it is in pain, check at the other side, because the pain is felt in the middle. Should be bilateral. But if the middle is not painful, then press at the lateral side, paravertebral area. Okay, morpholateral is the site for pain of the root. Okay, so this is SI joint pain, this is piriformis pain, this is for vertebral body or disc pain, and at the more lateral pain is facet pain, and more lateral is the nerve root, and more lateral is all myofascia, right? And if we press it here, what is this? Ischial tuberosity. What is inserted here? Hamstring. Okay, so hamstring, the function of hamstring is to do extension of the hip. Ask the patient to extend the hip. Should be felt pain, and the pain should be felt here. So it's easy. If we have a patient like that, piriformis muscle first. So it's felt here at the piriformis tenderness point area, and then we do piriformis test in pain, resistant and painful, and then probably the pain is coming from piriformis. We take the ultrasound. Next slide, please. Here, next slide, please. We put the probe here. How to find the piriformis muscle? Find the PSIS. We have venous dimple here, like this. You know, venous dimple here. We have venous dimple here. Put the probe there. It should be correlate with the PSIS. PSIS, put the probe transversely, and then we put the probe, move the probe to the lateral side. We will find the ilium, right? Okay, this is the ilium. Okay, after the ilium, we maybe cannot see the ilium very clearly because if we put the probe like this, the configuration of the ilium is sloping to the anterior side. So we must put the probe like this. Do it twin in, so the beam of the probe will be perpendicular to the iliac bone, okay? And then we will see the sloping of the iliac bone here, and we will find 3 layers of muscle: glute max, glute medius, and glute minimus. This is the sign that we are at the gluteus medius area. This is the superior gluteal artery, vein, and nerve. Okay, so put color so we can see the blinking of the vessels there, and so we know this is the glute med, and then translate the probe further until the ilium breaks. This is ilium, right? After we move downward a bit more, the ilium will break. Slide, please. And then we will see this one, above it, the piriformis muscle. Once the ilium breaks, it is piriformis. Because if we go down further, very frequently we want to check the external rotation of the hip, right? Put the patient in prone position, then flex the knee, and then rotate internal and external rotation, and the muscle will move. Below, there will be gemellus superior. Below it, there will be rotator internus. Below it, there will be gemellus inferior, quadratus, and all is external rotator of the hip. So, do not mistaken with the other. Once the ilium breaks, it is the piriformis. Okay? And then, measure it from here to here. The thickness of the piriformis, compare it with the healthy side, should be bigger than the healthy side if it is in acute condition. But if it is chronic already, very frequently, the thickness is bigger on the healthy side. So if we are not sure, again, the diagnosis block. 50% reduction, we are correct, give the medication in plane from lateral to the medial side. Okay, right, please. And other, okay, ischiocrural. Ischiocrural is the ischial tuberosity is the insertion of the hamstring. So if we extend the hip, the pain will be felt here. Next slide, please. Next, please. It consists of hamstring, 3 tendons. What is that? Bicep femoris, semi-T, and semi-Mi, right? Okay. Slide, please. And then we are sure, next slide, please. We are sure that the pathology is from the ischial tuberosities is called like that, right? So put the probe, continuing the piriformis muscle, okay? We continue downward, go under and until we find the ischial tuberosity here, stop. Because if we go further, we will find no bone anymore. Go back until the last bone, where we find here is the hamstring. Insert the needle. If I work from here, insert the needle in plane. If I put the probe transverse like this, in plane from lateral to medial side to here. Easy. Okay. Next slide, please. Slide, please. Any question? Okay. Before we talk about the piriformis muscle, the landmark, the home base. The home base is the PSIS, right? And then if I want to inject the sacroiliac joint, the same. Put the probe at the venous dimple here, okay? And then we see, next slide please, next slide please, next slide please, next slide, next slide, next slide. The test for the sacroiliac joint is a lot, right? What is this? Patrick. Okay, Patrick. And then you can name it Yeoman. You know it already, okay? Pelvic rock and so on. Should be in pain, but not always. Okay? Next slide, please. So, previous slide. If you are sure, okay, this is the PSIS. Put the probe like this. Okay. Before, if you want to scan for the piriformis, you move the probe to the lateral side. If you want to scan the SI, move the probe to the medial side. Okay. If we move the probe to the medial side, we will find the PSIS and the spine. Okay. If we go down further, we will find the sacrum. This is sacrum. This is PSIS, and we go down further because the gap in between the PSIS and the sacrum is not the joint. You can see it. It's not the joint. So we must go down further until, slide please. Go down further, go down further. Means slide please. Before? Oh, only that. Okay, sorry for that. We must go down until there's a line connecting the ilium and the sacrum like this, and there's a small gap in between, which is the sacroiliac joint. So we insert the needle from medial side to the joint. Once we see two lines with a small gap, but do not confuse with the S2, because if we put the probe like this, we see there is S1 here, and if we go down further, we will find the S2. Okay, SI and S2 is close by. Do not enter the wrong gap. The gap is at the lateral side. Insert the needle from medial side to lateral side, because the ilium cover the sacrum. Cannot be approached from lateral to medial side. Okay? This is for pudendal nerve, already mentioned by Dr. TD and Dr. Jim. I skip it. Slide please. Slide please. Slide. Slide. I think it's done. Slide. Go, go, go. Go. Go, go. Hamstring already. Right? Slide please. Slide. Slide. Slide, 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 slide. Cluneal nerve is easy actually. You put the probe here at the PSIS. This is iliac crest, right? Put the probe like this. There's fascia, right? Just enter the needle from lateral side. just above the iliac crest, and it's done. But we must be sure that the diagnosis is the cranial nerve entrapment. Slide, please. Slide. Slide, 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 slide. There's superior, slide, please. There's medial part. The medial part is coming here. We have the PSIS. Once we have the PSIS, just like we want to scan the SI, rotate the probe 90 degrees until we find the S2, S1, and S3, and then insert the needle from either from the caudal side or from the superior side to hit the complex of S2, S1, and S3 where the cranial nerve middle part coming from. Slide, please. Slide, slide, slide. Okay, but so then we may have a lot of pain patients and we may be able to do the scanning, but the scanning is nothing if we don't have the diagnosis. What for? What is the use for caudal? What is the use for piriformis injection if we do not know the diagnosis? So previous slide, please. So diagnosis is very important. The key is diagnosis. The second is diagnosis. The third is again the diagnosis. And just like TD and Dr. Jim has already said, do not treat the picture. We must be sure of our own diagnosis. If it doesn't match with the finding of the MRI or ultrasound or X-ray, be sure of ourselves. If we cannot be sure of ourselves, then do diagnostic block. That's the easiest way. And every patient is way specific. The treatment should be tailor-made, and we should follow the step-ladder pain management. Not every patient needs injection. Maybe exercise only. Very frequent low back pain patient can be by exercise. Okay? And preventive and promotive medicine is very important. After doing the injection, should be the patients be given education. What is happening? What is the cause? Okay? What should be done afterwards? Maybe she or he has to do exercises or improve the walking habit and so on. So the pain will not coming back too soon. Okay. Next slide, please. This is my book. If you are pleased, you can have it. Next slide, please. And this is my usual training program. You can follow us on Instagram only also. Slide, please. Okay. Hebat, in bahasa hebat is wow. But yeah, this is me. Only like this, okay? Slide, please. Slide, please. There's ultrasound guided injection workshop, also CM guided injection workshop. You can ask us if you are pleased and want to join us. Okay, thank you. If you have questions, please feel free to ask.
Thank you very much, Dr. Novi. Your expertise and clarity provided valuable insights that will surely enhance our clinical practice. At this point, may we call back Dr. Teresa C.T. Novi. So from the Pain Management Network, they would like to award this plaque of appreciation to the Department of Rehabilitation Medicine, University of the Philippines, Philippine General Hospital, the University of the Philippines College of Medicine, Department of Anatomy, to Dr. Rafael Bundok for collaboration in pain management education for a world free from pain. We award the same certificate of plaque of appreciation to the Department of Rehabilitation Medicine, University of the Philippines, Philippine General Hospital. Sige. Okay, so for the picture, maybe call again Dr. Rafael Bundok and Dr. Teresa C.T. Novi. Thank you once again to our previous speakers for their presentation. We now move on to the next segment of our program, a live demonstration. Do we have any questions from the audience? Dr. De Castro and Dr. Novi? Anyone? So if none, we now move on to the next segment of our program. So this is a live demonstration on lumbosacral ultrasound. So this session aims to translate theory into practice, highlighting key anatomical landmarks, scanning techniques, and clinical application relevant to our daily work. So for those of us who are wondering why this is called Muscle 2, it's because we have the first muscle last year, and this was one of our points of improvement to better appreciate or to better maximize our experience with the cadaver, which is to have a live demonstration of the ultrasound, so that we would be better appreciated tomorrow during the cadaver injection. So we'll have a brief orientation. Okay, so you will be grouped into 4 groups. So we have 1, 2, 3, and 4. So please take note of your name. So we have 4 stations. Group 1 will be here at the demo unit in front. 2 will be on the right side of the room. And then 3 and 4 on the left side. So for the first part, we have a 30-minute live demonstration of the following lumbosacral structures. So these are the things that you will have to see later in your in your own groups. So for our facilitators, may we call them here in front to acknowledge. So we have Dr. Jamailo De Castro, Dr. Teresia C.T. Novi as our roving facilitators. And then we have Dr. Therese Dayan Estrada, Dr. Jeremy Flor de Lis, Dr. Rochelle Saratan, Dr. Ronald Kua, okay, please come here in front to be acknowledged. So for the first station, we have Dr. Therese Dayan Estrada. Second station, Dr. Ronald Kua. Third station, Dr. Jeremy Flor de Lis. And fourth, Dr. Rochelle Saratan. So you may now proceed to your assigned stations with your facilitator, but please note that we're gonna have first a 30-minute demonstration here in front. For the first group, we have Drs. Cayetano, Espeleta, Tan, Leal, and Genuino. For the second group, we have Drs. Balaba, Lee, Navarosa, Kosing, and Banalili. For the third group, we have Drs. Domingo, Ray Matias, Barcelon, Mendoza, and Guto. For group 4, we have Drs. Abogado, Celis Agravio, Valera, and Sugitan. So you may now proceed to your assigned stations. But for the first 30 minutes, we're gonna have a live demonstration of the lumbosacral structures by Dr. Teresa C.T. Novi.
Is there volunteer here? Anton. Okay, Anton, how are you? Oh, okay, that's great. We need the patient to lay prone, okay, lay on your tummy with pillow underneath the abdomen, because we know that the lumbosacral area has lumbar lordotic, right? To make the patient more comfortable and to make the spine more straight, we need pillow underneath the abdomen. So put the needle here. Okay. Okay. Do you like the easiest part first? Maybe yes, right? Okay. So, can you pull down the pants? Okay. Okay, a bit more, more. Okay. Okay, now see the Venus dimple here? Can you see it? Dimple, right? I need curvilinear probe. Maybe depends on the depth of the structure that then we can see on the screen. May have, okay. From here. We need gel because our body consists of water, right? 60% water, so to make the beam can travel through the tissue, we need gel with this water based, okay? This is left side, my left side. But then on the screen, it's seen on the right side, so my direction is wrong. Left side towards me. So on the left side of the screen is the lateral side. And if I put my probe transversely over the Venus dimple here, we will see the, can I have pointer? Yes, pointer. Look, I put the probe at the Venus dimple, and you can see the white structure at the superficial one is the PSIS. PSIS is this one, right? And then at the lateral side, at the left side, we can see the sloping down of something here, which is the iliac bone, ilium, right? So, yes, you can have. And if you point the pointer at the right side, okay. Huh? Okay. So this is the PSIS, okay, and this is the sacrum. Because I put the probe like this, this is the PSIS, at the pedial side is the sacrum, and at the lateral side is the ilium. Ilium. Okay, this side. This is the PSIS, and this is ilium, and this is the sacrum. Okay. If I put the probe, the ilium is not clear. Clear, right? Okay. The beam is perpendicular to the iliac bone, and then we can see 3 layers of muscles here. Okay. Turn on the color, please. Somewhere here, you see the blinking of vessels, right? Okay. So this is the superior gluteal artery, vein, and nerve. So this is the gluteus medius, and this is the gluteus maximus, and below is the gluteus minimus. Okay. If I move the probe downward like this, I move the probe downward like this, you can see then the ilium at one point will break. The ilium will break. Here, the ilium, this in straight line, and piriformis is oblique like this, so I must turn the probe like this. Piriformis muscle. If we continue the muscle, it will insert to the greater trochanter. Okay, so this is the glute med. The ilium will become one line again. If we go down, it breaks, and that is the piriformis muscle. Okay, can you hold the? This is the piriformis muscle, big. You can measure it from here until here, and this is the sciatic nerve. Below it is the gemellus superior. If you want to make sure that this is the piriformis muscle, you can do the internal and external rotation.
Hello, hello.
If
Hello,
we go
hello.
down, it moves again. If I go down, is it correct like this? Okay, thank you. Okay, it's better, way better. Okay, so again, okay, this is the left side. From my point of view, now this is my left side, the lateral side, and this is the right side, okay? The right side means the medial side. If I put the probe at the kind of nipple, I will see the, what is this? PSIS. And what is this? The sacrum. And at the lateral side is the line of, can you move the bone here? Can you move the bone here? So imagine that I am put the probe like this. Oh yeah, okay. Okay, like this, okay? PSIS, sacrum at the medial side and ilium at the lateral side. Okay? If I go down, before I go down, I want to make sure that I can see 3 layers of muscle, which is the glute max, glute med, and glute min. There's blinking here something. Put down the color, please. Superior, gluteal artery, vein, and nerve. Okay. At the level of the gluteus medius, when I move the probe downward, release the color, please. Be mode again. Okay. At the level of this side, if I go down, once the ilium breaks, here is the piriformis muscle already, which coming out from the sacrum and insert to the greater trochanter. But the configuration is oblique, like this. So I must turn the probe oblique slightly like this. Okay, so this is my piriformis muscle. This one. From here until here. This is the piriformis muscle, and this is the sciatic nerve. If I go down further, and I think that it is gluteus, piriformis muscle is not piriformis anymore. It's already go down under gemellus superior, obturator internus, inferior, and so on, because if I go down further, can you help me? Go. I want to pull all, more. Okay, put some more gel here, please. Okay. Here is ilium, right? Once it breaks without turning on the color, I know this is piriformis and this is sciatic nerve, right? If I go down further, it's not piriformis anymore. If I do rotation, it moves, okay? And if I go down further, it moves again.
all moves because all is external rotator. So do not miss it. Once the ilium breaks, this is piriformis muscle. But make sure compare it with the healthy side. Okay, and then so this is this bone. What is this? This is ilium, right? This is ischium already. Okay, if I want to go down further, it is round, right? It is round. So if I go down, try find something straight. Straight, it is straight already. Once it is straight, means I am already in here. Okay, if I do twin in like this, I can see two lines, okay? Reduce the depth to 6. Okay, you can see two fibrous band here, which is sacrotuberous and sacrospinous ligament. Turn on color, please. Without turning on the color, we know that there is artery and vein of pudenda, where
So,
pudendal nerve is.
Sound check.
Freeze it,
Sound check,
please.
1, 2.
Freeze it, please. Okay. This is the pudendal nerve. Okay. So if have patients difficulty in peeing, pooing, and every having sexual intercourse is painful, maybe the problem coming from the pudendal nerve entrapment, you can put the needle from the lateral side, piercing the sacrotuberous ligament, and put the solution in here.
Just put this one microphone for
Oh
the
yeah, okay.
video. So it will clear. We're currently fixing the.
Oh, okay. So this is the site for pudendal nerve injection. Okay, and then if further, the bone will become round again. Thank you. This is round, right? And then if we go down, it is straightened, and we can see two tuberous ligament if we do the twin in like this. If you do not do the twin in, it's not clear. But if we do twin in, it will be clearer, and turn on the color, and then we can see the artery and vein and the nerve. And then turn off the color again. If we go down further, it will become round again, okay? This is the site for obturator internus. If you flex the knee, please, and do the internal-external rotation, please. Are you doctor? Yes? Yeah. Oh, thank you. You help. So that is obturator internus. Stop it, please. If I go down again, it's become tenting, right? Right? This is quadratus femoris. Quadratus femoris, if I go down further, the bone will disappear. And if I go back, once the bone appear again, freeze it, please. Okay, this is the hamstring. Put the needle here, from lateral side to the medial side in plane. From here to here. If you have ischial tuberosities patients, means raise your right leg with knee extended. Okay, painful, and the pain is felt here. You see the side of the gel, and the side of the pain should be felt here. Okay, so this piriformis muscle, pudendal nerve, ischial tuberosity, and then how about the sacroiliac joint? Again, we find the venous dimple. Venous dimple is here, right? This is the venous dimple, and this is the sacrum, right? This is not the joint. This is not the joint because the gap is only the gap. The joint is where the two bones is linking. So this part, the lowest part. So we go downward, From here we go downward, until like this. Here we have the ilium, we have the sacrum, and it's the gap, and the gap has lines downward, and this is line also. We have two lines here. Freeze it, please. Freeze it, please. The first line is the S2. The second line is the sacroiliac joint. And the needle insertion should be from the medial side to the lateral side, from here to this side. This is for sacroiliac joint. And then sacroiliac joint, piriformis, pudendal nerve, sacro ischial tuberosities, and then we go up to the lumbar area, okay? If we have radiculopathy, oh yeah, okay. If we have patients with numbness and tingling sensation at the lateral of the shin, okay, so it is L5, right? To the sole of the feet, means it is L5S1. So we have L5S1 at the right side radiculopathy. So how to approach it? We can approach it via the L5 and S1 foramen itself, or we can do it from the caudal epidural. How to perform the caudal epidural? May I have the linear one, please? Yes. For the piriformis scanning, if the patient is skinny, maybe we can use the linear probe, but for this man, we need the curvilinear one. Okay, so again, put the probe at the venous dimple. So the home base, I always call it home base, is venous dimple. This is, from my point of view, this is my left side. Okay, this is the PSIS, and this is the sacrum, okay? If I go to the middle, okay? If I go to the middle, we have the maybe L5S1 spinous process. You see here at the, this is real bone, right? So if I go down, this is the spinous process of the sacral crest, right? And this is all the muscles, right? If we go down further, we find the other sacral crest. If we go down further, we want to see something like this, which is called frog eyes. This is sacral cornu, this is sacral cornu here. If we go down, and then we find here, this is sacral cornu, and below it, in between, lies the sacral hiatus. And this is the caudal epidural. Caudal epidural, and the thick ligament here is the what ligament is that? Pardon? Sacrococcygeal ligament. This is sacrococcygeal. This is the short axis view. If we want to see it in long axis view, we rotate the probe like this 90 degree. Look. Firm, okay. Rotate, but this is for me, this is the correct position. From your position, maybe it looks weird, but in my position, it is correct because this is my left side. So the image is seen on the left side. This is the caudal epidural seen in long axis view. If I move further to the right side, it disappears. If I go back, it is seen again. If I go to the lateral side, it disappears again. Here is the good image. Freeze it, please. We can see that the, what is ligament? Sacrococcygeal ligament again. Okay, and this is the floor of sacral hiatus, and this is the epidural. Okay, and this is the sacral crest. So we insert the needle from caudal side, piercing the sacrococcygeal ligament, and stop here. Actually, this is bone also, but because of the position of the probe, it's not clearly seen. Put the needle here, hit the bone. When we find the bone, we are okay, we are safe. Because if we do not hit the bone and we go further here, what happened? We can go to the S3, S2, S1. Well, we know that the dura stops at the S2 or maybe S1 or maybe S3. So if we pierce the dura, means our needle tip is inside the dura. So we do subdural injection, not epidural injection anymore. So be careful, okay? Stop here. But we must make confirmation in the short axis view. So once we have this view, we can see the needle tip is here. Okay, reduce the depth to 3, please. 3. The depth. 3. Okay, once we see the needle tip here, rotate the probe again. Okay, the needle tip should be seen here, right? Just like we do fluoroscopic injection, at least 2 positions. Okay, and then if we see, if you go down, see, we can see the same frog eyes. If we go down further, we can see the same frog eyes. Do not enter the needle from this side because we want to make the volume injection. If we go from the caudal side, we need more volume to be reach the maybe L5 or S1. If we go from as close as possible to L5, S1, then we need only small amount of volume. That's the reason, because the more volume, it will cause maybe headache to the patients. Okay, but then we must make confirmation if you have confirmation with the fluoroscopy. If you use contrast, take 1 shot and you can see crystalline appearance, then you're okay. Means that you are not entering any blood vessels. But if you don't have fluoroscopy, just do long aspiration. Long aspiration and stop for several seconds, maybe 5 seconds, and nothing get into the syringe, no blood, it is okay. But not always there's no blood, it's okay. So make it slowly, okay? And then if you are puncturing the dura, actually the LCS will come out. And the color of the LCS and the color of lidocaine or dextrose or the dexamethasone is the same. So be careful, okay? So you must know the anatomy, know how to inject to make sure that you are safe for yourself, safe for your patient, okay? That's for caudal epidural. And then the next is facet. Any question later on maybe, okay? Facet. The lumbar facet, we have 5 L1 until L5 lumbar, okay? We put the probe like this. This is left side. At the middle, okay? This is the continuation of the caudal epidural actually. And then if we move it like this to the lateral side a bit. I need the curvilinear one, okay? Once the depth is more than 4 centimeters, we need the curvilinear one. This is left side. Okay. The depth, make it to 7, please. Okay. Sorry. Okay. This is the sacrum, okay? If I put the probe like this, in the middle, we can see the sacral crest, okay? If we go up, presumably, he has no scoliosis and the spine is at the middle, okay? If we are in the middle, I have already at the paravertebral area. We see already the bumping of each segment of maybe the lamina or the articular pillar, okay? So we count it. This is the sacrum and this is the L5. So this is the gap in between L5 and S1 and so on, L4, L3 and so on, okay? If we have, Dr. Jim has already mentioned before, we have the camel hump. This is the facet. This is facet. This is facet. We can see 2 layers of white structure, right? So we can approach to do the L4, L5 facet injection through this area, but it's not always precise by this position. If we want to more precise, we must rotate the probe in transverse view. This is L4, L5, right? We move it to the middle, and then we rotate the probe slowly. This is L4, L5, rotate, 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 rotate. It should be there, slowly, slowly. At the same position, this is L4, L5. L4, L5, sorry. This is L4, L5. Can you see it? Freeze it, please. Okay, so your hands should be steady. May I? Okay, thank you. So this is the L4, L5 facet. Okay, and this is the transverse process. And this is the shadow of spinous process of L4. And this is when we put the probe like this. Okay, what we see here is the space in between the L4 and L5. Okay, which is the interlaminar actually. Okay, and which means here is the ligament, interspinous ligament. This one is interspinous ligament, is thick. Okay, and then we can see through this hole is the vertebral body. Okay, this is the anterior complex. Okay, posterior complex, sorry. This is the vertebral body. And then this is the facet, and this is, what is this? Transverse process. So in this view, we can see already transverse process, facet, interspinous ligament, and this is muscles. What is this? Quadratus lumborum, areatus spinae. Okay. And here at the medial edge of the transverse process is the site of injection if we want to do the L4 nerve root injection. Just put the needle from the lateral side, hit the bone, stop. And if you want to inject the L4, L5 facet, put the probe in, insert the needle from the lateral side in plane into the joint. And if you want to do the erector spinae block, insert the needle from here to the lateral edge of the transverse process. And then it will cover the muscle of the erector spinae here, up and down. Okay. From this side, you can approach 3 injections. But then, you must be sure that you are in the correct position by turning it again to the long axis view. This, okay, this is L4, L5 facet, and this is transverse process. How can you know this is transverse process if below it is black like this? Because it is bone. If the beam hits the bone, nothing is down under. So if you do the injection of the medial branch, nerve root, medial branch. If you want to do the injection of nerve root, you should enter the hole. This is for the medial branch. Sorry to say the wrong name, okay? This is the injection for the medial branch. If you do the nerve root injection, you enter the hole, but just a half centimeter and stop. 1 minute left, okay? Then, if you do the medial branch injection, you must rotate the probe. Long axis view, slowly. You see, okay, you see this structure, okay? Don't get let go of this structure. Don't let go, don't let go, don't let go, don't let go, don't let go. Okay, and the needle tip should be here. You see? Precisely here. Because the medial branch lies in between the transverse process and the SAP, superior articular process, means at the superior side. So should be here, not here. This is transverse process, transverse process, transverse process. Okay? So that's all. Medial branch, transforaminal, erector spinae block, caudal epidural, and all. Okay?
Thank you so
Okay.
Thank you so much, Dr. Numi, for that demonstration. So
Okay.
you may now proceed to your assigned stations. We will
Okay.
project the revised list for the first session. So again, the first table here is table number 1. On the right side is 2, and then 3 and 4 on the left side. So for the first rotation, we have sacroiliac joint, piriformis, caudal epidural, facet joint, medial branch, interspinous ligament, and erector spinae.
Thank you.
Thank you very much, Dr. Novi.
Welcome. Oh yeah.
So we have 1 hour for this session.
Yay!
Will be
Kesini dari sana.
So we have around 4 to 5 members per group. So we have around 15 to 20 minutes to perform each participant.
Oh yeah.
We will be announcing 20-minute marks so that you're aware of the time.
Just on top of the transverse process, if you inject there, parang yung fascia niya maghihiwalay. That's the erector spinae block.
Okay.
Yan po. Sige. Next po. Okay.
Ma'am, okay lang po ba magkabit ng lapel para tignan lang po yung
I-record po yung i-discuss nyo for 20 minutes.
Okay. Sige. Saan tayo didikit? Dito na lang. Okay. Sige. Okay. Okay. Sige. So, okay. Sige. Saan yung ano mo? Saan yung this side?
Ay, sorry ba?
Yan. Okay, sige.
Left
So,
side is left.
sige. So, we'll start with the transverse view. So, this looks like your spinous process kasi it's a bone, it casts a shadow. Tapos, so if it's the spinous process, this one's your lamina. Okay, if you move a little downwards, you will see this one. This is your transverse process, and then your facet joint, superior articular process, inferior articular process. So since may nakikita ka dito, this looks like the interspinous space. So interspinous ligament siya. Okay, kasi so since hindi siya bone, wala ka masyadong shadow like, kasi may nakikita ka. Okay? So facet joint injection, tas dito yung medial branch. Okay?
I'm sorry, both angles po niya. Okay na po yung mga 45 degree.
Yeah. Oo. Yun. Nasa na yung transverse process. So here, okay? Be careful lang na, so if you're going to inject at the medial branch, you have to see it also in long axis. So the needle should be on the cephalad. So kung transverse to, ito yung cephalad, dapat parang nandito siya sa taas, not here. Okay? So yun. So since we're on this view, sagittal view, we start at the transverse process, okay? So your transverse process looks like a trident sign, okay? Erector spinae muscle, psoas muscle. You can inject here on top of the transverse process for erector spinae plane block or hydrodissection. erector spinae plane hydrodissection. Move a little medial, you will see your facet. So this is your camel hump sign. So facet joint. Tapos a little more medial, tapos naka-oblique, you will see your lamina. Lamina, interlamina. Tapos, so pag lamina, naka-oblique ka. Okay, yan, ganyan. Okay, horse head. Tapos balik ka ulit na straight. Tapos move median, you will see your spinous process. So na yung spinous process. This looks like the spinous process here.
Yes.
Okay? Sige.
Thank you po.
Next po. Sige.
Sige.
Sige. So, with the transverse view, yeah. So this is the transverse view. Okay? Yan. So, yeah. Sige. So this looks like your facet joint here. Pero can you show me yung transverse process? Sorry. Move up. Yan. This looks like your transverse process. So, sige. Hold. Stabilize up. Yan. Nasaan na siya ulit? Yan. Okay. So this looks like transverse process. So this is the area for medial branch. So inject here. Lateral to medial branch yan. Tapos this is your facet joint. So pag ganun, if you want to target. Tapos, yeah. And then this one looks like your interspinous space kasi may nakikita kang white. Yeah, but if you move more, nakikita mo yung nasa na yung spinous process. Saka yung lamina. Ito, this looks like the spinous process kasi may shadow. Tapos this looks like your lamina. Here, katabi niya.
Wala na yung white.
White above, yeah. Kasi siya, bone, so it casts a shadow. Yeah, sige. Tapos, can you turn the probe? Yan. So, we'll start at the, transverse process, so lateral, okay? Yan. So, here, walang bone. Tapos, transverse process, trident sign. Oop, stabilize ha. So, transverse process, trident sign. Erector spinae, psoas. Okay, so you can inject here on top of the transverses for the erector spinae plane block. Yeah. Yun. And when you do your medial branch, you have to see the needle on this view also kasi yung needle should be at the cephalad part of the, so kung ito yung cephalad, dito siya dapat yung needle mo. Yeah. Hindi ka pwede dito. Okay? Kasi nandun siya na area. Okay? So, just move more medially. You will see your facet joint, camel hump sign. Okay? And yeah, trident sign. Wait, ulit. Trident sign. Trident to. Ito. Tapos, ito yung camel hump. Facet. Tapos, you want to see the lamina. Move lang onte, medially. Tapos, naka-oblique ka. Oblique. Yan. So, this is the lamina. Yan. Lamina.
So you toggle lang doc.
Yeah, medyo naka-oblique siya. Tapos may kita mo this one. So this is your interlaminar space, anterior complex, posterior complex. Okay, so intrathecal space here. Okay?
So that's where you inject.
I actually don't inject here. Yun. So tapos, spinous process na.
Spinous process.
Where's your spinous process? Yeah. Ito ba siya?
So yung hanapin mo sa sacrum.
Sacrum. Looks like L5-4. Okay.
Pag sacrum, so
nakaganon siya.
Pababa.
Yeah, oo. Okay, sige. Next po. Okay po.
Thank you po.
For the participants, the primer QR code might be helpful for you. It's actually a Código reference for some of the structures, so maybe that will help you during the actual scanning.
Sabi mo, bibigay ko na.
Try natin, Doc. Transverse. Yan. So, kapag makita mo to, spine, ligament na to.
Ligament na siya.
Yeah. And then, mas klaro yung facet. Facet, kita. So, you move a little bit. Because if you want to do the injection, gusto mo, you don't want to see this part. Kasi, yung target, so in this scenario, baliktad ka, no? When you go inject here, dito siya papasok. Right? So, yun ang gusto mo, angulation, makita mo. Then just try to, just the facet, right? Ito. Kita mo yan, may space.
Yan,
diba?
space there.
That's actually the facet, right?
Ito lang siya.
Yep.
This one?
Yeah.
Ah, okay.
If you can play with it a little, minsan makikita mo yung transverse process. Here. Kita mo? Transverse process na yan. That's perfect. You freeze there, target mo na. Medial branch block.
Middle branch block.
Uh-huh.
Middle branch block here.
Here, facet yan.
Facet.
Same area. They treat almost the same thing. But when you do the medial branch, kailangan mo lang i-rotate and hanapin mo yung
Para
transverse.
ma-confirm ko lang na
Just superior. Make sure nga alam mo yung superior. I think may piriformis ata kasama, no? Kasama ba yung piriformis dito?
Yeah.
Yun. Piriformis, excuse me, ha? Dali lang yung piriformis. Actually, preferred approach ko dyan lang sa iliac crest. Kita mo na agad, waterfall. All you have to do is just go a little bit down, break na yung waterfalls. Piriformis na yan. Right? Diba? Pag nawala na tong slope, diba? Maximus, medius, minimus. All you have to do, break na yan. Then tilt, just tilt a little bit to the greater. Yan, that's already the piriformis muscle. Confirm mo lang na konti sa flexion and up. Okay. Sciatic nerve.
Sciatic nerve.
Hindi masyadong clear. Setting up yung brightness. Ang frequency nito. Detail. Ikaw, Doc, sige, try mo muna. Just look for the iliac. Ayan. Yep, yun na yan. That's already the performance. Angulate mo lang. And just... Yeah.
Flex mo.
Maximus to. See? Ang gumagalaw is just underneath.
Yan ang sciatic nerve.
Yeah. Ito. Yeah, ito. It's very important that you do it here because if you do the external rotation and internal rotation starting sa gitna, after the break, structures after the break, you don't know if it's the interior, obturator internals, gemini muscles. So yung pinakauna, because they will all move.
Yeah.
They will all move. Hindi lang yan
So
sa
dapat
piriformis.
proximal.
Yung pinakauna talaga, piriformis na.
And then what if I want to inject that?
Piriformis? Dito lang, diretso na yan. For muscles, some people will measure it also in
Okay.
Okay?
Sige.
Counter.
Yes. Thank you.
Spine muna tayo.
So superior ka pa rin kapag
Superior. Batang Wesley ka na eh.
pangalan niya yung turo mo eh.
Ano eh?
Dito kayo ba?
Anong gusto mo? levels muna. Okay.
Time check, we have
Or yan,
last
walang
40 minutes
kung
for
saan
the
yung
first
inferior
segment.
voice.
Again, projected on the screen are the target structures for the first segment. Then after this, we'll have review of the other structures for the second segment. Again, last 40 minutes. Hope everyone's scanning. Thank you.
Again, medyo, ano siya, ano? Medyo flat. So you want it a little bit high. You want it more round. Yeah. More round. So this is your piriformis. On top is your max sub-Q.
So sciatic nerve, ito siya sa gitna.
Ito. Sciatic nerve. We can put on the collar then to confirm.
When you increase that, decrease that. 6. Decrease. Yeah.
So it's here, no?
Yes, here.
Ito yung, you have your vessels here.
As target natin for hydrodissection.
Below, if you're targeting the sciatic.
Si posterior femoral patagios.
It's way more
Kasi may
down.
quad cell siya, no? Usually for sciatic, quad cell.
Pwede, kasi, yeah, kasi quad cell, ano na siya, on top.
It's more superficial. Kasama ng
So pag you, no? You see the position here. Good. So that's your pieces, no? Go down, scan down. Okay. This is your foramen, and this is your SIG. So have it more well defined. There. Kasi here you're losing it na. Baka lumampas ka. There. Para may sasalo pa. And then before this is again. This is once it breaks, no? But you follow that there. Once you follow, ayun, mas maganda yung orientation. Not so much, because you know it's banda dito lang naman yung sciatic nerve there. Ganda. SI, no? Once it breaks, mawala to yan. That's your piriformis. See here your superior gluteal. Actually, that's also a landmark. Kasi these ones there, vessels here, also vessels more lateral, no, inferior gluteal, superior gluteal, and then this your sciatic. More medial, this your pudendal later on. always palpate your patients. Step. Medyo okay, good. Okay. That's a better looking sacral hiatus, no? One is higher talaga than the other. Okay. And then put that in the middle. Okay. And then you shift. Okay, good. So put this in the middle. Yan. Tapos, don't lose that middle. Okay. Okay. Good control. So, there. Okay. Then you can confirm again. Go left, then right. You see the cornua, no? Cornua there, middle, cornua in the middle again. Once you have the line, you don't have to look. You're guided by that. Facet and inverse spinous. Also, another tip for doing caudal is I tend to move my picture minsan more than the screen para shorter yung needle path ko. Kasi ano yun, masakit for the patient. Masakit yung mahaba.
Mababa yung regular needle.
Yeah,
or
spinal needle.
spinal.
Gauge.
Convex.
No. Gauge for these gauge 22. 22 ako for the spine, for the lumbar.
So make sure that you don't go too deep, yeah, because you might hit the dura.
That's right.
Okay.
You mentioned you did the Dex 5D5.
Yeah.
10cc.
10cc, but you can go up to 20.
20.
Yeah.
Safe.
First injection 10 para hindi masakit. You can do it every week, every 2 weeks. It's safe, just dextrose. Some doctors or some professors would also suggest injecting it with steroid because for example, for cases of spinal canal stenosis, because sometimes there's fat formation in the canal just to cause atrophy of the fat to relieve that's what some of the Taiwanese professors say. You can try to use the steroid as well, even particulate steroid, yeah, but dextrose is safer. Reformis. Okay, let's check. Make sure you have to see 2 layers, glute max and your piriformis. You want to tilt the probe. So once you see the notch, once you see the notch, there's the notch right there. You turn the probe towards a greater trapeze. There. Okay, immediately once you see the notch, turn. Because if you're too late, you might end up here at the ischium already. That might be your obturator already. Okay, so immediately once you see the notch, turn the probe. There. You know that's piriformis. And you have to see 2 layers, glute max and piriformis muscle. Okay?
And then next structure will be
That's the ischio. It starts to flatten out. Okay. So toggle the probe. There. It flattens out. That's your intraligamentous plate. SI joint. Median crest of your sacrum. That's S1 foramen. Most likely that's S1 foramen. We can check. Go up. You don't see the foramen. That's the S1. Then that's S2. Okay? To double check, you can also do lateral. Longitudinal view. Sige, hawakan mo. Yeah, good. Okay. To check. There. Okay? 4, no? S1, 2, 3, 4. That's 4. Okay. Good. Your S1, S2, S3 dorsal roots also innervate the SI joint. So some would suggest to inject on that area.
then the synovial part.
That's the synovial part. There. That's the synovial part right there. There. That's a good image of the synovial part. There. That's the synovial
And then the
part.
ligamentous is
It opens, yeah. Go a little bit superior. There. That's a ligamentous part. If you go a little bit inferior, that's
so
the
injectate usually at the synovial.
should be here.
Okay.
Yeah.
And then
So when you
how often do you take
the prolotherapy, sometimes every 3 weeks. It depends on the symptom of the patient. Yeah. Most of the time they will respond with one injection of 15% dextrose with the ligament and the joint. Usually when they come back after 1 or 2 weeks, the pain is supposed to decrease by 50%. They feel a lot better. I ask them to do physical therapy for 2 to 3 weeks, and right after I do another shot if they're still pain. Your purpose is to regenerate that specific spot. Okay, ang bilis.
15%. Sorry, JDC. Yay. Ron, paano pag nagpinag-refer ng diagnostic for the piriformis?
No, I don't. I just say there's pain. Unsolved palpation.
nag-refer sa akin si Doc Justin, in-explain ko naman sa kanya. Wala akong
Tawagan mo si Just. Tawagan mo yung referring.
Oo, tawagan mo yung referring yun.
compare ko na yung
Wala ka makikita kit i-compare mo. They will look the same. Sometimes though, you see a pulsating, a twitching piriformis muscle. Sometimes you can see that.
Yung notching nga, hindi ko alam kung paano masabi yung may notching na siya. Yung piriformis.
The anatomical variants also, unless you have a very good machine, it's hard to see.
Pero may nag-refer din sa
There.
akin. Yeah.
Good. Very
Ito,
good.
dito sa Nepodendal.
There, that's
Gusto nila
pudendal.
sabay. Pag nag-inject daw ako ng piriformis, isasabay ko na daw yung pudendal.
Unless the patient has pudendal nerve issues.
Meron din.
So your pudendal nerve,
Anterior.
di ba meron siyang terminal branches? You have the inferior rectal, nerve to the penis, or clitoris, perineal nerve. Okay? So the pain of your pudendal nerve should be on those specific areas, perineal area, clitoris, or the penis. And because the inferior rectal artery innervates your anal sphincter also. So on that specific spot, there should be a bit of pain. If it goes a little bit lateral, it might be an inferior cranial nerve pain.
Training naman. Ganun din, D5, tapos depende na kung anong kaya.
Right after that, maybe we can go up to the lumbar spine. Okay? Sobrang gagal. Crossbeam. Pero mabagal siya. It will be slower. Frame rate will be a bit slower. Yeah. But resolution.
Yung wire naman.
So, ito, this is your
Where they could put
Caudal
So,
to
that is-
Cefalat. Yeah, ganun.
Target
So,
that
yeah, ito yung hypoechoic space. Or actually, yung gusto nila is medyo lagpas ka pa sa bone. Or like right before you enter the bone or medyo naka-enter ka ng bone ng onte. Yeah. Ganun. Okay, so yan. Caudal to cephalad. Okay? Sige, now transverse again. Yan. Tapos, move laterally, tapos medyo upward to find the SI joint. Okay? Sige pa. Yan. Upward. So, yan. This looks like sacral foramen, lower SI joint. Pag lower SI joint, same level sila. Okay? Tapos, move upward. Upward, upward. So, tataas na siya. Upward pa. That looks like your upper SI sacral foramen. Ito siya. Medial to lateral upper SI joint. Okay? Yep. Medial to lateral. Okay? Sige. Next po. Thanks po. Thank you, Doc. Do you want to po, Doc, palpate po yun sa end? With your, po, just yung PI. Kasi put your foot at the level of your PI. Yan. Tapos, so ito na siya, Doc. Sacral cornu, sacrococcygeal ligament, tapos caudal epidural space out of plane po. Or you can do long axis. Ito siya, Doc. So, caudal to cephalad po, like this. Okay?
So that this is the seating there. I think this one.
Ito po,
yeah,
ito
yeah,
po,
there's
yeah.
a better picture.
Tapos, transverse po. Yeah, yeah. To find SI, more lateral po, Doc. Sacral foramen. Sige, lateral po din. Tapos
Time
upward.
check, last 20 minutes.
Upward.
Last 20 minutes for this segment. Thank you.
Looks like your lower SI. Sige, up yan. Lower SI. Tapos nagiging upper na siya. Akyat ka pa, Doc. Akyat. Here.
There's the break.
Ito yung
There.
sacral foramen. Ito po yung upper SI. Medial to lateral po. Okay, sige. Okay po tayo. Sige. We'll go to po ha. Posterior. Sorry. So, so here po at the level of the ilium, okay, you will see this one po, no? So, gluteus max, medius, minimus, and then you see an artery here. The superior gluteal nerve is here po, beside the artery. Okay, so you inject here, lateral to medial. or the superior gluteal nerve. Okay? Here po. And then, if you go more distal, you will see the greater sciatic foramen. And then, this one po is your piriformis from the sacrum. It will go to your greater trochanter there. Okay? Piriformis. Tapos, if you move more distally, you will see this po, ischial spine. This one. This is your ischial spine. This looks like your sacrospinous ligament. On top is the sacrotuberous ligament. And then, color flow. Color flow. Dot color po. So, here po, you have pudendal artery and pudendal nerve. Okay? So, if you want to do pudendal nerve po, medial to lateral sa interligamentous plane, it's right here. Kasi your sciatic nerve po is here. Okay? We'll go back po to we'll go back to piriformis. So, this your piriformis, your sciatic nerve is somewhere, should be somewhere below. This looks like yung sciatic nerve. Yeah, this one. Here. Yan. So, in long axis, this is your sciatic nerve. Okay? Sige po. So, pudendal, ischial spine, tapos sacrospinous ligament, tapos sacrotuberous ligament. And then, if you go more distal, this is your obturator internus po. Okay? And then, sciatic nerve. And then this one, quadratus fem po. This one. Gluteus max sciatic. Looks like quadratus femoris po ito. Okay? So, ito po dok. Yung ilium. Yan. Tapos, you can see this one, yung artery, katabi po niya yung superior gluteal nerve. Yes, max medius to minimus pa po. Yeah. So, this is your superior gluteal nerve. Yan, katabi ni artery. So, you can inject your lateral to medial. Ganun. Yes po. Pwede rin PRP or steroid, vitamin B. Pwede rin.
Ilang cc depende?
Kahit mga few. So, depende. Actually, pwede ka 5 to 10, pero medyo madami na yun. So, kahit mga less than 5, okay lang na. Basta ma-hydrate na siya.
Pero walang lidocaine.
Pwede ka rin maglagay ng lidocaine. Tapos, go more distal. Greater sciatic foramen, you will see yung piriformis here, no? Yan. So, this is your piriformis na po, Dok. Sorry, dito ka pa, Dok. Ito po. You can do mga IRER to check. Yan. Sana po. There's your piriformis. Ito Doc, your piriformis po. Tapos, if you do IRER, gagalaw siya. Yeah. Okay. Tapos, yeah. So, if you're injecting at the piriformis, medial to lateral pa rin po. So, you can do lidocaine, Botox, E5, steroid sa piriformis muscle leg. Okay? Sige, this looks like your sciatic nerve po. Just if, yeah. Sige, tapos, so after this one, yeah, sciatic nerve, tapos, go more distally. This one, will become the ischial spine. Kasi straight na siya, tapos medyo patusok, pointy. So this one is the sacrospinous ligament. This looks like the sa taas, sacrotuberous po. So na siya. Sacrospinous, sacrotuberous, meron pang artery, pudendal artery, medial to that pudendal nerve. So you can do medial to lateral injection of the interligamentous plane kasi naiipit siya usually po sa interligamentous plane. Okay?
Where is your position?
Dito, opo, medial to lateral. Kasi po yung sciatic nerve po, baka tamaan, kaya medial to lateral
Yeah,
tayo.
doon lang position.
Yes po. Okay. Now, if you go more downwards po, distally, you will see a hypoechoic muscle hugging this one. Ito po. Yan. Meron pong nag-hug doon sa ischial bone. That's your obturator internus. Yeah. Now, if you move more downwards, yun, gluteus max, this is your sciatic quadratus fem na po ito. Baka ito na po yung conjoint tendon kasi ischial tuberosity na yun. Yeah. So, conjoint tendon, sciatic, tama. Conjoint tendon, sciatic, quadratus fem, gluteus max. Okay.
So, hindi ka nag-inject sa sciatic na?
Yeah, natatry ko rin po. Lateral to medial.
Hydrodissection.
Yes, pwede po. So, dito is your pudendal nerve.
Ischial spine.
Yeah, ischial spine. Tapos, obturator internus na po ito, yeah. Tapos, yeah, looks like your sciatic nerve po. Yan. Tapos, mukhang, na to, quadratus po.
Thank you.
Check. We'll start at the superior gluteal nerve. Sorry. Where is your, ito. Here. Akit ka pa, akit. Yan. So, beside your superior gluteal artery is your superior gluteal nerve. So, gluteus max, gluteus minibus here. So, lateral to medial. Okay? There. Yun. Tapos, greater sciatic foramen, piriformis, sciatic. Tapos, yeah. You can do oblique para mas makita mo yung magandang fibers of piriformis. Okay? Pero, medyo nasa ischial spine ka na. Ayan, so ito yung piriformis pa sa taas. Okay? Sige, tapos move downwards, distally, ischial spine. Tapos, here is your, sacrospinous, sacrotuberous, tapos pudendal artery, pudendal nerve. So, medial to lateral. Ganun. Okay? Okay, tapos downwards, you will see this hypoechoic muscle hugging the ischial bone, the ischium. This is your obturator internus. Yeah. Tapos go more distally. Sciatic nerve conjoint, I think quadratus fem, gluteus max. Yeah, ilium. Iliac crest. Yeah, oo. Iliac crest.
Time check, last 10 minutes for this segment. After which we're gonna have another demonstration in front. Last 10 minutes for this segment.
Balik muna tayo, Dok. Medyo na mabilis yung ano.
Sige. Yeah. So ito yung merong superior gluteal nerve, superior gluteal artery. Yan. So I go down. Yeah. So I go down. Then I break piriformis.
So, let's make, sige. Here, Dok. I-roll mo siya. dito, ano to, higher ka pa. Balik ka daw, balik ka daw.
So ito yung superior gluteal nerve.
Ako kasi, sige, go down.
Tapos when you go down,
Break na yan. Yun na yung break talk. Lumagpas ka na. Dapat sa first break, ikot ka na. Yes, ikot ka na. Towards the trochanter. Towards the trochanter. Ayan.
pero yung nerve niya parang
Okay, let's try to. We have to optimize the image kasi dito. Balikan natin Doc, yung first part na. Okay. Fine. Ako, you're already, I would prefer na ganyan. Then I only tilt kapag nag-break na. Kasi Doc, ganyan siya mag-start. Ako is like here. Then pag makita ko na yung break na yan. Oh. Sorry. Baliktad to.
di ba parang naka-mirror dyan? Kasi dapat hindi yan yung nakikita natin.
Baliktad.
Naka-mirror yung image.
Nakamalite siya.
Okay. Ayan. Ha? Ayan siya. Then you see the break. Lateral ka na. So reformist na. Again. Just go down. Break. Kaya din ako nag-angulator na ganyan.
So pag break,
Yun
na yun.
Reformist na yun. Again. Sige daw.
Sige. So from here, ito yung ilya.
Break.
Break.
Yep. Yan. Reformist na yun. Sciatic na to.
Sciatic. Okay.
Sometimes makita ka. Inferior gluteal na kasama. But when you're also here, you have to also play na ganyan na view mo. Hindi siya ganyan.
Okay.
Mas maganda kung ganyan.
Heel
toe.
Naka-heel toe pa.
Okay, so ganyan yung gusto ko. Okay.
And then, yun.
So yun na. So punta lang sa SI.
SI, kita mo na. Or,
Siyempre ulit, very slowly from there.
caudal ka. Caudal
Caudal
epidural.
pala, caudal
Yeah,
epidural.
frog eye.
So yun.
Whichever way lang na prefer mo, saan ka pumasok.
Wait again. So here.
Gusto mo ano, linear? Gusto mo mag-linear para mas klaro? Sige lang, after this, iikot naman kayo sa ibang machine.
Wala.
Mabagal siya nung mag-change. Mabagal siya mag-change. Yan, maganda, di ba? Ang ganda, mas klaro siya.
So ito yung frog eye. So ito yung sacral column. Sa gitna. That's the
Caudal epidural space.
epidural space. Then
Sangkap oxygen.
like that.
Yep.
Then we want
Pero
the
you
needle.
have to make sure na talaga daw.
Yeah. So you want the needle to enter.
Here. Sometimes pwede mong
So from here.
talaga.
So
Tapos,
yeah. So from here to up to there to the inside. And then you feel the
may give na dito. Actually, after the ligament here, may give na immediately pasok na yan dito. Give na yan dito.
What's the
Ako,
ligament?
I push until I keep seeing the needle until needle tip here and stop na ako.
Yung ligament, what's that ligament?
Sacrooccygeal.
So from there, then I want to do the SI
SI.
joint.
Ah.
So for SI,
Weird yung viewing niya. Parang baliktad siyang orientation.
So paano ko hanapin yung SI? Then anong landmark ko?
Yung iliac crest dito and sacrum.
Crest.
Diba kanina sa piriformis, sa piriformis dito ka. So ngayon, dito ka naman. Okay, so kita mo. Iba na ang view dito ha, because naging ano tayo, linear tayo. So,
Oh, sige. Okay, so ito din.
Yan.
Yeah. Okay, and which side do you want, left or right? Here. Balik. Okay. Hanapin mo yung iliac. Iliac yan. May iliac and then sacrum. So kailangan sila yan. Perfect. This is the
yes. So this is the foramen, and then that one is the SIG.
yes, try it.
So you want to hit this one.
Go a little
So,
bit lower.
But you will do it from medial to lateral.
Yeah.
Here. So go a little lower. Yan, better.
Sa linear. Mas
Ito,
maganda dito.
better.
Yeah.
Yan. No? So from here, then dito.
Yes.
Then go there. Okay. So
Ito yung target mo, yung foramen na yan.
Yeah, again. So from here.
Kita mo na basta ito. These two converge and then magpa-flatten to. And then you see the opening.
Yeah,
Sure ka na.
sacrum, and this is the iliac crest. So I go lower.
Baka makita natin yung clue niya. Medyo okay naman pala to.
Linya niya. O mas klaro na.
Ulit.
Okay, sige daw. Yan. Go down, slowly.
Yes, that's it.
Dito. Lower. Yan, dito.
Yan,
Yan.
correct.
Ah.
Yeah, okay.
Iba yung view, di ba?
Yung colonial, dali. Ito na yun.
Here. The clue is already here, but you just need to find it. Alam natin dito si clunial, but to see it small, pero kapag i-hydrodissect mo, minsan makikita mo talaga siya. Kapag na-separate mo yung erector spinae,
Malift off mo siya. Sige na.
Yan lang siya, pasok ka na dito.
Yes, right on. So, yan.
May angle niya. Yung angle pa rin niya.
Pwedeng ganito na transverse, pero okay din yung ganito.
Tapos in-plane.
Tapos
in-plane.
Okay, time's up. We'll have a 10-minute break first, and then we reconvene here after. So again, we have a 10-minute coffee break, and then we reconvene for the demonstration for the second segment. Thank you.
Erector spinae. Ang erector spinae becomes, nandun yung clunial, di ba? Erector spinae, di ba? Again, this is the multifidus. The clunial is coming from the erector spinae, so di ba? Ito.
Snacks are available at the registration booth. Thank you.
Yan. May maliit.
What was your home base again?
Ako kasi, I follow the erector spinae. Kasi that's where the clunial nerve arrives here. Dito siya nag-appears.
It appears
From the erector spinae. Pero yung iba naman diretso lang sa PSIS mo. Pero ako mas gusto kong i-follow siya from its origin. So this is the spine. Alam mo yung erector spinae is this muscle. Then it goes slowly towards the bone. Here. This tunnel up. Yan. Yan. So we can now do the long axis. Check ka na dito.
Or yung ginawa mo kanina yung transverse, no?
Pwede
Okay
yan
din
yan.
yung transverse.
Pwede rin, yeah.
Pero kailangan makita mo yung slope. Yan.
Go.
Facet joint. Camel hump. And then you see the joining of the coming together.
Of the sap-sap.
Of the sap. Yep. The sap-sap. And
Sap and
then,
the
yan. This is your, ano ba, trident. Ayan. Yung very hypercoic, here's your lumbar plexus. Again. Lumbar plexus. So I don't usually start there because it's very superficial. So I go here, lamina, horse head, oblique. You see the interstitial, you see your ligamentum flavum kasi ganda eh, skinny patient. And then, ito, kita eh. Kaya nga dapat ang kinuha ng pasyente, medyo batak.
Yung typical na may masakit na likod.
And then your anterior complex, you go more there, you close the gap, no? This is an articulation. Sometimes may mga techniques that you can do it like that.
In plane na ganyan.
In plane.
Pero ang haba kasi nagka-traverse na needle.
And then, ito mas kita yung ano. There. Mas kita.
Diagonalization na.
And then go here. Yeah. Try again.
Try mo yung ibang machine doon.
Yung sa trident, yung for plexus for of the median or lateral trident.
More on the posterior 1/3 of the psoas. Ito siya.
Is it more on the towards the midline or towards the lateral?
More on the lateral, at the level of the transverse. Kasi here, mawala ka na. Once you
As
have
parang
it,
they are all throughout
yes,
the transverse.
here,
All
transverse.
throughout the transverse.
And this your peritoneum. Transverse. You're at the L. So you know this is L5 na. So this is your L4, L5. L5 S1 joint. This is your SAP of S1, sacral iliac. Thank you. Thank you. Break the time. Okay.
10 minutes, ma'am.
Okay,
Pwede
okay.
mag-break po. So rin, break ka na rin.
Ako naman. Pahinga ka muna.
Kailangan ko kang
We go back here or my left?
Yes po, the demo po will be here also. This
Same.
up. Thank you.
Thank
Anton,
you.
no? Pala yung next part, may tusok mo. Kung nga mag-sakit likod mo yun.
Oo nga.
I want 6.
6, okay. Kaya mo pala 10. Yes.
Yeah, because I didn't want too much depth. I don't like it. It's so deep. So this is the depth measurement. Oh, this is 8.
This one, Doc. Up and down.
Up and down. Okay.
So 6.
Okay, so very nice.
Gluteal muscles are...
Just wanted to see something.
Wow. Siya niya?
Yeah.
Sacrotuberous. Mas ganda, ang ganda.
So this one is the sacrotuberous.
Very nice.
Let me see. Okay, I'm right. I'm left. Okay. So.
What's caudal here?
Okay, this left here is cephalic, right is caudal. Okay, so you can see hyperechoic, so that's your sacrotuberous. So usually it goes all the way up. So this one is really, you see. So this is a better view of the sacrotuberous lumbar. So that one is much better. So the one on the upper portion is the sacrum. The one in the middle is your ischium. So that's your sacrotuberous ligament. Yeah.
Sacrotuberous?
Right.
Right
Yeah.
here.
So yeah, that's a part of sacrotuberous. So this is the sacrum here. Then this is your ischium. So you can see here it spreads, flays out this way. So you can see it's hyperechoic. And then if you twist it like this, and then you go all the way to the spine. Okay, that's your spine. Okay, so this is your sacrospinous. So this is your spine. This is the tip of the spine. That is your ligament here. So that is your sacrospinous. So your pudendal is actually right here. It's your pudendal. It's just the tip actually. So this is your pudendal nerve here. Can you put Doppler?
You want to put them on the mic? We put the mic.
No, I'm just resting because everybody has a break. So don't worry. We'll show this to you later.
We'll resume.
I'm just looking at the ultrasound. If it is really the best ultrasound according to GE. I don't think this is the best ultrasound. Galit eh. Okay, so very nice. And then of course, so right on top of that is just this is the pudendal nerve. Where's the pointer? Kabagan ng pointer. Oh, okay. So there's a trick here. So usually, if you go this way, so it becomes rounded, right? You won't see anything. So you go up until it flattens. The moment you see the flattening of this structure here, the spine, then at the tip of that is your pudendal nerve. Very easy. And just below that is the sacrospinous ligament. This one. So it's very easy actually. Okay. Seryoso.
In that view, Doc, can you see the sacrotuberous as well?
Ayoko nga. Pusat ka muna. Okay, so you change your orientation. So you do it like this. So, because you go this way. So sacrotuberous would be this. Okay, so sacrum up, sacrum on the left, then your ischium on the right. Okay, can you remove the Doppler, and then can you decrease the depth? Okay, some more. I don't like the depth. Yeah, that one is a sacrotuberous. So nakaganon siya. Kaslant. Hindi talaga siya ganon. Pag ganon mo, wala kayong makikita. So you have to twist it like this. Okay. So that's your sacrotuberous ligament. Ayoko nga. Sino ka ba? Ano gagawin ko? Anong structure?
Then the sacrotuberous sacrospinous. Inulumbar.
Wala namang ka-challenge sa mga structure.
Okay na pala sila. Lunyal and review.
Teka lang. Wait lang. Okay.
Kasi wala kami tutus na. Pagdating ng
Sandali lang. At kumakain pa sila. Maya na. 5 minutes na.
There's a view that the pudendal nerve is like parang yung
series ng
Ano yan?
The pudendal nerve is between the
Actually, Doctor,
kasi you parang you show the sacrospinous in relation to the
Okay, so I go up. So I go up. So
Yes,
So
pero pagka-oras yung and ano kasi,
So,
more
nandito
on
siya.
pang radiologist na side. Halos yung mga features.
so at the sacral ischial spine.
So this is part of the sacrospinous pa rin. Sacrospinous pa rin yan.
Then meron
The
siyang
sacrospinous pa rin.
L6 to 20.
Tapos pag sacrotuberous.
But not in one
In one plane? No.
For this, ano,
Wala nang linear naman.
That's the sacrotuberous.
And the one pulsating underneath is still within the artery nerve?
Let me see. Yes.
Okay. Check. Okay. Thank you, Doctor.
Okay. Pero gusto ko siya umpisahan dito kasi may mga gusto kayo makita, di ba? Gusto niyo makita yung yung medial lineal branch.
So very maganda. But I brought na may stomach.
Mag-asawa na yan si TD.
Hindi ako
Okay, so L5.
Ito lang siya. For this, for yung cortex, meron mo cortex higher frequency na linear.
Oo. Pangit to eh. Ewan ko ba kung bakit kinuha to. Joke lang. Baka magalit sa atin. That's the iliolumbar ligament. This one is the iliolumbar ligament. Yes. Kung pangit yan, wag mo yun ibigay sa akin. Gusto ko yung microphone.
Yung last, sir, yung maganda. Iba yung kanina, yung pangatlong lapit. Yan kanina. Okay po. Try mo nga, sir.
Mic test.
Recording yata.
Okay. Wala pa naman yata sila eh.
Well, ano na po? Call na po. Kaya. Tawag ba? The camera over.
Kumusta ka?
Okay lang naman.
Ano ang pangalan mo?
Anton, sir.
Ha?
Anton.
Anton. In-exploit ka na, Anton.
Sige lang. Okay lang.
Yeah, of course. Okay, let's begin.
Okay, let's reconvene here in the middle.
As you can see, I can see you, but you can see me.
We ask everyone to go here for the demonstration of the other structures of the lumbosacral and pelvic ultrasound.
Okay, mic test. Why is it working now? Okay, you're watching UPPGH Caliber Workshop. Tune in at ADM 12:45, GA Healthcare, Logic, Totus. Okay, so we're going to review back these structures because it's very important as a beginning of our structures that we'll scan later on, and let's just make it very systematic. So I'm looking at the iliac fossa. Okay, everybody. Okay. So this flat bone here is the iliac fossa, and then attached to this, if you look at my probe, I'm going transverse, and then the left of the screen is actually the medial side, the right of the screen is the lateral side, so just to orient you. So this is my position, starting position, and then of course, I'm looking at the iliac fossa, this is the bone here. Okay, and what I can see are the three muscles, the gluteus max, medius, and minimus here. Did you see this? and it's separated by a fascia in between. And then just between your gluteus medius and minimus, you can see a honeycomb structure here, and also a pulsating structure medial to that. So this is your superior gluteal artery together with the superior gluteal nerve. This is the specific spot. If you're going to do intervention, you can approach this from lateral to medial on this side, and this is exactly the location of your superior gluteal nerve. So I was explaining earlier during the lecture is that when you ask your patients about pain here, they will exactly point to this area here. Okay? You don't see it in the screen? No video? Okay, anyway. So this is the exact site for your superior gluteal nerve. This is a very common area for pain at the gluteal area. Of course, you can go up, 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 up until your iliac crest. And then, this is the area where you can actually find the superior gluteal nerve over here. Okay? And then there is a very small groove which the medial gluteal branch of the superior gluteal nerve pass through. And this is also the area where it is very painful. So when you do your physical examination, you will notice that patients would complain of pain right here. This is the exact spot they will tell you there's pain. So if I do a long axis view, I turn my probe like this, then what I'm gonna see at the medial side, should I say at the superior side, would be your erector spinae muscle. And then of course below that is your gluteus max. Then on the middle is your iliac crest. Then you can see a fascia in between these layers. That's the fascia where your superior gluteal nerve is located. So this one is erector spinae. In between is a fascia. That's where your superior gluteal nerve is located. So for those of you who would like to dissect this fascia here, that fascia is where you find actually your superior gluteal nerve. You can also approach that on a lateral to medial approach this way, and then you can approach it from lateral to medial, targeting this area over here. So that's your superior gluteal nerve. Okay? And this is a very common area that's affected when you have a back pain at the iliac crest. Okay? That's exactly where the nerve is going. And then as I've said, I go back down here. So you'll see three muscles, max, medius, minimus. Between your medius and minimus, you have your superior gluteal nerve. And then of course you have your artery, the pulsating one. That's also your location. If you're gonna approach that, you approach it from lateral to medial with your probe in a transverse manner. So you see your probe like this, okay? Then you go down and you can see the collapse of this structure. When you see the collapse of this structure, all you have to do is to rotate your probe diagonally. Did you see what I'm doing? So from here, I go this way, transverse, then rotate. You know why I have to rotate? Because that's the orientation of your piriformis muscle. So if I rotate that structure, can somebody please lessen the depth? Just want to show you. You can see exactly that the piriformis arising from your sacrum on the medial side is inserted into your greater trochanter on the lateral side, and you can swing it this way, and below that is your ischium. So the position of my probe is diagonal, as you can see. It's oblique. Okay, transverse oblique view. That's your piriformis muscle. Okay? Can you see the muscle moving? Is it clear to you? There's no other muscle there except the piriformis. Okay, and then of course, I go down a bit. And you can see a muscle. You can see a muscle right below the piriformis, which is attached to the ischium. Can you see this muscle here? This one? Everybody? That's your superior gemellus. Okay, so it ends at the ischium here. Okay, then I go down. Then look at what happened as I go down. It becomes rounded. See the rounded? The bone becomes rounded. Okay? When you see the bone rounded, you check again. Because what's going to happen is, there's a muscle that rotates around that bony accusative lumbar, and that's your obturator internus. Did you see that? The obturator internus wraps around the bone. See the bone? Okay. Then I'll just move it a little downwards, and then the obturator internus is gone. And there's a muscle that pumps up. So this is your obturator internus. See, this is all wrapped around the bone. Okay, I've shown you how it moves as I rotate the leg, as I move the leg, but as I go down, there's another muscle that ends up here. It doesn't go past this bone, but just ends here, this muscle here. Okay, see this? That's your inferior gemellus. And I'm scanning gemellus, is scanning the gemellus. Okay, and the muscle below that, here, see this muscle here? That's your quadratus femoris. And you can see a honeycomb pattern here. Did you see this honeycomb pattern? What do you think is this? Yeah, sciatic nerve. Okay? Now, I have to go down a little bit more. And that is exactly at the gluteal fold. Okay, I'm at the gluteal fold, so I tilt my probe like this, and that's the origin of the hamstring. Okay? The semitendinosus and the biceps femoris. Right here. Okay? Now note that at this level, if this is your sciatic nerve, lateral to that, which is actually very superficial, of course we cannot see it very clearly, but you will notice a honeycomb pattern over here. I don't know if you can see that, but it's very, very tiny. It's supposed to be the posterior femoral cutaneous nerve. Yeah, this is very tiny here. It's just on top of the gluteus max, because what happened is that it goes underneath the gluteus max and then goes all over it. So it rotates back. It comes in as an inferior gluteal nerve, and then as it goes up, it becomes posterior femoral cutaneous nerve. So it's actually superficial to your gluteus max. Okay. So what else? So I go back again here. Then go back to my original location, and then let me see. Okay. Then here, because a while ago what happened is I go diagonal, right? So this time I go transverse. When I go transverse, you will see the ischium flattens. Ischial spine flattens. So the tip of that spine here, okay, here, you notice this? My position is actually transverse. If you look at my probe, position is actually transverse. So the tip of that, you can see a pulsation here. You see this pulsation? That's your pudendal artery. And just beside it is your pudendal nerve. So the best location to look at the pudendal nerve is to put the probe in transverse, and then look at the tip of this bone here. Where it ends, that's the location of your pudendal artery and pudendal nerve. So what really happens if you're going to approach that is, you approach it from lateral to medial, coming here all the way to that location here. Got it? Okay. And of course, you can see also the sacrospinous ligament right here. Okay. It's sacrospinous ligament. Then if you're looking at the sacrotuberous, all you have to do is just rotate it to 90 degrees. And then there you can see it. That's your sacrotuberous ligament. And then you can see also a pulsation there. It's the same structure that we're looking at because it's actually between your sacrospinous and sacrotuberous. That's your pudendal artery and your pudendal nerve right here. That's your still your pudendal artery. Because if you rotate that, you see the same structure. So if I rotate that, keep your eyes on that structure, it's still the same. See? See that? The same. You don't change it. Good? Question? Yes? Any question? Okay, so if there's no question, I'll go up. Then very important structure here. Okay, this is your posterior superior iliac spine. Then I'm at the level of L4, L5. Then you can see a structure here attaches to the transverse process. Actually, it goes all the way to L4 as well. L4, L5. This is your iliolumbar ligament. This is also one structure where you actually sometimes some pathology, especially if there is loss of the fibrillar pattern here. If there is a loss of fibrillar pattern, then you can also inject that with PRP and then try to resolve the pain in this area. Then you go up. And then as you go up, you would like to see the W pattern where you can see the spinous process on the medial side, facet joint here with its joint. And then of course, this is the transverse process. Transverse, facet joint, spinous process. So for those of you who are going to inject the joint here, you can approach it this way. Okay. And then if you go medial branch, you go this way at the superior articular process, and then the root is just right here. Now, if you do the so the crown patterns that you see a while ago is really when you view it on both sides, right and left, where you see this, the spinous process in the middle, on both sides, the facet joint, and of course the transverse process on the other side, both sides. But actually, when you do a long axis view, you can see the spinous process. Can I have you, Jen? You can see very prominently the spinous process in the middle. Okay. And of course the dura mater here. Then when you go lateral, you'll see the horse hair, horse head. Okay. This one. That's your lamina. Then as you go more lateral, you can see the dura as well here. You can see the facet joint. Now, what's interesting about the facet joint is that there are two shadows here. So you can see the superior and then inferior articular process articulating to each other. So you can just toggle it this way. So if you see the two shadows, that means you're at the facet joint area. That's described to be the camel's hump. And then as you go lateral, then you can see the trident, very distinct pattern because there's no other structures except this intertransverse ligament in the middle. And then all of these are your transverse process here. Okay? And then of course the psoas. Okay? I think that's just the more basic ones. We're not gonna teach the more advanced ones. So here, maybe that's the simplest way of doing it. What else? So you only have 5 structures. I think that's it. Okay, thank you very much.
Thank you very much, Dr. De Castro. Now we may proceed to our same stations earlier to finish off today's event by scanning these structures. And if you still have time, we could go back to the other structures you scanned earlier. So again, this is a review so that tomorrow it will be quicker for us to identify the structures. We have another 1 hour for this part.
Thank you, ma'am.
Ba't maganda siya ngayon? Maganda sa system na.
Ayun sa inyo. Thank you, Doc Jim.
Nananadya kayo. Nananadya ka. Ay, sorry.
1. This could be your sacral ila. So go up. Go up. Okay. L5S1. I think that's a good facet joint. So you want to see the transverse process here. So you want to move here kasi you want to inject na, no? Look for a good transverse process. There. Yeah. Yeah, there. There. You see?
Yung hinahanap nito, dito lang yung sa area.
That's, yeah. So periclonial nerve. Just the thoracolumbar fascia. Nag-zoom. Si ma'am na lang yung siya na lang yung
Mag-over ka dito.
Okay, posterior superior iliac spine, that's your ilium. You see the 3 layers, glute max, medius minimus, superior gluteal artery, that's your greater sciatic notch. So greater sciatic notch, diba? You have 2 structures above it, superior gluteal artery, superior gluteal nerve, piriformis, then underneath sciatic nerve, pudendal artery, inferior gluteal artery. Go. Okay. So it flattens out, so it becomes the ischium already. Becomes the ischial spine because your sacrospinous ligament attaches to the ischial spine. Sacrospinous, sacrotuberous ligament. And you see your pudendal artery right there, it's pulsating. Pudendal artery is lateral to your pudendal nerve. Asan ka na?
Sacred tuberous.
Yan na natin. Kasi you want this to be really linear. That's a good view. See? There, it's flat na flat. No? You see there. That's a good view. That's where you do your injections. Medial to lateral. Okay? Yeah, pudendal nerve injection. Right here. So your quadratus femoris already, no? Hamstrings insertion, so your biceps femoris and your semitendinosus combining. Semimembranosus a little bit more, you know, superficial si biceps femoris and semitendinosus.
So even if you're scanning the other side, you always stay with that.
It depends though. Kasi if you want to inject, the screen's supposed to be right in front of you. So when I do spine, I'll move the screen here. just so that my injection is better. If I'm going to inject here, I'll move the screen here, I'll do the injection.
Kahit hindi spine lock, ginagalaw ko
Yeah,
lang.
ako rin. Kahit
Para
hindi spine, it's safer.
nakatingin lang ako
Safer
ng
to-
ganyan lagi.
Just so that you don't have to keep on moving your head. One technique you can also do is what I usually do. Once I see a good image already, I don't look at the screen anymore. I just look at the probe and my needle and just check the trajectory. You should be in line with the probe and just check the screen if you're inside.
Kasi pag di mo tinignan
It's
to,
easier rather than looking at it at the same time. So just know the trajectory. Know you have to make sure that you're underneath the probe. Just look at that area. You'll be okay. There, that's a good image. You have your facet joint, that's your transverse process. I see a little bit of iliopsoas.
L51 check.
Once the iliopsoas disappears, that's your target. What you can also do, Doc, is the focus, pwede natin ibaba ng konti. Ayan na pala yun. Ganun pala yung focus niya. Ayan, i-deeper natin para mas maganda yung sound waves on that specific spot. So,
This one.
yeah, that's your target, Doc. Right there.
Tapos, I will rotate it.
Then to make sure that you're inside, you rotate the probe longitudinally to check the transverse process. So yeah, you have to be a little bit more, a little bit more lateral. There. That's your transverse process.
So that's the trident.
Yeah, that's a trident sign. Your target's supposed to be, that's the facet joint. Camel hump sign. Then the horse head, intrathecal view. There. You see the, that's trident again.
So if I go to Sapalo 6, this one is the SI.
SI joint, I think you should be a bit more lateral though. Bit more lateral. You want to see foramina. There, that's SI. That's SI. That's SI. That's the
S1 from.
yeah, that's a cranial part of the SI joint. If you go more caudal, you go to the cartilaginous part of the SI joint, the joint in itself, because above it ligamentous part. So that's the cartilaginous part of the SI joint.
I want to go to the from Sapalo.
To the sacral cornu. Sacral cornu, from the sacrum you can just go distal because there will be a break between your S5 and your coccyx. See there. That's your sacral cornu. That's the sacral cornu. Yan na lang natin to. So let's make it more shallow. There. That's your sacral cornu.
So we will the needle is
Turn the probe though for longitudinal. There. There.
that's
The sacrococcygeus ligament. This is your coccyx. That's your target.
So your needle is up to what level?
You should not reach S3. You might hit the dura na daw.
So just
Yeah, as soon as the needle disappears underneath the cornu, I think you're okay. Then you can do the injection. Sometimes the ligament can get ano lang no, parang Yeah, calcified. It can be calcified. I think in one of the cadavers before it was calcified already, and the
may
and
scoliosis.
may scoliosis. There's one of the cadavers.
We're not using that
Yeah,
cadaver.
has complete. The patient has a completely calcified sacrooccipital ligament, and the patient also has scoliosis. So we had a really hard time looking for the sacral cord. It was here. It was here.
Three layers.
Once you see the break, immediately turn the probe towards a greater trochanter. Turn the distal part of the probe towards a greater trochanter. There.
Move it.
Check the piriformis. So,
Where's the needle? The needle should be
medial to lateral. Very, very, very deep. Go down, so this will flatten out. You'll see your ischium. Then you'll start to see the ligaments here. There. Sacrospinous, sacrotuberous ligament.
Where's the needle?
Like that. Medial to lateral also.
And for the hamstring,
Hamstring, you can just do prolotherapy on the hamstring. Thank you. Practice more. I have one. What's more empty in both ears?
Yes, that's correct.
So what you're seeing is the posterior border of the acetabulum when you're looking at the piriformis. That's a good view. So that's a good view. Yeah. This is the facet joint. That's your medial branch. Good. That's a good view. Yeah, that's a facet joint. It's round. That's a facet joint. You can also see the space. You can also see there. That's the space of the joint. That's a joint. That's a trident. So the trident view, you would like to see your iliopsoas muscle. So iliopsoas muscle is underneath your transverse process. Okay, so you want to go a little bit lateral, a little bit caudal.
So actually, yung superior crudial nerve, you can do it blind. So I try to, parang ask the patient to extend. Tapos yung ito, nandito yung superior crudial nerve. Yeah. So yung itong area, sa ganyan, dun siya, yung fascia doon. Pero You can try it ultrasound guided dun sa may iliac crest. Like yung fascia rin. Yun.
Sorry, dito na to.
Saan yung iliac crest mo?
Yung crest
Yan.
here. Apo.
So, parang may fascia siya doon.
Medial to the crest.
Pag ganito kasi siya eh. Pag ganyan. Oo. Pero ibang pictures, umabot siya hanggang here. So, yung fascia, like, yung mga bilog-bilog na yun, that might be it. Like, yung mga small dots na yun, that might be it. Your cranial nerve. Kasi, yeah. So, pwede ka rin ng long, sagittal. Sige. Tapos, pwede ka dun sa, joke. Palang unti. So, yeah. Ito problem yung fascia here. Sige. Tapos, you can try to find iliolumbar ligament. So, ilium tapos lumbar. At, sige, try to find yung transverse process ni L4. Or L4 facet. Tapos move ka pa pataas. Ito, yan. So, kung ito yung transverse process mo, medyo oblique. Kasi pag ganun siya, ilium plus lumbar. Kasi you will see a line. Sige, medyo akyat ka onto.
Balik ka na to.
Actually, parang medyo good siya. Pero, I guess, yeah. Sige, akyat ka pa. You want
Ayan,
hair ito. Tapos, medyo oblique. Tapos, like yun. Kasi, so iliolumbar. Pero pwede mo rin, yeah. So, baka yun. This one, iliolumbar ligament. Mga L4, L5 transverse process. Ilium.
So for all these people, kung saan yung structure din yung pain, like when I expect mo sa referred pain na.
Yeah, well, all you have to do is muna. Tapos, so kunyari, for severe gluteal nerve, if the pain is there, kasi may diagnostic injection, like for example, like 0.2, 0.3 ml of lidocaine with severe gluteal nerve, tapos nawala yung pain, then that probably is the problem. And, so if you want, you can try, if kunyari nasa severe gluteal nerve, nasa may iliac crest, so you can try to agonize it with 5 water or a few ml of lidocaine for diagnostic block. If mawala yung pain, then that's probably the cause. Ano yung nakita doon? Potential. Although nag-potential na tayo. So, this is your ilium, superior gluteal artery, tapos superior gluteal nerve, this is it. Yun. Max, gluteus maximus minimus. Tapos gluteus sciatic foramen. This is your piriformis. Okay. Tapos, this is your ischial spine. So, ischial spine, sacrospinous, sacropudinous, pudendal artery, pudendal
In between po?
Pudendal nerve usually medial. Medial to the pudendal artery. Yun. Tapos, this is your ischium, obturator internus. Tapos, sciatic nerve. This is your sciatic nerve. So, quadratus fem. Tapos, gluteus max. Tapos, usually at this level, pwedeng baka inferior gluteal nerve siguro yung nasa taas. Tapos, conjoint tendon. Balik ka sa ilium. So, dito artery. Ito po. Improved image. So, arteries, terminal artery. Nakang nerve yung nandun. Sige. Tapos, greater sciatic foramen.
Time check last 40 minutes. Time check last 40 minutes.
Yep. Ito, mukhang piriformis to. Is, ito yung sciatic niya. Tapos, ito yung sciatic niya. Pero pupunta na siya doon. Okay. Sige, tapos, ischial spine. Tapos, ito yung sacrospinous, pudendal artery, pudendal nerve. Yan. Pudendal artery, pudendal nerve, ischial spine, sacrospinous, sacrotuberous ligament. Yeah. Para medyo mag-manure lang siya. Yeah. Tapos, this Q, obturator internus, is baba ka, nakikita mo sciatic, conjoint. Tapos, meron kang somewhere, here, crucial nerve. Pakita siya, ito yung taas mo. Ito po, sa ischial spine. Ischial spine, nakikita mo si sacrospinous. Sacrospinous yan, yung line niya. Pagkatugtong niya, itong ischial spine. Tapos ito, this is the pudendal artery, which is pulsating. Katabi niya, pudendal nerve, which is sacrotuberous. Sacrotuberous ligament. So this is your interligamentous plate. Interligamentous plate, siya yung naiipit. Dito, naiipit si pudendal nerve. Yung next na naiipit si pudendal nerve, kaunti. Yan. This is your obturator internus. Dito, the obturator internus has a fascia. That's your alveolus canal here. So this is your obturator internus. Meron siyang fascia here. Tapos yun yung alveolus canal. Dito naiipit din si pudendal nerve. In between the fascia, yung dalawang fascia niya here, at doon naiipit si pudendal nerve.
Sige, go. Ay, tapos na.
Still, still.
So I put this in the middle, spin on it. There. I'm at the L4, L5. No? So L4, L3. There. So this is facet joint, transverse process. This is lamina. Go up again, L2. There. Facet, transverse process, lamina here. L1. There. So, if I want to be really exact, no, and confirm my levels, I switch sagittal transverse. Kasi yun nga, mahirap makita sa ultrasound if you have variability or vertebral enumeration, variable lumbar enumeration. What else?
It's pag may listicles.
Listicles.
Would you do PRP on the ligament to stabilize and additional stability on the ligament and which ligament?
Okay. Ako, I usually do a functional approach when I treat the spine. So, for example, I treat the facet joints and I also treat the supraspinous and interspinous ligament. So, yan, this is the facet, diba? The facet. So, if you go up, actually, ang approach ko for interspinous ligament is here, eh. On top, eh. Ganun. On top.
In between the spines?
Yeah, in between, there.
That's out of plane.
Pwedeng out of plane and also in plane. But in plane is very superficial. Parang few ano ka lang. Parang,
Sobrang babaw lang.
Yeah, sobrang babaw lang. Centimeters, parang about cm ka lang. So I inject that.
You'd inject supraspine,
Yun.
interspinous,
Yeah.
no?
That's ano na kasi, that's your spinous processes
Correct.
na eh. So I inject here, inject there, that's your supraspinous. You can also go out of plane for the interspinous ligament, or once I touch here, I retract, go down, retract, touch this, retract, then go here.
One puncture lang.
One puncture. That depends sa needle. So, but sometimes, marami kasi, if I do a functional approach, I treat the facet joints, I treat the ligaments, I also treat the iliolumbar. Mildly sedated yung patient ko.
Okay.
Kasi maraming tusok.
Maraming tusok.
So it's very uncomfortable for the patient. So I have my anesthesiologist mildly sedated, and then I do the ligaments. Also, when you do the sacroiliac joint, you can also treat the ligaments.
So IV sedation.
Yeah, IV sedation lang. So you can treat this fibrous this thick fibrous ligament here. You can also, yeah, this the joint, and you can also treat the long posterior SI joint. SI ligament. Ito. Ito siya. Basta. This one. So, sacrotuberous, from there, you trace it from the ischial tube, and then dulong. Yan. Kasi ang continuation niyan hamstring eh. Okay. So you palpate the ischial tube. Here, it's here. Okay. There. And then there. On top is your sacrotuberous. Ito siya. So I treat the ligaments kapag meron kang SI joint problem to help them stabilize. So yun. Ako, I find it difficult to trace the sacrotuberous elsewhere. So I trace muna the ischial tube sa baba. And then dulong axis. And then around this area. So I also see that. That's about it.
Transforaminal na injection, hindi kasali sa...
Hindi. It's hard to see transforaminal via ultrasound.
Pag cervical tayo.
But it's usually called more formal term is selective nerve root. Kasi once you enter the foramen, it will create a bony dropout eh. Kasi bone na siya, so hindi mo nakita eh. Yeah. So,
Pero here,
So yan na siya. Bye, Doc. Diba, gusto natin makita like this.
Dito ka papasok. Di ba kita mo mawawala yung needle dito eh.
Yes.
Pag wala ng needle, dapat dapat makita mo siya just before it
Pero
disappears.
dito ako papasok,
Yep.
Jem.
Yeah. Yeah.
It's just before it
Yeah.
disappears.
Dito matigas to eh, sa
Ito ba may right and
spinos.
left siya? Ganyan. May ganyan and may ganon. Or
That's
isa
the
lang
same.
to?
That's the same one. But if you go too much left or too much right, you're in another area.
Okay. So again.
Dito ka na eh, papasok eh.
Okay.
Pero mas maganda talaga kung
Linear.
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 Oo. Kasi kita-kita talaga.
Kasi ito yung parang ano kasi yung tapos dito siya gitna, ito yung ligament at yung ligament spinal, sacrococcygal ligament again.
Gitna mo always ka pa. Always na.
Time check, last 20 minutes.
Mag may line kayo. Sorry.
Yes po. Ayan. Tapos ito, dito tayo.
Yes. So ito yung bone na hanggang dyan lang talaga dapat yung yung needle. Kasi dito you cannot see.
Okay.
That's not safe. If you cannot see the needle, dapat dito needle papasok. Dito yung ligament, pop. Dito. Dito.
So dito
Yes.
pwede ako mag-enter.
Yes. Kung makita mo kahit may ganito, pwede pa yan.
Yes.
Pwede pa yan.
Pero better pa pag ganito. So as in, ang entry mo is here.
Yes.
Dito sa ilalim,
Ako dito.
sa taas.
Dito. Pero mababaw lang yan, less than 1 cm yan.
Okay. So nakaslant yung needle in
Kung
plane.
medyo alanganin ka nga, kahit tanggalin ulitin mo lang, basta
In plane, basta nandyan. Tapos
in
makikita mo, pag nagganito ka,
Nasa
merong
gitna.
nagpo-flow.
Yes.
Nagpo-flow sa ang gitna kung makikita.
Dito.
Dito. Okay. Para tama.
Always in the center yung
Yeah.
everything.
Sige. Again. And then, And then, lipat na ako ng, sige, dito muna, SI joint. Pwede din to SI or hindi.
Pwede,
Dapat
pwede,
yung-
pwede. Pwede naman. SI joint na to.
SI joint na. Because, ito yung
Can you go more medially?
medial.
Baliktad yung probe mo. Yeah.
Kasi ang sacrum ko
Ilium,
is
ilium
ito.
to, sacrum to.
Ilium to.
Sacrum, sacroiliac joint na
So,
yan.
sacroiliac joint.
So
Pero
now,
saan
which
yung-
part of the sacroiliac joint? This is the more superior part. So you go a little bit lower. Slowly lang ito. Sacroiliac joint. Sige pa. Higit na motion yung joint. Yan, higit na. Slowly pa.
So, ito yung foramen. Ito yung
Sometimes di makita yung foramen. Depende
Pero kasi
talaga.
nakaano tayo, linear. So, pwede ako
Pwede naman
curvy.
small movements lang daw. Makita mo yung foramen.
Yan.
Dito. Foramen dito.
Yan. Tapos ito yung joint. SI joint na yan. Okay. Kasi ito yung
It's
sacrum.
very, very small talaga.
Yes.
Minsan lalabas na yung foramen.
So, tapos, dito mag-inject ka ng ilang konti lang yan. For the pain lang yan. Kasi di ba
Basta
Mrs.
SI ko
na
talaga is,
masakit?
SI ko talaga is diagnostic always. Lidocaine lang outside.
In the first one.
Tapos, ilang
If proof sila PRP or
next mo.
if hindi na masakit, PRP na dyan.
so confirm na natin. Confirm din.
SI joint.
More than 50%
That's
pain.
sitting on that.
Din.
So, ito dyan. Pwede dyan, di ba, Jem?
Ipapapil ko siya for 30 minutes.
Yan. Yan, okay. Okay, good.
30 minutes. Kapag effective, lakad-lakad. Gusto mo yung mga provocative test na wala. Okay, pwede na tayo gumastos. Mas confident ka na sila kasi sila na-confirm.
Sila na-confirm.
Kasi sa mga cervical, yung mga ginagawa na akong cervical kasi
Pwede ako mag-get.
takot ako kasi
Yan.
tapos
Tapos, kailan mo?
80 Pwede rin sinasabi ni Doc. Sabi kasing lateral hip pain, pwede siyang lumbar, pwede siyang yung tingnan mo, kapag mawawala siya yung provocative test mo, plus lidocaine, sabi kapag mayaman, B5, sabay na siya treatment. Sabay na yung pakasingil ka little bit higher. Saan ka na?
Ulitin ko yung SI joint
Yun,
ha.
nakita mo yun.
Ayan na.
Yes.
So, ito na.
Yes, yes.
Lower. Ito yung superior
Yes.
portion of the SI joint. Kasi ito yung sacrum, di
Yes.
ba? Tapos, ito yung SI joint. Ito na.
Ito,
Yan,
foramen.
foramen. Tapos, ito na yung
Ganda.
SI.
Perfect, perfect.
Ano?
Yun lang, ang angga lang.
Ayun yung foramen.
Oo. So, yan.
Yes.
Yun yung
Foramen on the
foramen.
side,
Kita, oh.
the medial.
Ito. Tapos, ito yung SI
Target,
joint.
target, foramen. Do not hit this.
Oo.
The target.
Yeah. Okay. Sige, next
Perfect.
na. Perfect. Okay.
Pag-uwi, hanap ka na ng matuto.
Oo nga.
Check natin kung SI ba naman.
Tapos ito, yung
Alam mo
Gunyal.
na yan.
Alam na.
Nire-review na ni Pat.
Pudental, di ka pa
Ayun nga, hindi pa ako
Sciatic
nagpudental.
Chris.
So
Then,
ito yung,
the sciatic
at
view.
saka yung, ano, hindi,
The
ay,
fleur
so,
de lis view.
ito yung fleur de lis view kasi ito yung quadratus femoris ko, di ba? Tama?
Yes.
Sciatic nerve na, yun
Saan?
ang sciatic.
Ito?
Ito.
Ang gulo. Kanina eh. Hindi siya na ano eh. Inano
Pero
ko
ito
si Doc
yung-
sa semistendinosus ko na trick eh.
Pero ito yung, ano yung
Ano to? Ano to?
troch.
Can you, yeah,
Pero
trochanter.
ito yung ischio. Tapos quadratus femoris. Kasi ano yung sabi mo yung obturator internus.
Ah, mataas pa yun.
Sige.
Sige, if you wanna go slowly, sige, slowly lang.
So,
Super slow.
slowly lang. Sciatic nerve. Teka, sige para habang nandito ako, fleur de lis view muna.
Who first?
Sige muna, ilong axis mo muna to. Ilong axis mo muna.
Ayan.
Slowly go up, slowly go superior. Slowly, slowly. Sige pa, sige pa. Sige pa. Labas mo ulit yung nerve dito.
Ayan.
Sige pa, malapit na tayo.
Wala na akong gel.
Obturator internus to.
Ah,
Yung
okay.
puti sa gitna.
Okay, obturator internus yan. Pero to, troch pa rin to. Troch pa rin to.
Yeah. Saan ba yung gel? Sa'yo ba?
Ito. Thank you, Alex. Ulitin natin. So, ito yung sciatic nerve. Yun.
Kung ma-trace mo yung sciatic all the way superiorly to the piriformis, ganda niya. Sige.
Yan.
Okay, ipakita mo ang sciatic. Angulate mo pa. Sige pa. Kita mo to.
Yan.
Dapat papailalim siya, no?
Oh, yeah.
Ito,
Baba,
going
kita,
under,
this is
pababa
going
siya,
up,
diba?
going down,
It's
no?
going posterior.
Piriformis,
Oh.
sciatic,
Wow.
Pag yung mga
okay,
variants,
superior gemellus,
kita ka ba na
territory.
Ano, superior gemellus. Ano to?
Territory. Basta may puti dito sila.
Superior gemellus yan. Ito piriformis. Para ma-prove ko na piriformis, ito yon. Yung ganyan. Ay,
Diba?
oh. Ano to? Ito
Piriformis.
yung piriformis.
Oh.
Oh. Tapos ito yung sciatic nerve natin. Long
So actually, you can actually do sciatic nerve parang tawag dito,
Galing.
gliding. Makita mo kung maganda ba yung glide.
Ayun no, ito yung sciatic nerve. As it enters into
Piriformis.
the
Piriformis. Kita mo?
Give me high five naman dyan. High five.
How do you do that, yung gliding?
Actually, it's ano siya, flexion and adduction. Ay, extension and adduction.
Extension.
Extension. Okay, extend.
And adduct.
Adduct. Ganon.
Yeah. That's one view. That's one way. Pero yung iba is mahirap ha. Di na natin
Ayun.
magawa.
O,
Kailangan
game.
sila
Adapt.
ganyan siya, flexion extension.
Ayun no. Oh.
Kita mo mag-glide na
Ayos.
konti.
Okay, pudendal na ako. Ba?
Yan, pudendal na yan. Pudendal na to.
Nandun na yun.
Ay, shucks.
Mabilis, masyadong mabilis.
Na-amaze din ako sa sarili ko.
Pero i-heel to mo siya.
Pero ito yung-
Gusto mo siyang i-angulate na ganyan.
Ayan na.
And then go medially. Yan. And then heel to. Ganyan.
Straighten.
Ganyan ang gusto mo view.
Tapos nasa yung pudendal nerve ko.
May position na dito eh. So,
Ito. Tapos yung sacrotuberous sa
Tuberous?
taas. Sacrospinous.
then ischial spine.
Ischial spine. Ay, shucks.
Galing. Kung nakita mo yung ischial spine dyan sa anatomy, di ba?
Saan?
Yun siya yung ito. Ito siya.
Teka. Wait lang Diyan ka lang. Para lumagis siya.
Cervical safe din, sir. EMG po.
EMG, oo, pwede nga din.
Lalo pag ladik na.
Ito na yung facet. Ay,
Facet. Hindi rin, lamina.
lamina. Lateral pa.
Yan, facet yan. Ayun, dalawang hub.
Ay, siya.
Tapos yun. Try natin to tomorrow. Pero out of plane ka dapat dito eh.
Out of plane ginagawa.
Diba? Dito, Doc.
Hindi, kaya raw in plane, pero talagang nakaganon.
Out of plane na yun, okay.
Very stiff na.
Out of plane na ate. Out of plane na yun.
Pero sobrang
Diba dito? Bawal pa yun.
should be here. Dito. Dito.
Kay dito kaya, kay sa'yo, okay na yan. Paano sagad? At,
but you have to visualize the foramen before doing an injection. Don't do an injection like this. Make sure that you see the foramen while you're doing the injection. Okay? Make sure you have this view for safety purposes. Don't inject this way. That's okay because you see the foramen there. That's still part of the joint.
Medial to lateral.
Yeah. I mean, you're pretty much sure that that's the ligament and that's a joint, but for safety, it might go through the foramen. Yeah. Accidentally. So I think you're at L5 already.
Yeah.
That's the interspinous ligament already because you see the intrathecal. Yeah.
To reduce the depth.
Can increase the
Increase the depth.
increase there. That's venous process.
So this is
Now,
L5.
I think that's L4. You might be at L4. Remember, the L4 level is a portion of your
This is in this is the posterior complex.
Posterior. This is the posterior, right? On posterior complex, right here,
Yes,
right?
Dora.
This is posterior complex.
Yeah,
This
posterior
one. Because behind it, anterior to that's the anterior complex over here. Yes.
So you know you're in the ligament because the sound waves go through.
Yeah, you can see the anterior complex.
Yes.
Otherwise, you're at the bone.
At the bone. So that's how I usually count the level. So interspinous, spinous process. Go up, interspinous, spinous process.
So right after the sacral corridor, that's your start of the L5.
Yes, doctor. I usually look at the median crest of the sacrum. Then there should be a space there, the L5S1 intrathecal space. And once I see the sharp spinous process, I know I'm at L5.
That's L5.
Yeah, I'm at L5.
So you go for that as the
Yes.
first spinous process. That's L5.
And one clue that would tell you that that's the L5 is when you go lateral, you still see the L5S1 facet joint and part of it.
This is the
At the spinous process, you don't see
So
the
as you go
anterior
more,
complex.
as you go more cranial, the junction between your facet joint and the transverse process becomes a lot more
Right
shallow.
here. Right here.
So right there, it becomes more shallower. It doesn't look like the classic one that we're used to. So tomorrow we'll try to target the easier ones. the L3, L4, L4 medial branch, L3 medial branch. So
The spinous, you see that?
that's a good, that's a good view right there.
Yeah, you see the anterior complex right there?
There, this one, this one's a good
This
view.
one. Yeah.
That's a good. Sean, sige na. Go, Sean. Sean, palit kayo after. Rest ka muna, baka magka-back pain ka talaga. Saka mag-twist ka talaga.
Oh, so ano, free, no PF, all meds, care of,
Anesthesia,
Pero ako pag spine talaga kung gym.
Really, yes.
Maybe personal preference.
Yes.
X-ray ako, MR.
MR.
Sure, sometimes may mass.
Especially if the pain has been for the
Yeah,
longest
for
and
an old patient. Tapos the anatomy looks a lot different talaga. SI joint will not look like the SI joint. It looks different. That's a good facet joint. There. That's a good facet joint. There. It's a very good facet. Middle po.
Then L, how would I know?
Accounting tayo. Sige. Accounting. So, you can start sacral cornu. Sacral cornu, diba? Go up. Sacral cornu, you're pretty much sure you're at S5. Okay? So go up, up, up. You're still at sacral because you know that it's small. Diba? Small yung ano. That's a median crest of your sacral. Then it will disappear. You're most likely at the L5, S1 interstitial space. Okay? Then if you go up, there, suddenly, lalaki siya. That's your L5. How do you know that that's L5? That's your L5 S1 facet joint. That's a sacral ala. That's where your L5 dorsal rama is. Okay? So this is L5. Then this is the interligamentous area of L5, L4. Then this is L4 already. It's L4. That's an L4 facet. Yan yung ano. L4, L5 facet joint. That's your transverse process. That's the classic looking one. So that's the easiest target. Okay? L5, S1 yung mahirap, pero yun yung pangating isa. Okay, so you're at L4, right? Intraligamentous L4, L5. Interspinous pala. Interspinous ligament. So L4. L3, L4. Interspinous ligament. L3. You're at L3. L3 is still classic looking. Malalim pa rin siya. Okay? There. But once you go up, L2, you see it looks different already. Very shallow na. There. But that's still the area of your medial branch. So always remember there's a space between your sacrum and your L5. There's an empty space there. That's an intrathecal space. So yun yung mas madaling ano. And the transition. So from a small spinous process to something suddenly sharp, that's L5. You can also do it longitudinally, but it's very hard. It's hard to look at the spinous process.
Or the bus go up.
I have a problem.
You can also start from top. Look at the rib. D12. Then go down. Yeah. Look for D12. The 12th rib pala. Look for the 12th rib. Follow the 12th rib. You're at the thoracic spine. Go down.
Para mas mabilis.
Oh, tsaka you have the gluteal cleft.
Yeah,
I mean,
it's
it's
easy
there.
It also looks different when we remove the pillow. Yeah, if a flattened shot, it will look different.
Sorry, Doc. Tama.
Cornu? Cornu, you want to see the frog's eye. So it's like the frog's eye, frog's mouth. Okay? Sacrum. Sacrum. So then L5. That's L5. That's L5. That's L5. It's the first sharp spinous process. This is L4, L5 interspinous ligament. L4. That's L4. That's L3, L4, then just count upwards. SI joint, okay. SI joint, PSIS. So you can palpate your PSIS somewhere here. Put their probe there. So na yun. Ayan, okay. PSIS, masyado mababa. There, that's your PSIS. PSIS. That's your ilium. Go medial. Then start going there. SI. Kasi PSIS, if you go medial to the PSIS, you already palpate with your SI. Okay? So easier to look for a bony anatomical landmark. Then put your probe there and start looking. PSIS here. That one, it's really pointy. And PSIS. Okay, PSIS, you know that when you're at the PSIS, go lateral, that's your ilium. You have your gluteal muscles. Medial to the PSIS, you have your sacrum. Okay? Distal to the PSIS, SI joint. There. So that's your landmark. You always want to start there. It's 1 to 1. That's it. So, SI joint. But with the SI, you have to see the sacral foramen. Yeah? Always visualize the foramen.
Which is more
More medial. You don't want to inject that. Okay?
Time's up. And that concludes our first day, Muscle 2. Please give ourselves a round of applause. So tomorrow, we're going to be focusing on cadaver injection, so on our injection techniques. The call time is at 8 a.m. at the second floor histology lab, 8 a.m. for registration, where you will also get your kits for the cadaver injection. Okay? Thank you so much. So these are again the QR codes for the primer and pre-test, no? So primer for you to access the needed structures for tomorrow, which are similar to what we scanned today. There are also some guides in that primer. And then for the pre-test, so that we could give the certificates. Please get some rest tonight so that you are, there are still snacks at the registration booth. Thank you very much.